And on behalf of the Internal Medicine Section and the NMA, I am pleased to have you here for the second day of our two-day CDC conference on the essential factors for promoting the increase of Black community COVID-19 vaccine. Today, we will have presentations from pulmonology, rheumatology, oncology, allergy and immunology, and infectious diseases. I'm so appreciative of those of you who are in our virtual audience and have chosen to spend time with us this morning and afternoon. And I'd like to once again thank our speakers for sharing their expertise so we can continue to provide excellent care for our patients in our community. And with that, I'd like to start with our pulmonary section.
Thank you for joining us at the pulmonary subsection program. First, we'd like to hear a word from our chair, Dr. Aaron Baugh.
Thank you.
Dr. Bo, you're muted. You're muted.
I'm sorry. Thank you so much. Arguably, no subspecialty was more impacted or highlighted by the COVID-19 pandemic than pulmonary and critical care medicine. It inspired a reflective mood among my peers that we wanted to mirror in composing this year's program. Thus, while we put together a broad look at vaccination, including its need, adverse effect profile, and reasons for differing vaccination rates, we wanted to connect this narrative to the social determinants of health, which we view as a fundamental driver of dynamics. To do so, we've assembled cutting-edge research from investigators that span from early career to late and more seasoned academics. I do hope that you're edified by our program.
Each speaker will be allotted 15 minutes. I will signal the transition to the next speaker. Joining us today is Dr. Ernesto Casillas, an incoming interventional pulmonology fellow and graduate of one of the country's top 5 pulmonary program. Dr. Cheryl Weisse, 2020 winner of the Young Pharmacist Award from the National Pharmacy Association. Dr. Daniel Gonzalez, a chief resident in rheumatology at the University of Texas Medical Branch and a 2021 gold medalist at the American College of Rheumatology College Bowl. And Dr. Sharon Cobb, a multiple NIH-funded director of Charles R. Drew University's BSN to RN program. Now we'll hear from Dr. Cheryl Weisse. There's no volume.
So a few objectives for this presentation include describing the concept of pharmacy deserts, recalling the factors that contribute to the formation of pharmacy deserts, and discussing public health implications of limited access to pharmacies and tying that in with the COVID-19 pandemic. So what are pharmacy deserts? What does this even mean? What is the concept? So to set the stage, some of you are already familiar with food deserts, and they're areas or census tracts where residents have limited access to healthy and affordable food options. They're defined by measuring the distance from the nearest healthy food retailer, using supermarkets or large grocery stores. And this is according to the USDA and the CDC. So pharmacy deserts were adapted from this definition. And the most commonly known definition is communities with no pharmacy within a 1 mile radius, or communities with limited vehicle access and no pharmacy within a half a mile radius. So in this presentation, I may use the term pharmacy deserts and areas with limited geographical access to pharmacies interchangeably. And so while the pharmacy desert is not a new concept, there's been research dating back to 2011 Our study was the first to identify and characterize pharmacy deserts in California, and more specifically in Los Angeles County. So really quickly, just want to talk about the social determinants of health and why it was important to this study. So we know that it includes the social community context, economic stability, education, access and quality, neighborhood and built environment, and then healthcare access and quality. So they're material or immaterial resources that can affect the quality of life and health outcomes. And depending on which side of the tracks you fall on, they can be either damaging for one's life or enhancing one's life regarding either individual or population health. So that's why it was important for us to characterize the types of deserts by social determinants of health, because they can be damaging or enhancing to everyone's life. So we aim to identify and describe all pharmacy deserts in Los Angeles based on that basic definition of being 1 mile or more away from a pharmacy desert, and then characterize those deserts based on the different indicators of the social determinants of health. So what did we define as social determinants of health based on that Healthy People 2020 framework? In our study, for economic stability, we used the federal poverty level and those that were renting and didn't own their own home. For education, we use whether they had a high school diploma in English as a second language, and thinking about English and health literacy and numeracy. Social and community context, we looked at the population density, Hispanic ethnicity, non-Hispanic, Black race and ethnicity, age, childhood and elderly. And then in regards to health and healthcare quality, we looked at those areas that were health professional shortage areas and looked at their health insurance status. Lastly, for the built environment, we looked at whether they had a vehicle or not, and crimes against people and property. So it was population level data that we used. We got them from the American Community Survey, HRSA, in regards to health professional shortage area, looked at the census for age and race and ethnicity, and then another crime bureau for crimes against people and property. We got all the community pharmacies, of course, from the California Department of Consumer Affairs, the pharmacies at that time in 2020. And we calculated all the street networks to do that first basic definition, being defined as 1 mile or more through the road network to the nearest pharmacy. And then we looked at the social determinants of health clustered within all of the different areas that were shown to be deserts. So the areas that were shown to be deserts are depicted here in this image. So 571 census tracts or communities were pharmacy deserts, and 1,752 were not. Los Angeles has 8 different service planning areas, which lets the Department of Public Health plan and implement targeted health, public health and clinical programs that are based on the needs of each area. So this area just shows the desert and non-desert types within the 8 districts or service planning areas, with red being the desert areas and blue being the non-desert areas. And for example, we have South San Fernando, which is the biggest geographical area, and it had the most pharmacy deserts. But on the other hand, you have the West, which is known for its affluence, that had the least number of pharmacy deserts and the second smallest population. But this is not surprising. It speaks to how exclusive those communities can be. So furthermore, when we clustered the social determinants of health indicators, we found that there were 2 types of deserts within our desert areas. So type 1 and type 2. So this table just depicts the measure of the social determinants of health population indicators. So recall that I said that we're all affected by social determinants of health, whether they enhance our lives or damage our lives, depending on which side of the fence we fall on. So in our study, we found that residents that live in type 1 deserts had twice as much of a particular social determinants of health indicator, which can negatively impact their limited access to pharmacies via the street network when you compare them to those that lived in a type 2 desert. So those living in type 1 deserts lived in areas that were potentially compounding the negative effects of having a shortage of pharmacy services already because of not being close to one greater than 1 mile or more away from it. They had a denser population that were more non-Hispanic, Black and Hispanic residents, more that spoke English as a second language, more that were renting and not owning, less vehicle ownership, more living in areas with higher crimes against property and people, more that lived under the federal poverty level, and less health professional shortages less health professionals to serve the area and less health insurance coverage. So what we see is a 2-to-1 ratio, whereas those in type 2 deserts had twice as many of these indicators, what have you. So to put these findings into context, we can take a closer look at what I call the tale of two service planning areas. So looking at service planning area 5 and service planning area 6. So in regards to the notable communities in service planning area 5, we have Beverly Hills, Malibu, Venice, and Santa Monica. Whereas in SPA 6, you have Compton, Watts, Athens, and Crenshaw. When we think about the pharmacy desert types that we see in both of these service planning areas, all of the deserts in SPA 5 are type 2 deserts, whereas 93% of the deserts in SPA 6 are type 1. And you can define SPA 6 as an urban area, whereas SPA 5 has more urban and suburban areas. So when we think about the pharmacies that are there to serve the residents in the community, we looked at it based on pharmacies per 1,000 residents. So while there are 1.22 pharmacies per 1,000 residents in SPA 5, there are only 0.26 pharmacies, or a little under a quarter of pharmacies per 1,000 residents in SPA 6. So when we think of this in terms of magnitude, there are almost 5 times as many pharmacies per 1,000 residents in SPA 5 than there are in SPA 6. But on the other hand, we think about residents per square mile, you have less residents per square mile in SPA 5 with about 3,300 per square mile, where there are 14,000 residents per square mile in SPA 6. So the smaller area, but a lot more people and less pharmacies to serve them. So, and finally, when we think about race and ethnicity in regards to social identity groups, SPA 5 is majority non-Hispanic white, while SPA 6 is majority non-Hispanic Black and Hispanic. So just thinking about what this might mean for a patient and living in both areas, you have someone living in a SPA 5 pharmacy desert type 2. They lack access to communities to their pharmacies based on travel distance, but they'll have a car. They have more suburban areas where when we think about business practices, pharmacies might be spread out geospatially by design. They have more health insurance coverage and then more health care professionals to pick from in the area because it's not that much of a shortage area. So pharmacy access might be less burdensome in these areas. Whereas living in SPA 6, where most of the communities are type 1 deserts, you're lacking access to community pharmacies based on travel distance. But what if you don't have a car? What if you live in an area that has higher crimes against property and people? Oftentimes that can lead to divestment within the community because of crime levels. Lack of health insurance coverage, maybe not speaking English as your first language, having less health professionals to go to in the area. So all of these aspects can contribute to the distance that's physically being traveled and impose barriers to getting to a pharmacy and pharmacy services, making the access a little bit more difficult. So I've just placed here on this slide an image of all of the different service planning areas and the desert types that exist in each, and just looking at, again, how many type 1 versus type 2 deserts there are. So we know from a historical perspective, we need to consider that prior to the civil rights movement, discriminatory practices such as redlining maintain non-Hispanic Blacks and Hispanics in impoverished, densely populated neighborhoods, while we had non-Hispanic whites who've out-migrated to suburban areas. So while redlining no longer exists, there are race riots, economic forces, which have increased housing costs, immigration, that all contribute to the persistence of predominantly minority communities in Los Angeles County. More or so thinking about SPA 6 and SPA 7, which are mostly Black and Latinos, and then SPA 5 and SPA 2, which are predominantly non-Hispanic white. So speaking to the point regarding the persistence of racial and socioeconomic segregation in LA, it's no wonder that we saw disparities in vaccination rates back in 2020 in LA County when the COVID vaccine first came out. So this is just showing the vaccination of the percent of 65 years and older that were vaccinated. And this was data at the time when only that age group was in that first phase to get vaccinated. And what we see is just the color shading. The darker greens means that more have been vaccinated. So what we see here is that the lighter greens being in the more of the South Central region where we have SPA 6, where there are more Black and Latino residents, and darker colors being on the west side. where we talked about those more affluent communities. And that's just a closer look at it. So seeing the lighter green and the darker green shading in regards to accessing the vaccine. So these are some key take home points of the study itself, just looking at different causes to why pharmacy deserts exist. And there have been constant community and healthcare ways of thinking to have equitable, innovative, community-based interventions that can increase access to medication, pharmacy services such as immunization, and pharmacists, some of them being, we had different Lyft and Uber getting patients to different pharmacies to get their vaccine and what have you. So it's definitely a problem or an issue that legislation and different researchers have called attention to. That being said, this is one study that just showed that there were fewer pharmacies in Black and Hispanic and Latino neighborhoods. Now this is looking across the United States. And 1/3 of the 10,000 neighborhoods that they found to be deserts, which are in the 30 most populous cities, they saw a difference in the percentage of white and racially diverse neighborhoods that were pharmacy deserts versus Black and Latino neighborhoods. And the disparities were most pronounced in Chicago, Dallas, Boston, Milwaukee, Philadelphia, Albuquerque, New Mexico, Los Angeles, Denver. So definitely this is an issue that's on a greater level across the nation. So why is it important in a pharmacy desert to think about that and think about the different social identity status? There's an intersection of the pharmacy desert with other health and healthcare disparities. We know that minority communities often fare worse regarding their chronic disease outcomes, documented low uptake of preventative services such as vaccines, high healthcare utilization in regards to acute and emergency room services. So not having a pharmacy or the pharmacy staff makes it more likely for such medication-related challenges such as non-adherence, cost-related or primary non-adherence to occur because there are those competing needs of what's going on in the community and those social determinants of health that are affecting those patients' lives that live in these minority communities and have health and healthcare disparities. Other contributing factors to the formation of pharmacy deserts include competition between pharmacies, and just other financial and market pressures. There are pharmacy closures, pharmacy mergers that cause pharmacy closures, non-community pharmacy dispensing. So a lot of the boutique experiences, when you look on TV, you see commercials for Hims, for Hers, online pharmacies popping up. But oftentimes you have to think about those who have low socioeconomic status or live in minority communities. Can they access things like those if they don't have broadband service or stable broadband service? Financial pressures could be different types of fees for different pharmacies and different spread pricing, vertical integration is steering, but also decreased reimbursement. Medicaid is one of the largest public health insurance providers in the United States. And it has, over time, the reimbursement rates for Medicaid prescriptions has also decreased. So retail and independent pharmacies that are located in these urban and rural areas that serve larger numbers of low-income racial ethnic minority populations covered through Medicaid are more likely to close due to lowered reimbursement rates, and they can't seem to recuperate that profit. So pharmacies close. So when they close, the clinical services that they have also go with them, and it makes it becomes a vacuum. So it's leads to pharmacy closures, decreasing hours, and it just makes it worse off for those that live in such communities. So these are some factors that are also contributing to it in regards to the inequitable distribution of the social determinants of health. But just thinking about pharmacy itself and thinking about public health, just want to discuss the bigger topics, especially when we think about the services. Pharmacy and public health have shared goals to promote the health and individuals of communities. So these pharmacy interventions can also be public health interventions. And so in regards to primary prevention, some of those things that go on in the pharmacy could be like A1C screening, blood pressure screening, and immunization. So again, thinking about COVID and thinking about the best way to protect yourself as a primary prevention to get vaccinated. Secondary prevention interventions that may go on include just being able to do diabetes disease management, hypertension disease management, community fairs that help residents who have chronic illnesses, help them get them under control. So when the pharmacy disappears, these secondary prevention strategies also disappear with them. And so it's interesting to note that all 50 states have some type of provision for pharmacies to be able to provide these services in their community, in their Pharmacy Practice Act. So once again, as pharmacies close in rural and urban areas, all of these different services go with them. So, and lastly, just thinking about pharmacies again, especially for the COVID-19 pandemic, the pharmacies have been chosen because pharmacists are highly trusted and trained healthcare providers who have direct access and knowledge of their patient populations. And we are trained and for the most part, located all over the United States. There's a statistic out there that everybody is at least within 5 miles radius of a pharmacy. So just thinking about, once again, earlier on in the pandemic, some of this wasn't accessible because of these deserts that were out there, and then considering all of the sheltering in place that was going on with COVID. So I just want to thank you for your time.
Thank you, Dr. Weiss.
Thank you, Dr. Weisse, for giving us that talk remotely. Now we have Dr. Ernesto Casillas to discuss the color of the pandemic.
Hi, good morning, everybody. I'll share my screen. Actually, can everybody see that?
It's in presentation mode. Okay, now that works. Thank you.
Okay, sounds good. Good morning, everybody. My name is Ernesto. Thank you guys for the invitation. It's an honor to present this work today. Talk is entitled The Color of the Pandemic, the Association Between Historical Residential Redlining and COVID-19 Outcomes in California. I have no disclosures. So as it turns out, we've known for a long time that where you live matters. And actually, one of the founders of socioepidemiology here in the United States, W.E.B. Du Bois, first started talking about this back a long time ago, back in the 1800s. And you could see here two of his really important works, The Health and Physique of the Negro American, and also the Philadelphia Negro Social Study, started to really, it was one of the first works that started to show this idea that where you live matters. And if you've read those books, you've known that they're really incredible works. Well, in our lab out here, we also believe that where you live matters. And here what I'm showing is a map created actually by the federal government, the Homeowners Loan Corporation. And this was a corporation that was sanctioned by the federal government and tasked during the Great Depression to refinance homes that were in default, or their or homes that were at risk of going into foreclosure. And the agents of the Homeowners Loan Corporation were tasked with going around major cities in America and surveying sites and appraising land value. And we now know that the way that they did these surveys was actually highly biased and actually, in fact, they're actually racist. The homeowners loan agents would literally go around neighborhoods and circle in red neighborhoods that they deem too high risk to refinance loans, or as you can see here, I put an example of one of the reports that they had, and this is a map of San Francisco. This is actually the original redlining map of San Francisco, and you can see the blocks in red were areas that were surveyed by these agents, and you could see the report here on the right. And one of the things that they mentioned here, I underlined in red. And again, this is a federally sanctioned organization that's doing this, but if you could see, the underlined text says, there's a decided concentration of undesirable racial elements. More than half of the Negro population of San Francisco are located here, and it is considered a highly hazardous area. And so we now know that the Homeowners Loan Corporation was doing this, and clearly it was doing it in a very biased way. Areas that you may now know in modern times as much more affluent areas, you could see are in green and blue. And the areas that were deemed still desirable or less risky were yellow. So we actually, during the pandemic in our group, had a question of how has redlining affected the risk of transmission and death from COVID-19? Because there has been previous work that has started to highlight that redlining was a factor in negative health outcomes. And so we set out to conduct an ecological study that used aggregate data at the census tract level on COVID-19 cases and deaths reported to the California Department of Public Health from January 2020 to November 2021. And as you can see here, the tables on the right show total number of cases and total number of deaths for the state of California. We then took Homeowners Loan Corporation maps from the state of California, which includes 8 major cities, one of them being San Francisco. Other major cities include San Diego, Stockton, Sacramento, Los Angeles, and a few others in between the state. We removed the zones from the Homeowners Loan Corporation that had been graded. We extracted them digitally. And then using census tract information, we overlaid the census tract centroid, or the center of the census tract, on the HOLC graded zones. And then by using this method, we were able to assign census tracts to previous Homeowner Loan Corporation graded zones. So what I'm trying to say is I'm trying to assign modern day census tract geography to geography or outline maps that were created back in the 1930s. We then used information that was publicly available to find these covariates. And this is kind of trying to adjust for variables that may be affecting the rates and deaths of COVID. We chose percent female, median age, overcrowding, the COVID testing rate, comorbidities, and also which included asthma, chronic obstructive pulmonary disease, chronic kidney disease, hypertension, diabetes, and obesity. And we used the American Community Survey to extract these data. Another thing that we did was we created separate models that included those covariates, but also included aggregate measures of community well-being. One of those aggregate measures, called the California Healthy Places Index, is an aggregate measure that has 25 separate factors that it is used to create one final score. And actually, the state of California was using the HPI in its response to the pandemic. So it was trying to do an innovative thing to try to ensure equity in the response to the COVID pandemic, for where to put testing sites, where to do vaccinations. And also it's trying to make sure that the communities that were vulnerable weren't impacted so much. So actually this was an interesting measure because we wanted to see if it was actually effective enough to account for what we think is systemic racism with redlining. In addition to that, we used another measure called the Index of Concentration of the Extremes. And this is more of a measure of spatial separation of the deprived and privileged groups, which means basically uses a measure of income to see the groups in a certain area, how separated are they based on their financial status, socioeconomic status. And we thought that this may be a more modern day surrogate to segregation, because as you know, redlining or segregation itself deprived groups of generational wealth and the accumulation of wealth over time. And so we thought that it may be a surrogate marker for redlining. So right off the bat, our initial analysis, this was our initial analysis. And so you could see on the bottom on this left graph, going from A being the most, the green zones or the areas that the HLC thought were the lowest risk and had the fewest ethnic and racial minorities. You can see that right off the bat, COVID cases seem to be lower. And there's this interesting trend where as you go from left to right, where B is the next worst graded zone, C is the next worst graded zone, and D being the red line zone, you can see that it has the highest cases. On the right, you can see the track seems to have a similar curve, but we weren't unsure at this point because these were raw numbers. We've then implemented negative binomial regressions to begin our modeling. And so in our first unadjusted model, this means just taking into account all the numbers and the HLC graded maps with the census tract locations. We saw that red line neighborhoods were associated with 102% higher case rate and 11% higher death rate compared to the best graded zones. We then started going from model B to D, adjusted for covariates, HPI, and ICE. And these adjusted models showed that redlining areas had at least 11% higher case rate and at least 18% higher death rate compared to the best graded or green tracts. And as you can see on the right here, I have a couple of cities with heat maps. The first one here on the most left side is the redlining map that we created. This one on the middle is the COVID-19 cases heat map, and the one most on the right is the death, the heat map for deaths in these particular cities. And if you're familiar with any of these cities, you could see that the areas that, for example, in San Francisco, this area right here in the red is like the Mission area, or an area where the general hospital is. And it also corresponds to an area with a more deeper color or more deaths, and definitely an area with a deeper orange or more cases. Similarly, in Oakland, you could see that the area in red is associated with more cases and also more deaths. And in Los Angeles, you could see that the center of LA, or downtown Los Angeles, and South LA are also associated with deeper colors. So that was an interesting result. And we then proceeded to see how the surge affected cases and deaths. And during the 3 surges, we found that redlining neighborhoods had significantly higher case rate by approximately 20%. During actually, it ended up being the second surge during the first year of COVID that we found that redlining neighborhoods were affected the most. And death rates were also significantly higher for redlining neighborhoods. The winter surge of 2021 actually showed that the winter surge had 58% higher case rate compared to the green tracts. So in conclusion, I just wanted to mention that the legacy of residential redlining remains present And this study shows that its effects have worsened the devastating impact of COVID-19 in vulnerable communities. Historical residential redlining represents a robust risk factor for worse health outcomes from COVID and likely other health conditions that should be taken into consideration in future health policy and action. And really, this isn't just about redlining. I think what we're trying to show is that this is a factor in negative health outcomes. And it's really up to our society to try to address these changes, because it really condemns these neighborhoods to having worse health outcomes for not just COVID pandemic, but for all other pandemics or other health outbreaks like the flu, RSV, tuberculosis, and many other communicable diseases, and probably all communicable diseases. So the next steps that we'd like to do are do a city-to-city comparison, because as you know, the COVID pandemic was really, the response to the COVID pandemic was not equal in every city, even in the same state. And so we wonder how local health policy affected the effects of redlining on COVID. We'd also are going to talk to the California Healthy Places Index, because we found that it wasn't enough of a robust marker to really account for or find the effects of racial segregation and redlining on COVID-19 cases and deaths. So with that, I'd like to acknowledge my collaborators in my lab, Nita Thakur, who is my primary mentor, and all my collaborators on this project. Any questions? Thank you.
Thank you, Dr. Casillas. For our attendees, if you have any questions, please stay at the end of all the presentation, where each panelist will address each questions respectively. Next up, we have Dr. Daniel Gonzalez.
Hello, everyone. Good morning. Let me see if I can share my screen here. Can you all see my screen?
Yes.
Okay, perfect. Well, thank you so much for inviting me. I'm very honored to be here. Again, my name is Dr. Daniel Gonzalez. I'm the Chief Rheumatology Fellow at the University of Texas Medical Branch. And I was invited to speak on a very rare rheumatological disease entitled MDA5 dermatomyositis. And I was asked specifically to present a publication I had last year, 2022, which was entitled Anti-MDA5 Dermatomyositis After COVID-19 Vaccination. I have nothing to disclose. So I briefly just wanted to talk about what exactly is MDA5 dermatomyositis, specifically for the non-rheumatologist and non-pulmonologist who are listening. So anti-MDA5, which stands for melanoma differentiation associated protein 5, is a rare subtype of dermatomyositis. And what anti-MDA5 is essentially is what's referred to as a myositis-specific antibody, or MSA. And over the last about 50 to 20 years, we've learned a lot about how to subtype and subcategorize different versions or presentations of dermatomyositis. And we use these MSAs to help guide us. And what's interesting about these myositis-specific antibodies, that if a patient is positive for one, you should expect or should be cautious for a distinct disease phenotype. And so for MDA5, I'm just going to focus on this MSA today. What a clinician should be suspicious for or should be cautious for are ulcerative erythematous cutaneous lesions, typically occurring on the hands, and I'll have photos showing this later. Now, the most alarming and concerning feature of this disease is its association with what's known as rapidly progressive ILD. And this is most concerning because up to 50% of cases can be fatal because of this rapidly progressive ILD. Now, thirdly, this can be kind of confusing because the name is a dermatomyositis, but this particular subtype, MDA5, is typically not associated with muscle weakness or muscle involvement. It's what's referred to as a clinically amyopathic dermatomyositis. You could be more specific and actually say clinically amyopathic to hypomyopathic, because the muscle involvement is not always absent. It's not a striking feature. It can be minimal to moderate. It's just not as striking as the skin or lung manifestations. And lastly, it has a very poor prognosis, and that's directly related to the rapidly progressive ILD that these patients can develop. So this is just an illustration I just briefly wanted to touch upon, just highlighting the different MSAs that exist. And I just wanted to show here that MDA5 is specifically a lung and skin disease. You don't really see the severe myopathy or the high risk of calcinosis or high associations with malignancy as you do with the other MSAs. It's just mainly a lung and skin disease. So here are some examples of dermatomyositis rashes you may have seen. Just to briefly remind you all, the Gottsched's papules are the erythematous scaly lesions typically seen on the bony prominences of the hand, such as the MCPs, the PIPs, and DIPs. Gottsched's sign is what's referred to as the same type of rash appearing on extensor surfaces like the elbow. Here's another clue we look for on physical exam, which is the heliotrope rash. The top left is a very diffuse periorbital edematous version of the heliotrope rash. The top right is a more erythematous scaling version with not so pronounced swelling. And both of these are considered heliotrope rashes. The center photo is just a facial rash you can sometimes see with dermatomyositis. Here are other examples of rashes. I don't want to go into too much detail about this, but this is other locations to look for that rash. So this is what is distinct about anti-MDA5 disease, is that in the distribution of the Gottsched's papules, you see more ulcerations as opposed to just erythema. So here on the far left, you see an example in the New England Journal of Medicine. There's very obvious ulcerations occurring over the MCPs, some over the PIPs as well. I'm going to use my marker here. On the far upper right, it's what's referred to as reverse Gottsched's papules. You can see the same sort of ulcerations, but occurring on the palmar interphalangeal creases of the hand. And that's another clue to suspect MDA5. The bottom photo is just another example where you see these interphalangeal creases with the ulcerations, some other locations of the ulcerations. And here as well, in the digital tip fingertip, you can see some ulcerations there as well. Here are some examples of how MDA5 may affect the lungs in terms of X-rays and CT scans. The upper left is a chest X-ray where you just see this kind of haziness bilaterally, some fluffy opacities. The CT scan on the bottom right, you can see some interstitial edema, some ground glass opacities as well. Here are more examples. In this particular case, you see the ground glass opacities, particularly in the middle and upper lobes, with some interstitial lesions. And in this case, some pleural effusions were present. So why am I talking about this particular disease in the setting of COVID-19 infection and vaccine? Well, the main reason for that is that over the past 2 years or so, there's been a growing number of publications and literature highlighting the association of COVID-19 infection with developing MDA5 disease. Mainly the fact that, that COVID-19 being a possible trigger of developing the disease. Now, prior to MDA5 becoming an autoantibody and playing a role in autoimmunity, what MDA5 essentially is a cytosolic sensor of viruses, particularly RNA viruses. And the SARS-CoV-2 virus appears to mainly be sensed by our immune system via this MDA5 pathway. What's interesting about the SARS-CoV-2 virus is that a hyperinflammatory state seems to occur after MDA5 sensing, with subsequent interferon and other cytokine productions. So the MDA5 this pathway does not seem to control the viral replication in our skin and lung epithelial cells very well. Now, on top of all of that, the clinical similarities actually between COVID-19 infection with MDA5 affecting the lung is very difficult to distinguish. The interstitial pneumonia that you see with COVID-19 with subsequent ARDS, acute respiratory distress syndrome, looks very similar clinically to the MDA5 rapidly progressive ILD that can develop. So we know the link between COVID-19 infection and MDA5, and we know that the MDA5 immune pathway is what senses COVID-19 virus. But now there are more and more anecdotal reports of the mRNA vaccine using the same MDA5 pathway as being a potential culprit in triggering MDA5 disease. And more of these case reports are coming out. This was my particular publication that I released showing 6 cases of MDA5 disease occurring after different types of COVID-19 vaccination within days of the vaccine. And I suspect more of these publications are going to continue coming out, highlighting this association. This is a very interesting article I wanted to briefly touch upon. This was a retrospective study done in China in the 3 largest cities at the peak of the COVID pandemic. So this was occurring between December of 2019 and April of 2020, where researchers suspecting this association with MDA5 disease with COVID infection went back and looked at the serum of about 274 patients who were hospitalized with COVID infection and did their titers and found that almost 50% of those patients, 48.2 to be exact, had positive titers for MDA5. And the higher the titer, the sicker these patients were and the poorer prognosis they had. So they concluded that the MDA5 was, they suggested it as being a prognostic marker in COVID-infected patients. And so this was just another article I wanted to highlight I found very interesting, kind of supporting the link between COVID-19 and MDA5. Here's a table just showing the clinical similarities with both. I don't want to spend too much time here, just basically showing that both are triggered by viruses. You can see the muscle involvement. The cytokine profiles are very similar, as well as the CT scan findings are very difficult to distinguish. Here's an illustration of MDA5 sensing of viruses. I'll use this slide, which is more specific to SARS-CoV-2, which essentially shows the same thing. You have the COVID virus that enters the cell, is sensed by this MDA5 sensor with eventual activation of downstream events where you get a pro-inflammatory state. Now, on the right side of this image, I just wanted to highlight that researchers were able to show how the MDA5 is the main sensor of COVID-19. They found that if you block downstream of MDA5 sensing, you basically inhibit the pro-inflammatory state that can develop. So it was just another support that MDA5 is the main sensor of SARS-CoV-2. Now, this is an illustration I wanted to highlight briefly of how the COVID-19 mRNA vaccine uses the same MDA5 pathway with eventual interferon and cytokine response. Perhaps for unknown reasons in some individuals, a hyperinflammatory state, just like in COVID-19 infection, may occur in these individuals. The hypothesis proposed is that increased MDA5 expression, like from the infection, may be occurring from the vaccine with subsequent self-recognition and autoantibody production. So we don't know much about what's going on here. This is just in words, basically what I described in the previous 2 slides, that upon entry to cells, you have recognition of double and single-stranded RNA by various sensors, whether endosomal or cytosolic. MDA5 is a cytosolic sensor with resultant production of interferon response and multiple inflammatory mediators. Now, the current mRNA vaccines, they're made with modified nucleotides to reduce binding of these immune sensors like the MDA5, thus limiting excessive production of this type 1 interferon and other cytokines. And perhaps this is the area that needs more research as to why in certain individuals, increased amounts of interferon are produced via sensing of the mRNA vaccines. We just don't know much yet. So this was the publication that I had last year, just introducing 6 cases of MDA5 dermatomyositis after different types of COVID vaccine, and also within days of getting the vaccine. I'm only going to use case 1 as an example of what a possible scenario could look like. Prior to my publication, there was actually only 1 case report suggesting this relationship, this association. So for my particular case that I'll highlight, it was a 45-year-old Hispanic male. He had no past medical history of any kind, no family history, and was not taking any routine medications. And he presented to his primary care doctor with this left-sided periorbital swelling and erythema. 2 days prior to his first symptoms, he received the second shot of his Moderna vaccine. He received the first dose of the vaccine 2 months prior without any issues. He was initially treated in the allergy clinic for a presumed allergic reaction, and he had received, courses of prednisone and antihistamines with no real improvement. And in fact, his condition worsened over the next several months, with the rash essentially extending to the rest of his body, the opposite side of his face, his extremities. He described the rash as very itchy, and he later developed polyarthralgia and right arm swelling and pain, which is what prompted his admission to the hospital. Here's a photo of his face at the allergy clinic early in his disease process. I hope you can appreciate, it's not an excellent photo, but I hope you can see the upper eyelid erythema and some left facial erythema that he had. Again, this is early in his disease process. This is when he was admitted to the hospital. And so you can see here on the palmar aspect of his hand, you see these, in the creases of his palms in the interphalangeal creases, you see these ulcerations. You see some erythema extending across the palm. On the far right, you see in the distribution of the Gottron papules, these ulcerations over the MCPs. The bottom left is actually a picture of his upper back. And that was described by the dermatology team as a very erosive retiform rash. I had never seen that before with MDA5. And the middle photo is actually a picture of his arm. And I put it here in the middle to compare to the photo to the right, where you can see that the photo to the right, his hand looks a little more skinny compared to the middle photo. This arm just progressively got more swollen during his hospital admission. So here's his physical exam findings. I won't go into detail because I just kind of highlighted the photos. I just want to highlight here that on his neuro exam, he had normal strength and range of motion in all his other extremities except that right arm. And the COVID vaccine was actually administered to his left arm. So this wasn't a local reaction, it was a systemic reaction. And the remainder of his exam was normal. So just to briefly touch upon some lab values, his CK level was about 300, but it did peak at about 1,000, and that coincided with when his right arm really blew up. His inflammatory markers were elevated. CRP had peaked at 19, and that also coincided with his right arm being quite swollen. Ferritin levels were elevated. After he had failed essentially IV antibiotics for a presumed infection cellulitis picture, we were consulted. We recommended an autoimmune panel. Now, the extended myositis panel, unfortunately, at our institution at UTMB, we don't have that in our lab. So it's a miscellaneous send out, and it can take up to 18 days to result. In the meantime, we basically did more tests. His CT arm basically showed inflammation concerning for myositis, and his chest X-ray on admission was clear. So after he had failed his IV antibiotics, we were suspecting some form of myositis. We started IV high-dose steroids with IVIG with a prednisone taper. Now, on his third day of his IVIG, he developed hypoxia, about 85% on the room air. A repeat chest X-ray at that time showed fluffy bilateral opacities. A repeat COVID test was negative. And his CT thorax, as you can see here, it was read as having bilateral ground glass and nodular opacities with concern for rapid error space and diffuse alveolar hemorrhage. So his myositis panel returned on hospital day 16 for high positive MDA5 and also Rho52. I only mentioned this antibody because it's considered a myositis associated antibody. And when positive with an MSA like MDA5, you expect a poor prognosis. So we went ahead and pulled the trigger on this gentleman and gave him rituximab, a powerful B-cell depleting agent on hospital day 9, about a week before the titer resulted because our suspicion was so high. His right arm swelling, rashes, and hypoxia improved, which was shown with a repeat CT lung that showed resolution of the opacities, and he was maintained on methotrexate ever since. So briefly, just highlight some of the pertinent results of my case series. 5 out of the 6 cases were female. The average age was 46 years old, with the range being 28 to 58. All of the cases demonstrated rashes typical of dermatomyositis with varying degrees of muscle weakness. 3 out of the 6 cases developed rapidly progressive ILD. The mean days after vaccine administration was 8 days with a range of 2 to 14. I have seen some case reports showing up to 20 plus days after vaccine administration getting MDA5. And 5 cases occurred after the second dose. Only 1 case was after the first dose. So this is basically a summary of what I just talked about. MDA5 with rapidly progressive ILD and COVID infection is very difficult to distinguish clinically. MDA5 is a known part of our normal innate immune response of sensing viral RNAs. The proposed mechanism of getting MDA5 disease is that RNA viruses upregulate MDA5 expression, leading to cell lysis, production of the MDA5 viral complex with resultant autoantibody production. And the antibody itself may have a pathogenic role, and that's exemplified or supported by the fact that the higher the titer of MDA5, the more severe disease you expect and the higher likelihood of developing rapidly progressive ILD. Now, what's really important with these types of patients is that timely diagnosis and therapy initiation is crucial because of that rapidly progressive ILD that these patients can develop. So, and lastly, my findings are not meant to dissuade individuals from getting the vaccine. In the vast majority of cases, the vaccine has been without any complications. However, in certain individuals, I just want to highlight medical providers to sensitize this life-threatening disease that may occur in this COVID era that we're in. And those are my references. Thank you very much. Any questions?
Thank you, Dr. Gonzalez. We'll hold the questions at the end of our final presentation. Our
Sure.
next presenter is Dr. Sharon Cobb and Dr. Atla Dillard, who will be talking to us about vaccine hesitancy in underserved communities.
Good morning, everyone. Thank you so much for the invitation to be able to present to you all today. I am joined by my esteemed colleague, Professor Attila Dillard, and we will be discussing to you all today on some of the work that we have done with COVID, especially in South Los Angeles. So I'm going to go ahead and share our screen. So currently we are both faculty as well as researchers at Charles R. Drew University of Medicine and Science, which is located in Los Angeles, California, and is recognized as a historically Black graduate institution and one of those only on the West Coast of the United States. So we're here again to talk about community partnered interventions to increase COVID-19 vaccine uptake in South Los Angeles. I will just say we have no relationships, commercial relationships to disclose. And just to give you a little bit about myself, I am the director of the pre-licensure nursing programs, as well as an associate professor at our university. And we also are joined by our study team. And I'm not sure if Professor Dillard, if she also wants to unmute and introduce herself at this time as well.
Yes, thank you so much, Dr. Cobb. Good morning to everyone. My apologies for my camera being off. I'm currently in clinic, but I'm happy to be here and thankful to hear all of the amazing presentations. As Dr. Cobb said, my name is Professor Attila Dillard, and I am faculty at the Mervyn M. Dimely School of Nursing at Charles Drew University. And for one of these studies, which we will be discussing today, I was particularly the project coordinator for the study. So very happy to present the work that we're doing at CDU and hope you all are interested in what we have to discuss.
Thank you so much. And as you can see on the screen here, we have multiple individuals, part of our study team. We have always focused on making sure that it's interdisciplinary, composed of physician, nurses that we are in our background, but as well as others such as medical sociologists, public health specialists, because we know that it takes a multidisciplinary team to achieve many of our outcomes as we discussed today. And moving on, we do focus, our university is located, as well as our work, in Service Planning Area 6. I won't delve into this as much because I know my colleague, Dr. Wissa, talked about this earlier in her presentation, but Los Angeles County is currently split into 8 different planning areas. And so we're located in what's known as SPA 6. This includes areas such as Compton, Crenshaw, South Los Angeles, Watts. And there's over 1.1 million residents that reside in this area, which is bigger than a lot of other metropolitan cities. Most importantly is that this SPA is mostly made up of the Latinx or African-American community. However, it's also recognized as one of the most under-resourced and underserved areas in the entire United States, which is why it's important that we continue to do the work that we do. So over 40% have less than a high school education, report a household income below the federal poverty level, and as well as report their quality of health to be fair or poor, which necessarily pushed us to say, this is why we need to create the interventions that we are going to discuss today. So particularly, I'm going to focus on 3 different interventions that we focused on. One was the first one with working with individuals who are diagnosed with a mental illness. Specifically, we're trying to mitigate their COVID-19 risk, as well as to increase vaccine uptake. And this was funded and in partnership with the UCLA David Geffen School of Medicine. The second one was focused more on African-American churches. So we created a faith-based participatory intervention to reduce COVID-19 risks within this population. And the third one, which I will definitely have Professor Diller discuss more on, is our community partnered intervention in order to increase COVID-19 vaccine uptake among low-income African-American and Latinx individuals in public housing. So these other two were funded by the National Institute, NIMHD. So we focus more on these areas. And why is that? We stood as either PIs or co-PIs within these grants. And as I said, it's focused more on COVID-19, which is the topic today, but it's focused on communities that are particularly left out. And at the end of our presentation, we hope to give strategies here today in order to have you also increase your immersion within these communities to particularly focus on their health. So with regards to the first grant that I discussed, what we did is that for many of our interventions, we focus on a multi-phase study in which we look, how can we embolden or empower the community that we're working with? So using a multidisciplinary approach, we train mental health therapists at a community mental health clinic known as Tessie Cleveland Community Mental Health Clinic, which is in South Los Angeles, but provides services for all of LA County. And so with that, we focus on looking at individuals who they're primarily, the therapists are primarily made up of minority populations. And so we were able to do a 2-day workshop training to train these therapists as COVID-19 health ambassadors. And we focused on how they will now lead individualized coaching sessions with their own patients. So they were able to, in order to have 4 coaching sessions with their patients on how to talk about COVID-19 risks, adopting prevention practices, how to complete some of that training, and how to increase their uptake. So we were pretty successful in a lot of the strategies, because not only did we have African and Latinx individuals with mental health illness as adults, but we also worked with the guardians and parents of African American and Latinx children. So we focus on both populations, and we were pretty successful in seeing an increase in both their knowledge and reduction of risk for COVID-19. So our second study focused more on African American churches. And with this, we were able to actually, again, using a multi-phase approach. For our first one, we worked with 12 African American church leaders, which are commonly known as pastors. And within that, we had a 6 to 8 week session with these pastors, in which weekly we discussed a lot of the topics that they were undergoing at that time. For the African American churches, it was a difficult time. This was something that had never affected the African American church. A lot of churches had to transition to going online. There was a huge increase in the number of funeral services. So there were just various challenges that were affecting African American church leaders that we discussed, as well as we created a guide on how can these churches reopen safely for their congregations using both federal and state public health guidelines. So this was our first phase, was to ensure that the leaders were also aware on how they can increase knowledge for their congregation, as well as reducing risk. The second phase of this was that we trained actually African American church leaders as health advisors. So we use different individuals within the church, such as those who are family ministry leader, those who are usher, those who are deacon, and we were able to train them in order to become those experts in the church about COVID-19. And so we focus a lot more on older adults who had an underlying multimorbidity, or they reported social isolation. And then in turn, these African-American church leaders then worked with 125 African-American older parishioners in order to mitigate the negative impact of COVID-19 on the management of chronic health conditions, as well as to reduce healthcare avoidance behaviors and psychological distress. So thus far, we're starting to end in this study, but we've been largely successful in actually with rolling out this particular intervention across the state of California, from Northern California to San Diego, because of how popular it has been, especially with its effectiveness with Black churches across the state. So this has been largely successful, and this was one of the areas we really wanted to target, especially for the African American community. And then lastly, this is one of our studies that we're currently undergoing, and this has to do with the Housing Authority for the City of Los Angeles. And one thing to note is that the Housing Authority for the City of Los Angeles, commonly we hear it, but this is known as for public housing, and it serves over 20,000 families, residents within Los Angeles, particularly in South Los Angeles, such in housing areas such as Nickerson Gardens, Jordan Downs, Imperial Courts. And so we've been able to work with the Housing Authority to be able to roll out this intervention in order for to increase vaccine uptake for one of the most under-resourced communities within the United States. And so with this, I will turn it over to Professor Dillard to talk about phase 1 of what we did with this study as well.
Thank you, Dr. Cobb. As Dr. Cobb mentioned, again, this study was a community-partnered intervention in which we were addressing COVID-19 vaccine hesitancy and concern, as well as attempting to increase vaccine uptake among African American and Latinx public housing residents in South Los Angeles. And with that being said, it was a multidisciplinary as well as multi-level intervention. So there's specifically 3 phases in which we carried out with this intervention. And I'm primarily going to be just talking about the first and the second phase as we are continuing with phase 3 currently. So phase 1 was all about activate leader training. We realized the importance of community health workers in improving health outcomes, health behaviors within their community. And so our goal was to train activate leaders, which stands for academic community team, for the improvement of vaccine acceptability and targeted engagement. And so these were leaders that we identified in the community, primarily public housing residents were trained, as well as we included students from our health professional graduate program, such as our nursing students, as our physician assistant students, as well as our public health students. And so our goal was to develop a triad in which we were able to put various disciplines together to work and learn about becoming COVID-19 vaccine experts. And so this would help them be prepared to then work with some of the public housing residents in our next phases who identified as being vaccine hesitant or concerned and who were not vaccinated. So this was phase 1, training activate leaders. And again, our training spanned a number of different topics. Some of the presenters here were individuals who provided recordings for some of our trainings, and that involved a self-paced 8-week Google Classroom training sessions. And so all of this was done online, in which the public housing residents, the physician assistant students, our nursing students, as well as our public health students at CDU were able to engage in this training. And so overall, to date, we have trained 114 activate leaders, and they have gone on to participate in our second phase of this intervention. And we were able to make sure that a majority of the activities and the education that they received during this Google Classroom training was in alignment with their coursework. So again, highlighting the importance of community engagement, working with the communities with our health professional students. Our university is one that prides ourselves in community work and making sure we're able to align that with the coursework that our students are getting as they become health professional leaders. So that was our first phase, activate leader training. Our second phase was very interesting. It was our community partnered intervention in which we developed town hall forums as well as health and resource fairs for community members in various public housing sites. Particularly, we worked with 4 public housing sites for our health and resource fairs. But our goal primarily with our town hall forum was to provide education from a multidisciplinary panel in which we had 4 weekly virtual town hall forums for residents. And we covered a number of topics such as dispelling COVID-19 vaccine myths, understanding, what the booster means, right? At this time, the boosters were coming out, and we were also identifying that, the FDA had provided or approved vaccines for children. And so we were hearing through our work, our community work with HACLA, the Housing Authority of the City of Los Angeles, as well as some of our public housing activate leaders, that these were topics that they needed to learn more about. These were topics that were contributing to some of the vaccine hesitancy that they were hearing among their peers, among their families and friends. And so we were able to identify these topics, and we had 4 virtual town hall forums that took place over 4 weekends. And primarily, we wanted to make sure that these town hall forums were inclusive to everyone, understanding that a large population of public housing residents are monolingual Spanish-speaking residents. We were able to ensure that all of our town hall forums were both presented in English as well as exclusively in Spanish. And so we had a panel of mostly disciplinary experts from pharmacists, from physicians, nurses, as well as public health leaders, and even our public housing residents to take place in this panel where we can provide bi-directional conversations between our public housing residents who attended and identified themselves as being unvaccinated and hesitant, as well as the experts on COVID-19. So this took place across 4 weeks, and following each town hall forum, we had health and resource fairs. Again, in collaborating with the Housing Authority, they identified the importance of us providing vaccine accessibility to the community. So that was something that took place across our four public housing sites, and a number of residents came out and participated in some of the resources that were available. And so when we talk about our results, specifically for phase 2, we were able to expose our intervention to over 600 residents, and that included participating in virtual town hall forums, those who maybe attended health and resource fairs, as well as just engagement through the community through our recruitment. And I do want to mention, although we were able to identify or engage with 600 residents, there was still, of course, some challenges in participants wanting to participate and specifically complete surveys. So the data that I will share today is reflective of our 268 residents who did complete surveys with us, because again, we were identifying, trying to understand their vaccine hesitancy and mistrust, as well as other factors related to COVID-19 uptake with our questionnaires. But what was great about our residents is we were able to vaccinate 55 residents, and you'll see our demographics on the
Pardon,
side
Professor
here.
Dillard.
So
Yes.
I will quickly wrap up.
Feel free.
We'll quickly wrap up. So, there is lots of data, and we'll be happy to share the results as we're creating in terms of data analysis. And as well as manuscript. I think most importantly is that we saw a reduction in terms of vaccine concerns. And most importantly, we're continuing now in phase 3, which is to continue with recruitment of unvaccinated public housing residents, and also to provide individualized coaching for those who may still express some hesitancy toward taking the vaccine. So we do have strategies in order to change the conversation, and just really looking at these community health workers and how do we, in terms of promotion of care, and really looking to see how we can empower individuals to be at the center of their care. So with that, we thank you, and we just hope that we all continue this conversation in order, how do we do a culture shift towards more person-centered care? Thank you so much, all.
Thank you, everyone, to all of our panelists and experts who joined to share our research. We have exhausted our question and answer time, but if you post your questions in the question and answer portion of the chat, we're happy to answer. To our panelists, I would again express my thanks. The National Medical Association is the nation's leading forum for the discussion of health disparities and the health of minority communities. And so we hope you continue to stay involved with us. And thank you to our chairs and coordinators for this event. Thank you from Pulmonology.
Also, please don't hesitate to email all of our speakers if you have any questions that we couldn't answer today.
Treadwell, you're muted. You can start.
Hello? Should I begin now?
Yes, Dr. Treadwell, yes.
Let me make sure my slides are up. I'm trying to put my slides. You have my slides, or do I need to sign out? And let's see, trying to figure out what I need to do here.
You want me to share it for you? I have it.
Yes, yeah, please. I appreciate that. Excellent. Let me get my, trying to move my picture somewhere else. There you go. Good morning, everyone. I am Ed Treadwell, Professor Emeritus at the East Carolina University School of Medicine and Rheumatology and Immunology, where I've been the last 40 years. Still now has transitioned mostly to research. And I'm very happy to have my a long-term colleague, Dr. Adrienne Burford-Fogg, who is a clinical professor at the McGall Medical Center of Northwestern University and the Feinberg School of Medicine. And Adrienne has a very active private practice in rheumatology, and so she will be given the realistic point of view, and I'll go over some of the recommendations that the American College of Rheumatology and the Arthritis Foundation has given out during this COVID-19 era. And so I have no disclosures to give, and I know this is not CME's. Shonda has recommended that to me. So our objectives are to try to give some updates on a vaccination among rheumatology patients, which I think is the most one at risk with all our diseases. And Dr. Gonzalez has just showed one of my diseases very well, dermatomyositis and polymyositis, which was my initial research projects when I started my fellowship. And I've collaborated with the University of Oklahoma, who have done a lot of the work on dermatomyositis and polymyositis. And so the MDA5 is of very interest to all of us, and it's interesting how that may become associated with the tRNA synthetase antibodies, and also one of the antibodies that I worked with early on called PM1, and it was later named PMSCL, which you can get it now. So that's a very interesting area, and why these patients get interstitial lung disease. That's a very good segue into the things that we deal with in rheumatology, and those patients need heavy immunosuppressives. The earlier the start, the better. So the question is, how do we give patients the vaccinations, and somebody who is also immunosuppressed, and what effect does that have on them? So that's a very interesting topic, and I'll try to review some of the salient features of that as well. So, and also we want to review the drug therapies that put patients with rheumatic disease at increased risk with and without the COVID-19 disorder, and to say that, why these patients need to be vaccinated as well. And there's a lot of questions about, patients already immunosuppressed. How do we know they're immunosuppressed or not? And there are ways in determining that. Since my early career, even in medical school, I grew viruses for a whole year. So I was very blessed that most of my training was heavily influenced by infectious disease. And although, and that was my goal one time, to become a bioimmunologist. But right before HIV became on the scene, I thought I wouldn't have any work to do except working for a state lab. So I guess it was God's will that I didn't go in that area. So it was only about 1 year after that when HIV became recognized, and I was very involved in that as well early on. So we want to increase awareness of physicians, healthcare providers, as well as nurses, anyone involved in patient care and rheumatic diseases, to be aware of what these patients' risk may be and how they should be vaccinated. Okay, and I thought I was using my own slides. They're moving. Okay, so here's some pre-test questions. You'll get post-test, and this is one that you can think about and do. COVID-19 vaccinations, as well as boosters, are recommended for all autoimmune inflammatory rheumatic disease patients except children under age 10 and adults over than 75. So you put that true or false. And the Moderna, Pfizer, BioNTech, and J&J vaccines are all recommended for primary and booster vaccination, true or false. Next, So next slide. And this is a primer, schematic representation of the COVID-19 virus when it was first discovered. And now we've discovered a lot more sites and variants than it was then. So I couldn't get my picture of the current updates on it, so I apologize for that. So and most of you will also recognize about these variants, aware of these variants, and I'll go over some of them as well. And my infectious disease colleagues have already reviewed a lot of this review on yesterday, and I really appreciate Dr. Foster, as well as Dr. Wiley and Dr. Jordan, excellent review of this. And so if I make any stumbles there, hopefully they'll back me up and forgive me. Thank you. Next slide, please. And this is Dr. Fauci, a picture of him, and he has taken all kind of hits. And Dr. Fauci was the guy as far as the National Institute of Allergy and Immunological Diseases at the NIH. And of course, at one point in time when I came out, he was the guy, the lab to get in, and it was almost, you had to be almost an act of God to get in there. So. And everyone looked up to him, and he's obviously a good friend of mine. Dr. Gallo was his associate, and I know Dr. Gallo very well, and he taught me a lot about viruses. And that's the sort of way, like, you can't be Jesus and God too much, because once you fail people, then they'll crucify you like they did Jesus. So I kind of have my sympathy for Dr. Fauci on that, but he has contributed a lot to the understanding of viruses and immune disorders, and so we should give him credit for that. Next slide, please. And so how do we get COVID? And this was reviewed yesterday. Well, we get it from contact, and and we had to learn that in our clinic. During the holiday season, we all got happy about being nice to our patients, and I kind of let it slip because we had not been doing that, and so we bought wrapped candy in, and patients could pick it up. And guess what? We had a floor that same day. About 4 patients, we went back in retrospect, it contacted COVID, and then some of us got COVID as well. And then just picking up wrapped candy. So don't do that. If you want to do that, use a prong or tongs and pick it up and give it to them and have it, separate. But even I wouldn't do that because the risk is very high. And unfortunately, it was mostly when the variants were coming out and patients had been vaccinated and staff had been vaccinated. So even though they caught it, it was mild. So it was said yesterday. The thing is distancing and even masking now, and I can't believe why people are not masked now. And it's probably like 1% of people in my area of a mask, and North Carolina is experiencing one of the highest rates of COVID now, as well as influenza. Influenza should have taught us our lesson that during the COVID, when people were masking, the incidence of influenza went down to less than 5%, almost 1%. So I don't understand why we need to be taught this lesson over and over again. You go to the next slide, please. And so this shows too that people in the rural areas in our area, they masked well, went out to the car to see the patients, and they kept the incidence of COVID down. So this is another instance. Next slide, please. And so the American College of Rheumatology in 2/11/22 put out the first recommendations, and they were revived in October 22, which I'll show you later. And so the recommendations are not rules. They are designed to replace not designed to replace the judgment of rheumatology care providers, either were primary care providers over their patients. So the primary care doctor has to make the final decision, but we want to give you some guidance to how you may have to do that. The patients at high risk are the autoimmune inflammatory rheumatic disease patients, known as AIRD, rheumatic disease. They have a plethora of different immune-related conditions. And we know they are higher risk of COVID-19 for hospitalization with worse outcome. And my pulmonary colleague said these patients are at high risk of getting lung involvement, interstitial lung disease, and from my experience, a lot of these patients, it starts in the throat and slowly trickles down to the lung. And I think we should be cutting it off and pay attention to when the infection starts in the throat. And if you catch that early, and I think these patients should be treated, and even sometimes with antibiotics. And I think now people more leaner and suggest antibiotics, and because this infection can be normal flora from the throat. And if you get that stopped early, I think we'll save a lot of patients. And so the vaccination should include all individuals with an autoimmune inflammatory disease or rheumatic disease with or without the COVID-19 infection, starting at age 5 and older with the Pfizer BioNTech vaccine, and age 12 and older with the Moderna. Next. And for patients not yet vaccinated, either they recommended that the mRNA vaccines are recommended over the single-dose J&J vaccine. I can give you a personal experience with that. And although my work is anecdotal and this is not CME, maybe I can spread out a little bit and tell you some things that we track patients. We track patients in our clinic with antibody titers, and even before the vaccine, we didn't get a chance to publish this, unfortunately, before they got the vaccination and afterward. And I can tell you that the J&J was much weaker than the Moderna and the Pfizer. Yeah, although they got some response. And I think there's been a lot of research done that maybe not been published, and that's the reason they made the recommendations that you don't need to get antibody titers before and after vaccination. I think they have given us good guidelines when they take the vaccine, and this is based on our collection of data as well. So, and there's no known contraindication to taking the COVID-19 vaccine beyond known allergens to the ingredients, what's in it. So, but a lot of patients did have reactions to it anecdotally. These were anecdotally, people were telling me that they was wiped out for 24, 48 hours. And so that scared a lot of patients. And a lot of patients, the fear came from saying that people like Bill Gates and others wanted to wipe out certain populations, especially minority populations, and that's the reason they put this virus out intentionally. I told them I don't care if a donkey put it out, and I know how to protect myself. I'm going to do that. So we need to try to diffuse some of this bad communication on why people shouldn't take vaccines. And unfortunately, the boosters, the rate I understand is only like 18%, and that's just unbelievable. So I think we have a lot of work to do, and this conference is very timely in trying to get people to understand why they should be vaccinated, and especially our immunosuppressive patients. Next, please. And they also made recommendations that in this group they had a task force who made these recommendations. They consist of 9 rheumatologists, 2 infectious disease people, and 2 public health individuals who came out with these recommendations. So we had a good across the board group, and they recommend a 3rd dose of the Pfizer Moderna vaccine, which is the mRNAs, and they recommend at least 28 days after the completion of the 2-dose mRNA vaccine for patients receiving any immunosuppressive or immunomodulator therapy except for hydroxychloroquine. And there was a theoretical risk that autoimmune inflammatory disease patients may experience a disease flare after getting the COVID-19 vaccine, but the benefits of the vaccine way outweigh the risk. If you didn't get it, the death rates were much higher, like 7 times higher than patients who didn't get the vaccine. And healthcare providers should not routinely order any lab testing, such as antibody tests for IgM, Ig spike, nucleocapsid protein, to assess immunity to the COVID-19 post-vaccination, not to assess the need for vaccination in a yet unvaccinated person. Now, I do have a little variance with that. I think the cost is the main thing, but of course, if you had the data, that would be, to me, that would be great. And we did test patients afterward, and a lot of my patients, and it was helpful because I knew the data. I knew where they had good immunity or not. But then sometimes patients who had good immunity also got the COVID. So it's more than just one factor in just the antibody. You have immunity you've got from getting the vaccine, and you also have innate immunity where your T cells are the ones that attack the virus even without never ever seen it, especially not killer cells. So you have 2 leg arms of your immune system that's important in attacking the virus. So sometimes it's not one at all, no matter what you do. Next slide, please. And so the timing of the question is, what about the medications we are giving patients? What about the immunosuppressive medications like methotrexate, mycophenolate, known as CellCept, cyclophosphamide, Cytoxan? Patients getting these kind of drugs, also the biologics we use for rheumatoid arthritis, psoriatic arthritis, Crohn's disease, like JAK inhibitors, which is known as baricitinib, tofacitinib, upadacitinib. All these are pretty potent drugs that we give patients, and there are guidelines on that, which I review. And it's interesting that they did not recommend that you give pre-medications such as acetaminophen, NSAIDs 24 hours before the vaccination, because they said they did not want to reduce the effect of the medication. Now, I'm a little biased on that. I must kind of tell you that if a patient wants to take those, I did let them take them, because patients know their bodies, and I've worked with viruses for a long time as well, and patients act differently, and I must admit I kind of know myself, because I had influenza all the time growing up, and until we got vaccination, and still, because my immune system, I've studied my cells, and it kind of put me predisposed to that. And I do take those before I take the vaccine, because it's I try to know myself. So I'm kind of going against the recommendations on that, and but not meant for everybody. But they do recommend that if you get any symptoms after the vaccination, go ahead and take these. Next slide, please. And so, and the recommendation also said, except for glucocorticosteroids and anti-cytokine therapies such as IL-17, 12-23, IL-23, interleukin-1, IL-6, and these are common biologic antibodies made against these that we use in rheumatoid arthritis, psoriatic arthritis, as well, especially IL-6 with the new one, IL-23, definitely psoriatic arthritis, that we hold all immunomodulatory or immunosuppressive medication for 1 to 2 weeks after we give the booster vaccination, assuming that disease activity allows this. And that's where rheumatologists, dermatologists, gastroenterologists may have to make decisions on this. And patients on rituximab or other anti-CD medications should discuss the optimal time with their rheumatologist provider. These are very potent drugs, especially rituximab. And rituximab really wipes out your immune system, especially making antibodies pretty bad. It really, so that one, it definitely has to be given by the primary care provider with the help of infectious disease and probably rheumatologists and all them together. And they also recommended people who are immunosuppressed to receive a booster shot in addition to the primary series and align with the guidelines from the Center for Disease Control and Prevention. All of this has been discussed with our infectious disease colleagues. And those who receive all 3 Moderna vaccines should get a booster at least 5 months after the 3rd vaccine. And those who receive the Pfizer-BioNTech vaccine and are aged 12 to 17 should get a booster after 5 months. People 18 and older should get a 4th vaccine after 5 months. Okay, so those who receive the first J&J vaccine and follow it with either the J&J with either a J&J or mRNA booster at least 2 months later should receive a booster 2 months after the 2nd shot. Okay, next slide, please. And I apologize, my camera was kind of not focusing on me enough. It's kind of apologize for that. And for the general population, the primary vaccine series consists of 2 doses of the mRNA vaccine, the Pfizer-BioNTech or Moderna, 1 dose of the J&J. And for people who are mildly or severely compromised, require an additional dose for their primary vaccine series, including children. That means 3 doses of an mRNA vaccine and 2 doses of those who receive the J&J vaccine. That means 1 dose of J&J and 1 dose of the mRNA vaccine. And according to our CDC colleagues, people who are mildly or severely immunocompromised include rheumatology patients being actively treated with high-dose steroids, alkylating agents, and metabolites, TNF agents, blockers, other biologic agents, and disease-modifying drugs that are immunosuppressed, immunomodulatory. Patients who are immunocompromised should see their first booster at the 4th shot at least 3 months after their 3rd shot, and may opt for a 2nd booster, 5th shot, at least 4 months after their 1st booster. And booster recommendations differ for immunocompromised children. That's when the physician has to make their own decision. And immunocompromised patients should receive their J&J, who receives J&J should receive the mRNA booster, 3rd shot, at least 2 months after their 2nd dose of an mRNA vaccines. And these patients are also eligible to receive a 2nd booster shot at least 4 months after their 3rd dose. Patients not immunocompromised who have non-inflammatory types of arthritis, that means like osteoarthritis, should receive a booster shot as well. So just because you're not immunocompromised, it doesn't exempt you from getting your normal vaccine. And this includes a 3rd booster of an mRNA vaccine at least 4 months after a 2nd dose of a booster, 2nd shot of an mRNA vaccine after a 3rd dose with the J&J vaccine. Patients 50 and older who received the J&J vaccine may also opt for a 2nd mRNA booster, 4th shot at least 4 months out of their first shot. Next slide, please. And boosters are available for adults and children as young as 5. The CDC recommends that adults and children receive an Omicron booster as well, since this Omicron variant has become very progressive now, and we're having more variants all the time. And so you get that if it's been at least 2 months since your last booster or primary vaccine dose. And you also, if it's been at least 3 months since your last COVID-19 infection, and also health experts also advise against getting an additional dose of booster that differ from what is recommended by the CDC or the FDA without the supervision of a doctor. If you have concerns about this vaccine protection, talk to your doctor about the best approach. Now, New England Journal of Medicine just published an article about correlates of protection that they can go and tell if the virus you have, the immunization you have will protect you against certain viruses and they do a neutralization test by taking your serum and taking the virus and see will it inhibit the virus. And so it's in lab test assay. And so the FDA just recently approved this. So they kind of going back kind of what I was doing. And I could do that because I had access to the tools. I had the lab available to me that I could test patients when, pretty much more freer than anyone in private practice. So we could tell, when you had good protection against the virus. So I'm glad to see the correlates of protection come out, and I hope that is put to use. Next slide, please. And also, the recommendations did address treatment with monoclonal antibodies, and in some cases, they do recommend a patient who is probably critically ill, who we know have COVID, that may get these monoclonal antibodies to the virus, and that may give some protection as well and help them to recover from the virus, because a lot of the rheumatology patients, a high percentage of them did get admitted to the ICU and did have lung involvement higher than other patients who had the COVID infection. And they also recommend that high-risk immunocompromised patients receive treatment with monoclonal antibodies when they are available and effective, and once they have been exposed to the coronavirus, once they begin showing symptoms to do that because of the high risk. Next. And the bottom line is, as was told yesterday, following COVID-19 vaccination, rheumatic disease patients should continue to follow all public health guidelines, which includes, number 1, mask wearing. Please try to tell that to everyone but you can. Hand washing hygienes, physical distancing, and other preventive measures. So I think if we do that, we can really cut the rest of these variants coming and the spread of the virus. Continue to obtain resources, stay updated to be informed about COVID-19 vaccine safety, risk, and medication interaction. I was very impressed and happy that the ARP does updates to elderly individuals. I'm in that group of being elderly now. I heard them coming on the phone, and I thought it was a telemarketer. And so I told my wife early on that I was not going to block telemarketers because I want to see what the scam artists are doing out there, where I can educate people, when they're not listening to things. And also, good things come out of bad things. And so I've gotten a couple of phone calls and said, we are online now, you are AARP member, so we're going to bring a person from the CDC on, or either they came from a high government official, and we're going to give you an update on COVID-19. And that was very informative. And so hopefully we can get more of that kind of education out to all our citizens of the United States worldwide. There's good education, and I think we all are indebted to do this. It's our charge to do this, and I think if we do this more, we can prevent the deaths and the illnesses from the spread of this disease. Next. And so one thing now, the big challenge now, the Omicron variant is the XBB variant that's come out that serves more than 50% of the COVID cases in the northeastern United States. with the risk of recent increase in travelers, especially during this past Christmas. They were expecting with all the millions of people traveling, and a lot of them traveling without no masks on. Again, I bet you wouldn't get 5% people wearing masks, even in the airlines. And so we are just making a bad situation for ourselves. So please let us try to stop this. And this XBB variant is a subvariant of the BA2, which may provide some cross protection. And the BA5, the original variant, has been overcome by the BQ1 and BQ11 now, most dominant, but on decline. And I apologize for not having a good chart there with this. I just couldn't get it quite all together for a short time. And the BQ11 and BQ1.1 is expected to account 63.1% of the cases in the United States compared to 64.6% just about 2 or 3 weeks ago now. So these variants are not as bad probably as the original one, but they still can be lethal and cause a lot of mortality. So we want to do all we can to try to protect everyone from this. Next. Okay. And this is a study showing that it was from Turkey, and what they want to know was, they did this nice study, and it's a reference at the end of my references, and they want to show how these vaccines, how did the vaccines, person I'm taking the vaccine, affect people, their anxiety level, kind of what they thought about it, and so they looked at 225 males and 311 females, mean age 50, age range 18 to 93, that were vaccinated between September 21 and February 22. And anxiety was rated by the subjects about, what is your anxiety on a scale of 0 to 10 about taking this thing? They did it before they took it, and then they took it after they took it. And it's amazing there was no significant difference. So they did it for the coronavac vaccine, as well as Pfizer, BioNTech, and some of the patients had both vaccines. So you can see 180 had the Coronavac, the Sinovac vaccination, and 214 had the Pfizer, BioNTech, and 142 of them had both. And results that 53.4% reported no anxiety after the first vaccination, and 67.5% after the vaccination, with a difference of p less than 0.01. So really they had less anxiety after the vaccination. So then 283, 52.8% reported a side effect after the vaccination, and the side effect was higher in the Pfizer than it was the Coronavac plus the Pfizer. And 8.4% patients had increased rheumatic complaints after the vaccination, but none of them was severe or caused the patient to be hospitalized. So in conclusion, overall, there was no significant increase in disease activity and absence of serious side effects requiring hospitalization reported after the vaccination. I may have had a reference under there. I can't see it on my screen. Can you raise the slide up just a little bit there, Solomon? If not, don't worry about it. I think it's just a reference. Okay, so in summary, COVID-19 vaccination can be given in most rheumatic diseases and autoimmune inflammatory disease without significant adverse effects as in other diseases. Vaccines also continue to show benefit, although there has been an increase in Omicron variants or new strands, and there are new techniques of testing neutralizing antibodies, correlates of protection, as they call it. And I think that would be very helpful in determining, if the vaccine's effective or not. And we have other courses. And then the good thing now, we have Paxlovid that seem to be very effective in treating COVID infection. And so some of those patients may need to be treated with that. Next. And these are the references, and I hope these can be given out to all the audiences, and they can share my slides, and with them to share my slides as well. Next. Now, are we ready for our questions now? We are. We can take them. If not, we can wait to my other partner is going to give a presentation on the on clinical applications of our discussions. That's Dr. Adrian Barefoot Fogg. Now we want to do the questions now. Okay, we can.
We already launched the question. The audience are answering the question now.
They answer them now?
Yes, they're answering them now.
Oh, okay, good. Let me get it up there. Let me get it up there. I mean, okay. Do we have the results yet, Solomon?
I'm sharing the result now. Should be able to see the result.
Okay, I didn't see them there. Let's see. They didn't come up.
Should have popped up on your screen.
Let me see where they disappeared on my screen here. Let me see where I got them at. I'm not seeing my, okay. I'm not seeing my answers. I'm not seeing them for some reason. I don't know. I'm not seeing them. Let's see. There we are. Okay. Do we have any? I'm just seeing my own. I'm not seeing my others. Okay. We'll go ahead then, and we'll bring Dr. Barefoot Fogg on and let her come on. I think she is muted. She needs to unmute.
Can everyone hear me?
Oh,
Can you
yeah.
hear me now?
Yes. Thanks.
Hi, I'm Dr. Adrian Barefoot Foggs, and it's a high privilege to be here today to speak to you about clinical applications of COVID-19 vaccines in rheumatology. I should point out that I have no disclosures. I thought we'd start out with case one, which this is one of my
Can you
patients.
pull up the slide? You're not sharing your slide.
Oh, it's on my screen. Now, how do I transfer it to yours? Let's see. I need you to do that. It's on my screen. Can you see it now? Oh, wait a minute. Wait a minute. Okay. Can you see it now?
No, if you go to the bottom of your screen, you see where it's the green button that says share at the bottom of your Zoom. You see that green icon that says share. If you can, I can share it from here.
Okay. That's working now. Oh, wait. I see it. I see it. Okay. Are we shared? Can you see it, Solomon?
Yes. When you put it in presentation mode, right at the very bottom to your right, where you see the zoom in now, if you go down to the very bottom, that the last icon there, that last icon to the right, go back to the right. Go, yes, no. Before that one.
That's
Yes, that one. Click on that icon.
okay. Nothing's happening. Oh, there.
There you go.
Okay, great. All right, and I'm going to shrink this. Okay, let's start with one of my patients that this is an actual case, a 61-year-old African-American female with longstanding lupus and severe asthma. She came into the office requesting a COVID-19 vaccine. She was under pressure from her family. Her history was notable for multiple hospitalizations for treatment of asthma and lupus. Her lupus flares are typically characterized by joint pain, swelling, and rash. She is treated intermittently with prednisone 20 to 40 milligrams daily for 4 to 6 weeks. Her other medications include albuterol and amlodipine, ipratropium bromide, and hydroxychloroquine. She previously had anaphylaxis after treatment with Fasenra, cyclobenzaprine, and the influenza vaccine, which contains polysorbate. Next slide. The best treatment option, and we have 4 options, is 1, proceed with the COVID vaccine. 2, check antibodies to the COVID vaccine and administer the vaccine if her levels are low. C, discontinue Plaquenil for 3 to 4 weeks and then administer the vaccine. Or D, do not administer the vaccine. Case 2 is a 63-year-old woman with rheumatoid arthritis, fibromyalgia, and osteoporosis who comes in for evaluation to determine whether or not she should have a COVID-19 vaccine. She has had severe polyarthritis, and she has failed treatment with methotrexate, Enbrel, Humira, Orencia, and Actemra. For this reason, she was treated with rituximab with improvement. She denies joint swelling, joint pain, stiffness, or fatigue. Which of the following options is the best? First, administer the bivalent 2-dose mRNA COVID-19 vaccine 4 to 8 weeks apart. B, administer a 3-dose primary mRNA vaccine, COVID-19 vaccine, on a 3-dose primary RNA schedule. C, discontinue rituximab. D, do not give the vaccine because she is immunocompromised. I'll give you a second to, you can submit your pre and post answers. Now, just to discuss the course objectives, we will briefly review the indications for COVID-19 vaccines. I believe they were discussed in detail by Dr. Treadwell, and discuss the implications of utilizing the COVID-19 vaccines in patients with autoimmune disorders. And we're going to use these 2 case discussions to highlight what is currently indicated. So first of all, just to briefly review, for all eligible individuals, the bivalent messenger RNA vaccine is strongly advised. The newest vaccine, the NVCoV2373, which just was recently started, is not a messenger RNA vaccine, may be utilized. It is approved, however, there's much less data. So currently, we favor the 2 messenger RNA vaccines, which you're very familiar with. That's the Pfizer vaccines for individuals primarily 12 years and older, but there is a regimen for individuals 5 months and older, and the Moderna vaccine for individuals 18 years and older, and that's 2 100 microgram doses 4 weeks apart. Keep in mind that individuals less than 65 years of age can extend the interval between those 2 vaccines to approximately 8 weeks. The Novavax COVID-19 vaccine was just approved. It's for 12 years and older. It's 2 intramuscular injections, and it's administered at a dose of 5 micrograms 3 weeks apart. Use is limited to individuals 18 years and older who have not previously received a booster and are unwilling or unable to receive a messenger RNA vaccine. Now, just briefly, and I'm sure you're familiar with this as well, but want to point out the difference between a monovalent vaccine and a bivalent vaccine. A monovalent vaccine contains an mRNA component from only one strain of the COVID-19 virus. The it does not contain, for example, the Omicron. Bivalent vaccines, however, contain messenger RNA components from two strains of the COVID-19 virus. Essentially, the bivalent vaccines are updated, and so that's what we currently recommend that all of our patients, and I'm sure you've heard, get a bivalent COVID-19 vaccine to protect against variant strains of COVID-19, such as Omicron. Patients with autoimmune disorders, rheumatoid arthritis, lupus, psoriatic arthritis, gout, vasculitis, axial spondyloarthropathies are particularly vulnerable to COVID-19. And in rheumatology, that's what we face, is a large base of immunocompromised patients. In addition to the fact that they already have an underlying autoimmune disorder, they also are on biological treatments which suppress the immune system and limit their ability to mount an antibody response to the virus. For this reason, we try, whenever possible, to vaccinate these individuals prior to initiation of an immunosuppressant or biologic agent, because they may not mount an antibody response. And this is really important because they are immunocompromised and may not mount an antibody response. A 3-dose primary messenger RNA vaccine may improve vaccine effectiveness instead of just giving them a 2-dose vaccine. Booster doses may be given as early as 2 months after the primary series, depending upon their antibody response. Now, the NVX-CoV2373 vaccine, as I mentioned earlier, has been recently approved for individuals who are at least 18, have received a primary vaccine series, but no prior booster dose, and are unwilling or unable to receive the messenger RNA vaccine. Now, let's just talk briefly about the side effects. Following the vaccination, side effects are common, and they may include pain at the injection site, fever, fatigue, headache. Those are the most common things. Some patients may just develop generalized lethargy, and generally speaking, these reactions resolve. Rarely, however, I want to point out myocarditis may occur, and this is truly with both of the messenger RNA vaccines. Now, it's important to note the contraindications. These are the patients who absolutely cannot be treated with a COVID-19 vaccine. And the primary contraindications are severe or immediate allergic reactions to the vaccine or any of the vaccine's components. And this would be polyethylene glycol, which is very, very common, polyethylene glycol, or polysorbate. All individuals should be monitored for an immediate reaction for at least 15 minutes following vaccination. Individuals without a contraindication who have a history of anaphylaxis of any kind, an immediate allergic reaction to other vaccines or injectable therapies, or a contraindication to the COVID-19 vaccine class, other than the one that they are receiving, should be monitored for 30 minutes. So basically, we keep these patients at the facility for 15 to 30 minutes. We monitor for side effects, but certain types of prior reactions to vaccines, such as a reaction to polyethylene glycol or polysorbate, if they've had anaphylaxis to either one of those, they should not receive the COVID-19 vaccine. So now let's go back very briefly and review the case. This was the 61-year-old we presented to you at first. She came into the office with severe asthma, requesting a COVID-19 vaccine. She had the history of multiple hospitalizations for treatment of asthma and lupus. And once again, the lupus flares were characterized by joint pain, joint swelling, and rash. She's treated intermittently with prednisone. Her current medications include albuterol, amlodipine, ipratropium bromide, and hydroxychloroquine. She previously had anaphylaxis after treatment with Fasenra, cyclobenzaprine, and the influenza vaccine. So I'll give everybody a second to respond, but which of the following is the best treatment option? Proceed with the COVID-19 vaccine, check antibodies to COVID-19, and administer the vaccine if her levels are low. Discontinue hydroxychloroquine for 3 to 4 weeks and administer the vaccine, or do not administer the vaccine. Solomon, were you able to tabulate the answers?
Oh, we didn't program your question.
Oh, you didn't program the question. All right. So let's discuss this. The answer to this question is do not administer the vaccine. And the reason is, point one, just some things to keep in mind. This is an immunocompromised host. In general, that would make us more likely to administer the COVID-19 vaccine. The problem is, and while we might check antibodies anyway, she can't receive the vaccine because she had profound anaphylaxis when she received the influenza vaccine, which required hospitalization. In addition, she's already on steroids. I also want to point out hydroxychloroquine, which we use routinely to manage our lupus patients, does not suppress the immune system and would never need to be discontinued. So this is just to remind you, the patients who are allergic to either polysorbate or polyethylene glycol cannot receive the COVID-19 vaccine. Now, case 2 is the one we discussed earlier. This is a 63-year-old woman with long-standing rheumatoid arthritis, also a patient of mine, with fibromyalgia and osteoporosis. And her question was, should she have the COVID-19 vaccine? She has severe polyarthritis and failed multiple treatments, including Enbrel, Humira, Orencia, and Actemra. For this reason, she was treated with rituximab with improvement. She denies joint swelling, rash, stiffness, morning stiffness, or fatigue. The question was, which was the best option? A, administer the bivalent 2-dose messenger RNA COVID vaccine 4 to 8 weeks apart. B, administer a 3-dose primary messenger RNA COVID-19 vaccine as the 3-dose primary. C, discontinue rituximab. Or D, do not give the vaccine because she is immunocompromised. And so what I will tell you about this, the answer is to try the 3-dose primary vaccine. Now, she could get the bivalent 2-dose vaccine, but may not mount the appropriate antibody response because she's already being treated with rituximab, which may impair her ability
I think we were cut off, Adrienne.
Yeah, I think Dr. Adrian might have lost our connection or something. So
So we are back now.
No, she's not. She just, her connection is lost. She might be trying to log back in.
So I think we need to, well, we're gonna need to go to our question and answer session with only 10 minutes to go, 9 minutes now.
You do have some questions in the Q&A box. That
Yes, we need to go to those, Solomon.
Yeah, we can move ahead and just go to that.
Yes. Let me see what, so let me, what the question and answers, I guess, are they for, yeah, one of them said, okay, I'm not sure. Say good, that was to Dr. Hosley. I see Dr. Young says, is Paxlovid administration to immunocompromised patient contraindicated? And I would say no, it's not. I don't know any reason somehow, but I'd like to get my infectious disease colleague Leon to weigh in on that as well. Got another one. Why do some patients experience COVID positively following Paxlovid treatment? That I'm not sure. I'll have to refer that to my infectious disease colleagues. I wasn't aware of that. Is Dr. Young, can you tell me what experience you have had with that? The other one is, Dr. Trail, what are your recommendations for Novavax patients who are allergic to PEG and ingredient in mRNA COVID vaccines are being routed to Novavax? Okay, I've done a lot of research on polyethylene glycol. I spent the whole year looking at that, and we did not think it was allergic for a long time, but I was involved with another drug trial where we brought the drug that came to market, and patients did get allergies to PEG, and it did affect. As long as you get allergy to PEG, it's not severe. It doesn't mean it affected the antibody titer to the virus. So it depends on what kind of reaction they got to PEG. They got antibodies to PEG, may affect the titer, and that's, I think, when the co-protective assay technique came out that just the FDA approved, will help us answer that question. And I don't have an answer yet, and I'd like to see how that works. Someone had sent an email to Dr. Hosley. Can you post schedule in an email? I'm not able to copy it from the chat and would like to be able to follow it. I'm not sure what that was. I think that's all the questions that I see. Adrienne, do you have any comments? I see you are muted. There you go. Yeah. You have any comments on those?
No, I think a couple of things. It's very challenging in the setting we're in to monitor our patients closely enough. So when we actually get to make contact, we want to be sure that we've identified the patient at risk, and whenever possible, encourage them to get the vaccine. The problem with our patients is that many of them are immunocompromised. And so this might be a setting where we want to check an antibody level to see how they responded to the vaccine when it's administered.
I totally agree with that. And I'll give an example of a patient I had when she first got the vaccine. I followed her titers for 4 months and she did not have any. And then I did it later, a month later, her titers came up. She had about like 2,000. Very interesting, isn't it?
Yeah.
Yeah. So I think primarily, if it was me, if I had a chance, I would follow titers. At least
Well,
it's, yeah,
yeah,
if you
I
had
do
the
too.
ability to.
Yeah, in our patients, I do too, and it can also provide guidance about when it might be time to give another booster. So I definitely.
Right. You may need a booster earlier. That's right.
Right.
That's right. And I'm one on myself. I followed myself. I did not get a good response initially, and I should have had a booster within 2 months.
Yeah.
I should have gotten a booster. Yeah. I see that there are more questions. My colleague telling me. Let's see. That's well. I have an MD2 student at Morehouse School of Medicine that wants to be a rheumatologist. Can you network with her? Also, I would be happy to. Tell her, give my email, tradewelle@ecu.edu. I'd love to. I love to mentor. Is there, I got the cross activities, some others, let's see. Dr. Fogg, Adrienne, there's a question for you. Regarding case number 1, if that patient contracted COVID, what would you use to treat the COVID infection given her allergies to PEG and polysorbate? I think that went to you. I may have tried to answer that. I think that went to you. Adrienne. Adrienne, can you respond to that?
Yeah, that's a very good and complex question. This is a patient because of her respiratory problems, long-standing asthma, multiple hospitalizations. We would probably bring her in the hospital and assess her depending on her progress as to whether Paxlovid would be enough. That may not work in her setting because she is in the hospital at least once or twice a year. So this is a lady that if she turned positive, I would send her directly to the emergency department.
One of my colleagues, Dr. Yvonne Sherb, rheumatologist, immunologist in Fort Lauderdale, Florida, just put in a question, said, do you think natural immunity is effective as vaccine immunity? If so, why is chicken levels not sufficient to determine whether vaccine is needed? Natural immunity is your, normally comes from your innate immunity. That's your innate immunity. So there are 2 different types of immunity I just mentioned earlier. So you need both of them, and either one of them may protect you, and you don't know. So your T cell immunity, that is when you first get the virus, whether you're vaccinated or not, your body tried to protect you, and obviously it doesn't enough. So you need antibodies from vaccinations and either exposure to the virus. Then your body can make antibodies, later on. So you need both types of immunities. So no one, you need all you can get. You need your innate immunity, and you need also your immunity that you get when you're vaccinated. So you need both. Either you get the infection and you get immunity for a while, but you need, even though you get the infection, you need to be vaccinated within 2 months from that. Yeah. So you need both. Adrienne, you may want to key in on that as well, if you like to.
Well, I think that you're highlighting one of the major challenges that we face in rheumatology because our patients have compromised immunity at both levels, and that makes it harder to contain an infection once it starts. So early diagnosis and aggressive treatment is imperative in patients with autoimmune disease.
Now, one of the comments I may make, just because a patient is on immunosuppressive agents, a lot of them still make antibodies. Most of them still make good antibodies. I think the most risk medication is rituximab. That's the biggest one. But some patients' immune system will tank even one dose of a biologic. So, but it's not that common. Uh, so, so if you want to follow the IgG levels, that's a good one as well. IgG and IgA, but IgG is the main one. You want to do that.
Well, and I might add to that, and you're correct. Case I presented, case two, the lady who finally responded to rituximab, the very first thing they did when she was admitted is load her with antibodies. That's what they aggressively did. So you're right about that.
Adrian, I think you have a question. You said the number one question. I'm not sure what, I don't see that question. Dr. Hosley thought there was one for you. Let's see, Dr. Ken said there is cross-reactivity between PEG and polysorbate as they are similar structures. Yeah, it may be cross-reactivity with that. When I studied polysorbate, I didn't study polysorbate. I did all the different variants of PEG. PEG has about 8 different, at least, structures, molecular weights. So I'm sure there's one they use in the vaccine. So I may have looked at polysorbate. I have to go back and look at my data. It's been some while ago since I did all those studies. Trying to see the question that Dr. Hosley just put up. It kind of went away on me. She made a comment. Yeah, I was reading it and it went away on me. Said Dr. Hammer, Dr. Falls, regarding case one, if that patient contracted COVID, what would you use to, and then it just stopped there. I guess what you use to treat.
Well, the problem with case one, and let's go back up here just very briefly, because of her multiple hospitalizations for asthma, and I was purposely vague, she has compromised respiratory function to begin with. So in this case, if she developed COVID, I would admit her for a few days. And depending upon what happened in the hospital, she might be able to be managed with Paxlovid, but she may need more treatment. It's not clear. It's not clear to me. Certainly they will give her COVID antibodies. This is someone who belongs in the hospital if she's diagnosed with COVID. This is not a patient that we should manage in the outpatient setting.
I agree. 100% agree. Well, thank you everyone very much for coming and joining us. And I hope you are able to take some of these recommendations and hopefully it'll help you in managing your patients. And again, let's encourage them to mask and do all the other good things. And along with the vaccination, I think our patients would be more protected. And I hope everyone have a blessed day.
We do. Thank you.
Please let me know when it's time to start.
You can start, Dr. Mitchell.
Oh, thank you very much. So thanks to the group for inviting me to participate in this program. Certainly with COVID on cancer patients, there is a lot of information and things that we have to be very careful about. I am very appreciative to the organizers of this program and the National Medical Association for the opportunity to participate. I'm Dr. Edith Peterson Mitchell, and I'm Professor of Medicine and Medical Oncology at Thomas Jefferson University in Philadelphia, where I am one of the associate directors of the Sidney Kimmel Cancer Center, where I direct the Center to Eliminate Cancer Disparities. And I'm Vice President for Community Services for Jefferson Health System. Nationally, I served on the Cancer Moonshot Committee during the Obama-Biden presidency and vice presidency, where Vice President Biden was in charge of the Cancer Moonshot. It was a great opportunity. And now that he is president, he has indicated that we need to reimagine the Cancer Moonshot and that we should decrease by 50% the cancer mortality rates in the country over a 25-year period. And plans have been outlined for that. I am currently on the Council of Councils for the National Institutes of Health over all of the institutes. And I'm just finishing a 3.5-year work on the President's Cancer Panel, and we'll discuss some of those things. I have no disclosures, and I would also invite all of the experts that have presented over this 2-day period, as I am editor-in-chief of the Journal of the National Medical Association, to submit some of these great presentations as manuscripts for potential publication in the Journal of the National Medical Association. So what I will talk about today is the COVID-19 virus and cancer patients and assessing the effect on cancer screening and treatment. Because cancer screening and treatment decreased significantly as a result of COVID-19, there has been an uptake in cancer mortality rates. So we need to address that again. I will talk about closing the gaps in cancer screening that was based on data from COVID-19. So the President's Cancer Panel established a review of the cancer increased rates and decreased screening rates as a result of COVID. And this was established by the President's Cancer Panel, which I mentioned I'm just in the process of finishing a 3.5-year program. So this information that I will present was from data collected by the President's Cancer Panel and the 3 members here that I have identified, Dr. John Williams, Dr. Edith Mitchell, and Mr. Robert Ingram. Now, the President's Cancer Panel was established as a part of the Cancer Act of 1971. And here we have then President Nixon signing that enactment by the Congress. And since that time, there has been a decrease each year in cancer mortality rates, not only in the overall country, but in minority populations as well. At the initiation of the SEER data by this National Cancer Act of 1971, initially there was collection of data on two populations, Caucasians in this country and African American patients. Starting about 2000, the year 2000, there was collection of other racial and ethnic minority groups, and consequently a broader understanding of cancer mortality rates in this country. Screening for cancer is incomplete and uneven even prior to COVID. And notice on this chart here that there is greater uptake for cervical cancer screening. Second is for breast cancer screening. Third is colorectal cancer screening. And look at the bottom of the screen where there is information on lung cancer screening. These are the 4 cancers for which the National Cancer Institute has follow-up data showing that screening does result in a decrease in the death rates. So cervical cancer, breast cancer, colorectal cancer, and lung cancer. Note that there is less uptake of lung cancer screening than for any other, and it is at the bottom of the totem pole in terms of benefits from screening and also uptake of screening by clinicians for their patients. So there have been significant gaps between recommended cancer screening and uptake and lack of timely follow-up after an abnormal test result. And this is what allows for a decrease in the cancer death rates. That is appropriate screening and then appropriate and timely follow-up after there has been an abnormal test results. So who is affected by the lack of uptake of screening or follow-up? Many communities of color, African Americans represent the population where there is less evidence of screening and less uptake and follow-up and appropriate treatment after an abnormal test, no matter what the cancer type is. They're socially and economically disadvantaged populations, redlining, where there are no screening institutions within a distance of where patients live. There is low educational achievement, so understanding the reasons for screening, how to screen, and how to follow up. And then there are other residents problems, rural areas where there is a lack of institutions and clinicians to provide those services, and also in center city and urban areas where there is a lack of institutions, a lack of clinicians, and therefore a lack of screening for cancer. There are other barriers such as lack of awareness or understanding of what screening means, lack of provider recommendations such that many individuals don't have clinician providers with whom they have good relationships. So there is poor recommendations. There are logistical challenges in that many patients may not have the ability or the opportunity to take off work to undergo these tests. There's the fear and stigma of getting the test done and the cost in that individuals may not have insurance coverage for the testing, may not have an understanding of how to follow up with cost situations or presenting the information for their insurance plans. So there are many reasons why there's poor uptake of cancer screening, and this was prior to COVID. And now I'll talk about some of the things that occurred with screening after COVID. So at one point, there was a 90% reduction of cancer screenings. Many institutions ended their outpatient centers and focused on inpatient services because of the number of patients presenting that required inpatient care. And that was one reason. Another was many patients were afraid of getting COVID if they attended any outpatient services and outpatient care. So there were many reasons allowing for a 90% reduction in cancer screening. And what that meant, what that meant was that we were not testing patients for these cancer screens that we knew were beneficial in terms of decreasing cancer mortality. So there was a long-term impact of missed or either delayed screenings, and we believe that will result in increased morbidity and mortality from cancer. So that instead of our 50-year from the National Cancer Act, where there was a continuous decline in cancer mortality rates, there is a concern of increased mortality because of the lack of screening. So we brought together, meaning the President's Cancer Panel with the National Cancer Institute, brought together, starting in the fall of 2020, a public meeting series focused on barriers and opportunities to breast, cervical, colorectal, and lung cancer screening. And then in the winter of 2021, we began writing our innovations in cancer screening. Now, I'll tell you about one of my patients where we were able to show that screening mattered. This was a 45-year-old woman who continued her meetings with her GYN physician after the birth of her children. And there was an abnormality on the cervical cancer screening. The GYN doctor produced the recommendations. She underwent therapy, and therefore the GYN problem was eliminated. But the GYN physician said to the patient, "You've got this taken care of. Why don't you get your mammogram and colonoscopy done?" So that they were accomplished. The mammogram was normal and showed no abnormalities. And the patient underwent colonoscopy. An early colon cancer was found. It was surgically removed. And with the CT scan as a part of the colorectal cancer screen and surveillance after a diagnosis of colon cancer, there was a mass found in the left lung. And the patient underwent evaluation and was told that she had stage 4 colon cancer. And she was being prepared to begin therapy for stage 4 colon cancer. I was consulted, and with the radiologist, we determined that this area of the lung was not a common area of metastasis for colon cancer, and it was an early colon cancer. So in discussing with the patient, she had a long history of smoking and met the criteria for lung cancer screening. And she subsequently was found to have an early lung cancer. It was surgically removed, and therefore, with the various physicians participating, we showed that she had been cured of all of those cancers, and therefore met the criteria for lung cancer screening as well. And what that brought to our attention was that we really needed to form relationships where all physicians seeing the patients could recommend as appropriately needed evaluation and screening for all of the cancers that the patient was at risk for. And I will talk about that now. So when we look at on your left, the disproportionate burden of cancers, hospitalizations, and deaths of racial and ethnic populations, what you see is that for some racial and ethnic populations, such as Black or African American, have higher incidence of cancer death rates when compared to others in the country. Same is true for American Indians and Alaska Natives also. So therefore, and for the Hispanic population, overall, there is a higher incidence of cancer death rates in these communities. But what we see during the COVID timeframe was patients did not come in for their cancer evaluations and treatments. These are individuals who had known cancer. And consequently, for patient cancer encounters after COVID, there was a substantial decrease in cancer encounters, whether they were for surveillance or therapeutic interventions. Consequently, the National Cancer Institute on your right and in the light blue have predicted that as a result of COVID, within 3 years, there would begin to be an increase in cancer incidence rates as well as cancer mortality rates as a result of decreases in screening and decreases in therapeutic interventions as a result of COVID. Now, some of these, as I mentioned, were decreases in outpatient centers and a focus on inpatient care, which was necessary for COVID patients. And the other, many patients just did not want to come in for fear of contacting COVID. So we had these problems. So as a result of that, there were some things that we proposed as a result of the President's Cancer Panel, what clinicians needed to know about COVID and cancer. So what do we need to know? So there was a study done from March of 2020 until October of 2021, utilizing national death certificate data, and the National Cancer Institute sponsored this study. And it was shown that COVID-19 accounted for 1 in 8 deaths, or approximately 350,000 deaths in the United States between March of 2020 and October of 2021. Heart disease was the #1 cause of death. Cancer was still the second leading cause of death. Accidents were the 4th cause, strokes the 5th, and COVID as #3. In every age group 15 years and older, COVID-19 was one of the top 5 causes of death during this period. And this was published in the journal JAMA. So to summarize that, what we have is, according to the National Cancer Institute, the leading cause of death in the United States between March of one of the leading causes was COVID-19. And based on an analysis of national death certificates during the study, COVID-19 accounted for 1 in 8 deaths in the United States, or 350,000. So a major cause of death. But in addition to that, deaths from other causes, including heart disease, strokes, and diabetes, also increased during this time, and perhaps related to the fact that many patients did not come in, or there was no access to care because of the decrease in healthcare delivery because of COVID and many offices actually closing. So therefore, there was a recommendation that, first of all, individuals who may be at higher risk of COVID-19 infection, including hypertension, diabetes, cancer, and others, should follow the CDC guidelines very carefully to reduce the risk of COVID-19 infection and to reduce the risk of long-term complications. So therefore, there was the recommendation that practicing clinicians, no matter what the specialty or subspecialty, should follow CDC guidelines, understand them, and know the changes that occur as a result of COVID, so that we can decrease the risk of COVID infections for our patients, and also to make sure that we maximize the opportunities for prevention of infection, but also for therapeutic interventions for those patients who have been identified with COVID. I won't go into those details because we've heard a lot from the other participants in this great conference on what are the therapies and how they can be instituted. But the importance of all practicing clinicians to understand the CDC guidelines, to know the CDC guidelines, and to know when there are changes so that we can provide the right information to the right patient at the right time. So the challenge is for everybody to understand COVID prevention, treatment, and how to connect with other practitioners, infectious diseases, or others, rheumatology, on the complications. So therefore, we all need to get involved. We all need to work together as a result of COVID infection in our communities, and especially on affecting cancer screening, cancer therapeutic interventions, so that we can continue the decline in cancer mortality rates that has been there since the institution of the National Cancer Act in 1971. So vaccines. Clinicians should carefully follow updated versions of the recommendations receiving vaccines and subsequent boosters. Again, I won't discuss so much of the specific recommendations because they do change with time. And it's so important for us to know those changes so that we can give patients the right information, and especially those patients on cancer treatment or have other therapeutic comorbid conditions with cancer, so that we can therefore give patients the best. So vaccines, very important, and mask. Now, you've heard from others regarding mask, and from the oncology world, we recommend that patients still utilize mask and to make decisions about mask. So mask mandates have been lifted in many situations, and that doesn't mean mask riddance and the total elimination of mask. I was wearing a mask recently, and my son-in-law said to me, "You're still wearing your mask?" I said, "Yes." "Am I the only person in this room wearing a mask?" And he says, "I think so." But you still have to decide when and where to wear a mask. And what I say is individuals must decide for themselves how to utilize COVID-19 prevention, precaution, and strategies, and including when and where to wear a mask. And I tell my patients, one should consider wearing a mask in public indoor situations, especially in crowded events, and as always, following recommendations from the healthcare team. And I don't know about others, but I insist that patients wear masks in my office. It's certainly a closed situation in the waiting room, in patient care areas, and in patient evaluation areas. So wearing a mask is still very important. For patient decisions, a lack of mandates in many public situations leave cancer patients who may be suffering from other chronic diseases, who may be on therapeutic regimen where there is a decrease in the white blood cell count or other measures that may put the patients at high risk. And it's very important in recognizing that cancers occur more frequently in the over 65 population, and therefore for geriatric patients, there may be increased risk. So it's up to the clinicians to recommend to their patients when they might consider wearing masks, even if the public mandates have been eliminated. And therefore, we have to tell our patients. So this is another area where clinicians can be very important in the protective measures from patients, because most patients listen to their physicians who offer and who provide chronic and long-term care, and they will believe you. It's trustworthy, and we have established that trustworthiness, and consequently, we need to make sure that we are recommending to patients. Also, it's important that we recommend to patients screening. And I say that not just for the primary care physicians to recommend screening, but for specialists and subspecialists also recommend screening to the patients for the appropriate cancers. Another thing that patients will believe in their physicians about, and that is regarding the risk of hospitalization due to COVID, the risk of long-term COVID effects that can persist following the acute illness and symptoms, and make sure we are telling patients about these so that we can enhance the protective effects and can enhance the screening and evaluation for cancers that the patients are at risk for. And because of the pulmonary effects of COVID-19, it's also important for us to include the risk of lung cancer, and therefore can advise patients. Understanding vaccines, it's very important for us to understand the vaccines, and the booster vaccine doses are very important, and therefore advise the patients to continue and make sure that they receive the appropriate vaccines and booster vaccines for prevention of COVID-19. And while the patients may say you can still get COVID after vaccines, but remind them that there is a substantial decrease in required hospitalizations and the severity of COVID-19 after the vaccine treatment, and that we continue to follow up with patients. They will also ask if you had the Pfizer or the Moderna, can you get the other? And yes, for the boosters, there can be a mix and match, meaning that if someone received the initial Pfizer group that they could receive boosters from the other. So there can be mix and match, and they don't have to shop for the exact same manufacturing group for the booster doses. So understanding those vaccines, and I can tell you patients ask all the time. So in summary, COVID-19, it's still present in our communities, and physicians and the healthcare team need to maintain currency with CDC guidelines and recommendation in the care of our patients, and making sure that we are able to give the patients the right recommendations. Now, what about the future? Well, first thing is to remember and tell our patients that COVID is not gone. There are still patients dying of COVID in the United States every day, and that there are variants that are becoming very prominent, and a more transmissible variant has taken over in the United States. And I guess I left since Thanksgiving here, and that is the XBB 1.5, which is rapidly spreading in the country. The vaccines do offer some protection, but reminding patients that COVID is not over. It has not been totally eradicated in the country, and therefore we need to protect. So advising patients regarding getting vaccinated and boosted, advising patients and families regarding avoiding crowded and poorly ventilated places, and providing medical care, seeking medical care, and getting that medical care early if they have symptoms of COVID. So side effects, you've heard a lot about side effects today. And for cancer patients, there is certainly pain at the injection site, tiredness, muscle pain, headaches, chills, joint pain, and fever. And side effects can be expected, but they're usually over in 3 days. And they are not more highly represented in the cancer patients as in other patients. There is one rare side effect of the second shot of COVID vaccines that I want to indicate to physicians and other clinicians, and that is the prominence of axillary lymph nodes on the side of the injection. And these could be mistaken as a sign of progressive metastatic disease in patients, or newly found breast cancer or other cancers on the side of the injection. These usually decrease after about a month, and I recommend to clinicians not to assume that this is progressive metastatic disease. It is a common finding in the axilla on the side of the injection. Now, because of this unusual side effect, if patients do not have cancer and who are receiving a screening mammogram, unless there is an urgency to wait for that mammogram at least a month following a COVID-19 vaccine. It can cause tremendous anxiety in the patient with no cancer who receives a message that there is a possibility of malignancy and other diagnostic intervention is needed that can cause tremendous anxiety. So if the patient has no evidence of cancer and there is no reason to suspect cancer, delay the mammogram for at least a month following a COVID injection. Safety, we are asked frequently if the COVID vaccines are safe for patients. And these are not live vaccines. They may be given during or after cancer treatment. Now, there may be some cancers where specific recognition and specific recommendations might be needed. And that would be for patients with acute leukemias or who have chronic low white cell counts after cancer treatment. So with that, we need to speak with a cancer specialist in that area of malignancy regarding recommendations for vaccines and therapeutic interventions for COVID-19. But again, it's staying up to date with CDC recommendations and making sure we approach and include the cancer specialists in that area of malignancy. And other prevention may be required. I encourage all clinicians to review the CDC and updates frequently to maintain currency with therapeutic recommendations as well as the prevention. And for individuals having tested positive for COVID-19 or who have symptoms of COVID-19, evaluate as early as possible to maximize long-term outcomes and therapeutic interventions for patients. So again, I've explained the fact that there has been a decline in screening, a decline in patients seeking cancer care, closing of many treatment centers with institutional focus on taking care of cancer patients. We are now back to where those centers are becoming more functional and are reopening, but still for redlining and cancer treatment centers, there is still a lack of them in relationship to where patients live. And therefore, we need to ask our institutions to maximize those opportunities in the community. What we've done at Jefferson is maximized all of our community hospital resources. We have a van that goes through to these diagnostic deserts. And on days during the week, we offer mammograms and other screenings. And then on weekends, we also do the same. And in order to close the gaps in cancer screening as a result of COVID, we need to improve and align our communications, both with our patients as well as with our colleagues. We need to facilitate equitable access, provide and fund community-oriented outreach and support, increase access to patients obtaining screening tests. We need to strengthen our workforce collaborations so that the clinician or nurse practitioner is not the only one the only ones available to talk with patients. Other individuals in the office, even the front desk can maintain information for patients so that we are maximizing utility of office personnel. So what do I mean by that? Develop effective communications that can reach all populations and utilize other office staff to pass out information for patients on screening for cancer. We can also leverage the National Cancer Institute or the National Cancer Roundtables so that we have the utility of the cancer. I say breast because I'm on the breast cancer roundtable, but get the information on screening, provide that to office personnel, and they can therefore increase the information on screening for breast, cervical, colorectal, and lung cancer. And therefore, we can maximally get the information to our patients. We don't have to have the physician or nurse practitioner give out all of the information. Other office personnel can be high touch in reaching the underscreened population. There are also community health workers and others who can be a part of that. And what it does is build relationships with the community, provide information, and we can thus provide information on COVID recommendations, screening and follow-up cancer care, identification of what the barriers are in the individual communities, and therefore we can maximize our opportunities for having patients participate in COVID vaccines, COVID information, and coordinate care. Each community is different, and therefore our physicians and clinical staff will need to provide this information based on their own community. But if we focus on COVID-19 information and prevention, cancer screening, we can all impact those entities that relate to prevention of COVID-19, including vaccines and other prevention modalities. Strengthen our workforce collaborations. We've got to make sure that we maintain communications from the specialist to the primary care provider, because sometimes in situations it is assumed that there's communication, but there's not. So we want to make sure that there is communications between the specialists, recommendations for interventions, such that, for example, if a patient develops symptoms that might be consistent with COVID-19 infection, and therefore the specialist and primary care provider should communicate with each other, because as we discussed earlier, with cancer treatment or some of the other chronic disease management specialists, we should not assume that the primary care provider is the one recommending for vaccines or responding to information from patients. Wherever that information comes in, we've got to make sure there is a response to that, and that our supportive services, supportive policies, our education and training, all teaches our providers, whether it's the medical assistant or whoever gets information, that if a patient either with cancer or other chronic conditions, that they have the ability to call the patient and to get them in. So that we've got to make sure that we have all of the appropriate things for patients. We have the testing and the preventive genetic testing or genomic testing to maximize opportunities for patients. And then we've got to make sure that we are utilizing effective healthcare information technology, and we can reach other clinicians. How many times have we seen a patient who needed something and you couldn't get to the other system where they may have had services, preventions, x-rays, and so forth done. And we've got to work together to close the gap between access, communications, and implementations. And by working together to make sure that we are maximizing the information regarding COVID, maximizing screening, and all clinicians don't assume that the primary care physicians are doing the screening recommendations, because the patients may not even go to the primary care physician if they are being treated or evaluated by another specialist, a subspecialist, and therefore our panel and publication recommended 4 goals: improve and align communications, facilitate equitable access for patients, strengthen workforce collaboration so that we are all working together to care for the patients. And our report can be accessed on President's Cancer Panel .gov at cancer.gov, and therefore you can obtain hard copies if you leave your address at this email address. You can get a hard copy, but you can access the report and download it very easily. So with that, I thank you so much. You can, as I mentioned before, the report was released Wednesday, February the 2nd, 2022, and it is online. And thank you very much. And thanks to the NMA and the organizers of this program, and to the organizers, I'm happy to answer any questions.
To make sure there are some questions in the Q&A box. If you check at the bottom of your Zoom, you see the Q&A.
Okay, so I have here Marie Young. Oh, thank you so much for recognizing that Jefferson released my or unveiled my portrait about 6 weeks ago. I guess that wasn't a question, but there was a request to answer it. Dr. Shelton, again, there is a congratulations on Jefferson unveiling my portrait about 6 weeks ago. And it turns out I was the first African-American professor to have my portrait released. Thank you for putting that in the chat. And again, Dr. Shelton, thank you. You did request an answer. I have from Dr. Young now. Can you share thoughts on American Cancer Society Black Volunteer Caucus, whose goal is to ensure inclusion and involvement in the Black community? And yes, the American Cancer Society has the roundtables, which I participate in, the colorectal roundtable, the lung cancer roundtable, the breast cancer roundtable, and whatever else the American Cancer Society invites me to participate in. And having volunteers in the community, I think is very important. But what I have recommended is that for physicians, whether you're in practice, in private practice, or community practice, or a health system practice, wherever, I think we should find ways to pay these community experts. They are very good. They understand the community, and they can really be an extension of our practice because they know the community, they know people in the community, and they can therefore extend our efforts regarding COVID prevention, getting patients to the hospital for treatment as necessary, getting patients to undergo vaccine receipt. So I think we should all propose to our healthcare systems, whatever the system is, wherever you admit patients, these hospital systems should be a part of what we do in the community and should find resources to pay the Black volunteer community workers, because they can certainly influence the community on the resources that are available from that healthcare system. So I hope everybody will join me in singing in the choir, that these should not be Black volunteers, they should be Black paid healthcare workers. And I hope we can spread that information. This is our community, and it is up to clinicians in the community to relay to the healthcare system what the community needs are. So everybody help me join the choir in singing this song to pay the Black volunteers in our community. Next, I have Dr. Hamner. Dr. Mitchell, regarding axillary lymphadenopathy following receipt of COVID-19 vaccine, have you seen bilateral axillary lymphadenopathy? I have not seen bilateral adenopathy, nor have I seen it reported. It's usually due to the local reaction on the ipsilateral side of the COVID-19 injection. It's usually also after the second, not so much the first. So think about that as you order the vaccine for individuals. And if the individuals have no cancer, are not at high risk, ask them to delay the mammogram for about a month or so if there are no potential consequences of delay of the mammogram. Next question. Breast cancer, it is recommended to avoid injections in the arm on the affected side following node dissection. Is this avoidance recommended perpetually? No, it's not recommended perpetually. And the incidence rate of lymph node dissection for cancer therapy has decreased tremendously. And patients usually undergo a diagnostic test to determine if there's high risk of lymph nodes, and therefore the lymph node dissections and the consequences as far as side effects of lymph node dissection are thus avoided. So it is not a universal recommendation, but it's a good thought to just be complete in terms of evaluation of patients. And I think I'm finishing up right on time. And I have answered the questions to the NMA Internal Medicine co-host. And if there are other things Dr. Borum or others need from me, I'm happy to follow your questions and recommendations. So Dr. Borum, back to you.
Thank you so much, Dr. Mitchell. It's always a pleasure to have you participating and providing your expertise. We are so appreciative of your participating in this conference.
And thank you, Dr. Borum, for being a member of the editorial board for the Journal of the National Medical Association. And again, I'd like to say to other participants in this program that we would like to see some of this great information submitted to the journal as a potential manuscript. So thank you so much for allowing me the opportunity to participate today. Thank you.
Dr. Alana, we can begin with AI.
Hello?
Yes, Dr. Alana, we can begin with AI.
Oh, thank you. I just have to switch my computer. Sorry, this one isn't working. I'll be ready in like 5 minutes. Thank you.
All right, good morning, everyone. I'm so sorry for the delay, but I'm very excited to be here. Right. So honestly, it's been just wonderful to hear all the expert recommendations on promoting the increase of Black community COVID-19 vaccine uptake. My name is Dr. Alana Burnett Stinson. I'm a second-year allergy and immunology fellow at Northwestern University. And today I have the privilege of introducing our speaker, Dr. Nancy Joseph, who will be discussing COVID-19 vaccine uptake from an allergy and immunology perspective. Haitian-born Dr. Nancy Joseph received her Doctor of Osteopathic Medicine from Ohio University Heritage College of Osteopathic Medicine and completed her pediatric residency at Stony Brook Children's Hospital, where she served as a class liaison and curriculum committee member. She completed her allergy and immunology fellowship at University Hospitals Cleveland Medical Center, where she served as a senior chief fellow. She is double board certified in general pediatrics as well as adult and pediatric allergy immunology, but she currently exclusively practices adult and pediatric allergy and immunology. Dr. Joseph is the alumna of past chapter officer of the Student National Medical Association and pastor chapter of Sigma Sigma Phi National Osteopathic Honor Society, of which she remains a member. She is a dedicated member of the National Medical Association and is active in both locally and nationally, and is the current chair of the Allergy, Asthma, and Immunology section of the NMA. Dr. Joseph has written a number of cases, co-authored a book chapter on the epidemiology of allergic diseases, been a guest on several panels, and has given numerous lectures and presentations at academic meetings, both local and national. She was most recently featured on the Doc UR podcast, advocating for mental health for physicians, and on NMA Talks as an expert panelist discussing asthma in African-American community. Dr. Joseph founded the Dynamic Doc, a brand created to inspire and empower others to live a full life on purpose for a purpose. With that being said, take it away, Dr. Joseph.
Thank you so much, Dr. Stinson. So I'm gonna go ahead and share my screen. Let me know if everybody can see that.
We can see it, looks great.
Perfect. So as Dr. Stinson mentioned, I will be talking about COVID-19 and allergic and immunologic diseases. As she said, I'm Nancy Joseph, and we are going to start off actually with some pre-questions that should be populating on your screen. Please let me know in the chat if there's any issues with those questions. And then I also have them in my slide as well.
Dr. Joseph, it looks like the pre-questions the poll is on.
Okay, perfect. And I'll just give you guys a little bit of time to answer those. And then we'll move on with the presentation. All right, and also as I go through the presentation, if you just need a little bit more time to finish, feel free to go ahead and finish up those answers if you're thinking about it a little bit more, but preferably you do it a little bit before we get to the answers in the actual presentation. So let's move forward. So first, we'll just kind of start off with just some COVID-19 review real quick. So coronavirus is actually, well, COVID-19 is from the Coronaviridae family, hence the name coronavirus. And contrary to, coronavirus got all this publicity because of the COVID-19 pandemic. And many think that coronavirus is new and it's, hey, what's going on with this coronavirus? Why is it so virulent? And it's actually, it's not the first coronavirus. It's just a very virulent kind. So coronavirus is also known as a severe acute respiratory syndrome coronavirus, SARS-CoV, and it really emerged in 2002, but COVID-19 or coronavirus 1 was the previous one, but coronavirus 2 emerged in 2019. And of course, that's what we've kind of known now, and that's what we're dealing with the pandemic. And as a lot of people both experience and know, COVID-19 affects predominantly the respiratory system. It can range from mild to severe, and it does affect predominantly birds and mammals. And in general, COVID-19 got so much publicity because of its virulence. And so I don't have a slide in here about virulence, but we'll talk about evasion and why it does what it does, how it does what it does, and why it's notable, why it matters specifically out of all the different coronaviruses. So that's when we get into the COVID-19 and its immunology. And so, viruses in general are, they are codependent. They can't live alone. That's why, when coronavirus, the pandemic, the height of the pandemic, a lot of people were worried. Can I get it through my mail? Can I get it through, everything that's, mailed to me? And that's why, the thought was, after 2 days, it's gone, it's dead. It's because it can't do anything outside of a living host. It needs our bodies, our machinery to live, so it cannot live independently. That's why after a couple of days, whatever was there is just kind of dead caspids. There's not really anything there in terms of outside your surfaces and things like that. And so basically you're just, you may be thinking to yourself, well, if it needs me, well, how can I could just kind of, how is it able to do what it does in our bodies? How is it able to be so virulent, so prominent, such, lead to such a level of a pandemic, with it being so codependent, right? Well, we answer that question. So this is, I have, pictures about this, but the main kind of immunology of viruses is all viruses enter to the body somehow. Coronavirus, enters the body and it attaches to your cells. And then after that, once it gets in, it now has to kind of find the right machinery to replicate itself. So it gets into the native cells, it uses the machinery, it replicates itself and makes a whole bunch. And then after that, your native cells, your cells that it used to replicate itself, doesn't need that anymore. So it basically lyses the cell, kills it, and then it goes on to infect other cells. And this is a very kind of detailed, but if you kind of go with the outline of what was just in the last slide, this is how it does it. First, every cell has little receptors. And so the virus very smartly has these little proteins on the outside just so it can attach to those little receptors. It attaches. I hope everybody can see my mouse. You can see my mouse? Okay. So it attaches, and then your cells, because it attaches to the receptor, there's a whole bunch of different chemical changes that happen. And then that signals the cell's membrane to envelop it. And once it does do that, it goes into the translation. So translation is what we learned a long time ago. Translation happens with proteins. And so the virus protein gets now incorporated into your machinery, right? Because your machinery doesn't really know, yeah, it's a virus or not. It's like, oh, okay, well, this is the thing that's on my agenda to replicate. That's what I'll do. Okay, great. Protein, I'll translate this. It's kind of like a very blind translator. You give it this, it'll translate it. And so the virus knows that, comes in, and it, translates its own proteins. And then now all these viral proteins are made. And now the virus kind of uses its protein because now it's in little parts and proteins, and then kind of makes itself into a whole again, which is what this is showing. So this is specifically for a bacteria, but any host, this is true for. A bacteriophage is simply a virus that's specifically to the bacteria. So basically it attaches, it kind of gives its RNA, right? So a coronavirus specifically is an RNA virus, not a DNA virus, but it enters, gives it its RNA here, and then your cells is like, okay, sure. And then it makes a whole bunch of it, and then it kills your cells by lysing. So that's the nuts and bolts of kind of the immunology of viruses, specifically coronavirus. I actually will go back a little bit about from the beginning to show you this picture. So this picture is important because all of these, it looks so cool, except it's actually so virulent and dangerous at the same time. So all of these little things are the little proteins in the virus that it allows it to do all the things that we just talked about, more specifically the attachment. And so that's what you're seeing here. Just made it into a really cool 3D picture, and it just looks way more visually pleasing. And so, you know, with so many viruses around, coronavirus is not new. The concept of virus is not new. So, well, how does it happen? Like, how does coronavirus? Because, you know, our bodies have fought other viruses. Why can't it fight this one off? And so the answer is, it's all in the trickery of the virus. So what happens is your body makes these things called interferons, and your body has a multitude of defenses, one of which being interferon. So it gets attacked, it makes interferon, and what happens is interferon kind of is a response protein whenever, you know, a virus attacks a cell. But COVID-19 is like, well, I know that. So what I can do is I can decrease that signal. Because what happens is if the signal is either decreased or blunted, then there's less responses to your cell saying, hey, I'm being attacked. And so one important note I want to make here is, you know, we keep hearing, you know, every other day there's a new variant, and a variant is nothing more than a mutated virus. And so basically, you know, your body fights these viruses, and over time, viruses have to learn how to thrive. In so doing, they have to then mutate. And so the mutation can be successful in that it makes the virus more potent, AKA virulent, or it could just not be as successful and the virus remain, you know, it's still fought off by the body effectively. It just so happens that COVID-19 is very virulent, and all its variants have been just as virulent. And so that is the reason why they're so super popular. And so with COVID-19, it inhibits the number of proteins that are a number of proteins that are necessary for the production of these interferons. So that's how it decreases it. There's, again, multitudes of kind of cellular processes that happen that then release interferon. COVID-19 inhibits several of them. So therefore, interferon release is blunted if at all happens. And so that's what happens. Also, your body has pro-inflammatory cells that are made, one of which is cytokines. And so what the immune dysregulating nature of COVID-19 is that, you know, it's pro-inflammatory. So it then stimulates all these, you know, inflammatory cells, and, you know, inflammation is, you know, happens as a response to an infection, but it can be relatively destructive to its environment. It's really kind of like this chaotic cellular thing that happens, necessary at times, but it's kind of more of like a reaction to something. And so COVID-19 is a pro-inflammatory thing in general, and it increases certain types of cytokines. Some cytokines are pro-inflammatory, some otherwise. It specifically increases pro-inflammatory cytokines. And so one of the defense mechanisms we have, aside from the different cells that our body does to help let other cells know, because interferons, the reason for that signal is, hey, okay, maybe this cell will die, but if I can send the signal off to these other cells, they can then be aware that a virus is around and increase their defense mechanisms, which would then keep them from getting infected themselves. And so that's one way of, you know, defense. And obviously vaccination is another form of defense. And what it does is, you know, the vaccine allows your body to see, to be, you know, to know, hey, this is, when you see this, this is an enemy, but without the virulent level that a regular infection would cause. So it challenges your system, but in a healthy way, and it stimulates your workhorses, which is your B cells and T cells, to make these little antibodies, and then that induces protection. And so your antibodies are kind of little, you know, soldiers that recognize that this is an issue. And so if I ever see this again, I know how to respond. I've seen this before. I have these specific antibodies there to recognize COVID-19. And so that's what that's a red star. That's what it's denoting. So you see these little proteins on the outside, like we talked about before. Now, the goal of these antibodies is to keep those proteins from attaching, because what happens is the moment those proteins attach to those receptors, the end, because automatically all of these intracellular processes are going to automatically trigger them. And then now, next thing you know, your virus protein is getting translated, because that's what your machinery is designed to do. And then now you're replicating a virus over and over again. And so these antibodies, these neutralizing antibodies, specifically attach, right? Because they're specifically made. That's why when you get a vaccine, it takes so long. By so long, I mean 2 weeks plus, in order for it to be like effective, right? Because intracellular processes have to then take place in order for these very specific antibodies to form. And so after 2 weeks, so it takes about 2 weeks for that to happen, because T cells have to stimulate B cells, which then make these little antibodies. And so once you get these antibodies attached to these cells, then they can't bind. Now it's like, okay, well, now you can't attach to these cells. Therefore, this little caspid just kind of is now bobbing around, looking to see, hopefully I can get into another cell that, antibodies aren't as effective in that area. Or maybe if I'm not attached to an antibody, hopefully I can get attached to a cell. But it definitely blunts the response. So we will then transition to, COVID-19, and what does that mean for different groups of patients, and what does that mean in terms of why are they at risk, that type of thing. So we'll talk about more immune compromised patients, different types of immune compromised patients. We'll talk about the elderly, and then we'll talk about asthma. We'll spend most of our time on asthma only because there's been a little bit, there's been various research studies and things like that that puts asthma at a different level than it previously thought to be. So let's talk about immune compromised patients. And so as you can imagine, immune compromised patients are immune compromised for a myriad of different reasons. But once you're immune compromised, that means your defenses are down. Once your defenses are down, it allows the virus to then, the things that were keeping me from causing an infection is now gone, or at least blunted. And so I can cause an infection much easier. And so an example of your immune compromised patients. So Dr. Mitchell talked about that, she talked about oncology. So any patients that are receiving, chemo medication, anything that decrease the immune system, anything that attacks the immune system, obviously with the intention of fighting, cancer and various issues. But, a lot of times some people are on immune suppressants, like rituximab, that type of thing, for reasons aside from oncologic reasons. All of those, like people who, patients who have gotten, organ transplant or anti-rejection medication. So one of the jobs of the immune system, of course, is to fight anything that's foreign. And when you get a different organ, that inherently is foreign to the body, and to keep your body from attacking that particular organ, you have to then give an anti-rejection medication. Well, those medications work in general by decreasing your immune system. And so it's helpful because then you don't reject, right, the new organ that you received. But then in general, your immune system is decreased now. And so that makes way for infections to be more likely. And so those populations are definitely at risk. And COVID-19 already being a very smart virus in terms of evasion, it already does a number on healthy patients that have fully functioning immune systems, much less immunocompromised people. And so then that leads us to the elderly. Many may ask, why is it, you've noticed anytime a new vaccine comes out, in terms of the populations that get, approved first to get the vaccine is elderly population. And why that is something called immunosenescence. Basically, over time, you're just much like everywhere else in your body that ain't what it used to be. Your immune system is also ain't what it used to be. So what happens is things just kind of are not as potent, they're not as effective. And so your response to vaccines are not as strong, and your fight against infections are not as good. And so you need all the protection you can get. And so things like the vaccines and things like that, they first are recommended for immune compromised patients, and of course, and also the elderly and that type of thing. In addition, because of all those things I previously mentioned, it also increases your risk of having complications from infections. We often will see, if you remember, in medical training, an elderly patient will come in, maybe altered mental status and that type of thing, and it's like a UTI. Right? When you're 25, you get a urinary tract infection. You may just have, burning during urination, maybe things like that. But then when you're 85, that's a different story. You may have a myriad of symptoms that you may not have had when you were younger, but from the same infection. And it's because you're just more susceptible. There's an increased level of morbidity and mortality just from, your body just not being as good as treating those and taking care of them yourself. And so that's that. So then that leads us to asthma. So real quick word on asthma and kind of more pathophysiology and how asthma works. So asthma is just basically a recurrent obstruction of your airway. And there's lots of inflammation involved in asthma exacerbations, but it is airway inflammation that leads it to being constricted. There's mucus buildup in your airways. And what that looks like in real life is respiratory symptoms, from coughing, shortness of breath, to wheezing, to chest tightness, that type of thing. So in general, your asthma airways are hyperresponsive airways. What makes an asthmatic different from, average, regular individual, you have hyperresponsive airways anyway. So that means that you can get, you're more prone to getting airway obstruction, and the recurrence of that makes you asthmatic. And so over time, with asthma being, if asthma is uncontrolled, you get repeated inflammation. Repeated inflammation then leads over time to a level of remodeling that's irreversible. And so why viruses are very important is because viruses are a very common cause of asthma exacerbations. So that is why COVID-19 virulent, despite its virulence or not, coronavirus in general, all viruses can lead to an asthma exacerbation. So that's what makes it important about asthma. So asthma control is very important. So the last two are points I'm going to kind of dive a little bit deeper into. So let's talk about asthma in the African American populations. After all, this is a presentation by, talking about with in sponsorship with the National Medical Association. And of course, the National Medical Association, we're all about diversity and this health disparities and shining a light on that. So let's take a moment to shine a light on asthma in the African American population. So why it's important: African Americans are 40% more likely to have asthma, and 10.6% of Black non-Hispanic patients, according to the CDC, have asthma. And the rate of asthma-related ED visits is nearly 3 times as high in non-Hispanic Blacks than our white counterparts. And African Americans are 5 times more likely to have asthma-related hospital admissions and 3 times more likely to die of asthma-related causes. So when we talk about asthma, and we specifically talk about asthma in the African American population, these are some of the reasons why it's incredibly important, both not only to talk about it, but to also address it appropriately and also treat it appropriately and arm everyone with the appropriate information, both on risk factors and treatment, including vaccination. So then let's get into asthma and COVID-19 specifically. So in the beginning of COVID-19, we all heard about, asthma and what it meant in terms of increasing the risk. And, the CDC was saying, moderate to severe asthma, that increases your risk of having severe COVID-19 infection and having sequelae from that type of thing. Well, most recently, a lot of studies are showing that that's not the case. A lot of studies are showing that asthmatics are at the same level of a risk of severe infection as the general population. Now, keep in mind though, while I'm saying this, the caveat is any virus, any infection, respiratory infection can flare your asthma. whether you have mild intermittent asthma or severe asthma. Those are just, it's just a common flare, right? However, when we talk about, COVID-19 specifically, the results, many research has shown that one person that's asthmatic, one person that's not asthmatic, the risk of having severe infection, all other things being equal, is not more. It's the same. And so there have been a few studies that talk about how non-allergic asthma may have a slight increase, but the problem with those studies is they don't say, with non-allergic asthma, COPD could be one of those things that's going on with those patients. So it didn't tease out whether, okay, they have non-allergic asthma. Are we talking about ACOS? Are we talking about asthma COPD mix? Did we tease those out? And so that's unclear. So bottom line is, if you talk to the American College of Allergy and Allergy, Asthma and Immunology, or if you're talking about the Quad AI, if you're talking to, experts say, hey, you know what? By and large, these studies say asthma is not, as contrary to what we previously thought, having asthma doesn't increase your risk of having severe infection or having an increase. It doesn't increase your risk, or your rate of infection doesn't increase, and doesn't increase your risk of hospitalization or death or anything like that. And so that's that. However, when we talk about COPD, that's not the same. That remains a risk for more severe disease. It increases the risk, rate of infection, that type of thing. So COPD is still a risk factor, just not asthma. So another thing that came up is steroids. And, in the beginning of the pandemic, there was a lot of talk, okay, wow, if I have COVID-19 infection, right, and I have asthma, well, I usually get treated with steroids. Should I get treated with steroids? What should I do? I don't know. Maybe I shouldn't get steroids, that type of thing. And the short answer, and I'll get a little bit more into detail, but the short answer is risk versus benefit, right? So you have some patient here getting asthma, having an asthma exacerbation. We're talking about severe asthma exacerbation. You treat it like you would treat an asthma exacerbation. If the patient's at the point where they need steroids, they're at the point where they need steroids. And so then they can be given, and again, remember, we're not talking about a month-long steroid. We're not talking about a 3-week-long steroid. We're talking about, a 5 to 10 day, a taper, that type of thing, because the risk is hospitalization. You don't want your asthmatics to get hospitalized. You want to risk the risk of ICU admission, intubation. Getting an asthmatic being intubated is something you want to avoid at all costs, because that leads into a level of complication that we don't want to get into. But in general, the risk versus benefit, that goes along with steroid inhalers. I have some of my patients that were worried, steroids, when we talk about steroids in general, oh my gosh, I'm on steroid inhaler, should I not be? And the answer is take their inhalers, because steroid inhalers, increases your control. Increasing control decreases the risk of exacerbation. Therefore, in general, the risk is much lower, and having these complications, and the benefit is much higher. And so asthma control is the purpose of this particular slide, is incredibly important. And achieving that and maintaining that is incredibly important. And so continue your patients on your inhalers, both whether it's single inhaler or combo inhalers, that type of thing, and treat them accordingly, because controlling their asthma will keep them from the complications that will ensue. Because we want to keep away from that remodeling, because once that airway remodels, you can't get that back. So that leads us to talk about, I'll kind of tie in asthma and eczema too, because we want to touch on what biologics, which is also a concern. And so we talk about eczema in general. Eczema, as eczematous patients, just your skin doesn't retain the moisture like it's supposed to. You get the dryness. Molecularly, eczema is mediated by a certain number of cytokines and interleukins, certain numbers of types of cells. And so most eczema is treated with over-the-counter, creams, topical steroids, that type of thing. But you can get those severe eczema that those things just aren't adequate. And so they may need to be on something called biologics. And biologics really are immune modulators. And so like I said, cytokines and interleukins are, very key in the pathophysiology of eczema. And so what these biologics do, they target those specific cytokines, one of which is Dupixent that you'll hear a lot about. But in general, these immune modulators raised concern. People were thinking, okay, well, if it modulates my immune system, does it then put me at increased risk for getting infection, more specifically a COVID-19 infection? And so there've been research on that because again, we talked about asthma being something that was of concern, risk factors. A lot of asthmatics are on biologics, such as, there are immune cells that also specifically you have different types of asthma. You have neutrophilic asthma, you have allergic asthma, in which, one of the key allergy cells is IgE. And so there's specific biologics that target that. And in so doing, there are immune modulatory. And so again, whether I'm biologic because I have asthma or biologic because of eczema or other things, we're concerned about those. So specifically with eczema, there has been research done that shows that there's no significant risk in patients on biologics. And people were just like, well, should I even get the vaccine? I don't know. And the answer is yes, you should get the vaccine. You should be on the vaccine, or you should get the vaccine. You should still be on your biologics. And so that's kind of the bottom line of the research that's been shown when it comes to biologics, patients on biologics, and whether they should get the vaccine or things like that. So that leads us to talking about, in general, the benefits in allergic and immunologic diseases. And so we talked about how infections are triggers. So, primary prevention, if we talk about just in general, the rules of medicine, the dogmas of medicine and medical treatment, primary prevention is key. And then if we can prevent, we don't have to worry about as much, or we can decrease the sequelae that happen when the diseases do occur. So prevention is best. So avoiding triggers, and of course, if certain triggers happen, appropriate treatment. So virus being one of them. But if we can just, vaccines help prevent infections. Infections are triggers. If we help prevent the infections with vaccines, we can help prevent the triggers, thereby preventing the asthma flares, which could then lead to those things we talked about, especially in the African-American population: increased ED visits, increased hospitalization, increased mortality rates, that type of thing. We talked about boosters, immune compromise, immune deficiencies is important to get those boosters because they restore your protection, right? We talked about immune senescence, think people like immune compromised or the elderly. You get the protection, but again, protection wanes over time. And so that's why a booster is necessary. That's why a booster is needed. We just can't afford, especially with those at-risk populations, to keep that infection as low, when that boost wanes, we have to keep in a good, maintain a good level, because we just can't afford to just be out there unprotected. So protective benefits of vaccines, we talked about how protective they are. We talked about the immunology of them. When we go to molecularly, why they're protected, why they're effective, your immunity does wane, therefore something to boost it is necessary. And so, yeah, and with that, we'll jump into some post questions, which should be popping up on your screen, but I'll also go over them separately. So we'll go to the first one. Dr. Stinson, let me know if they don't populate over on them.
Nothing's populated so far.
Okay, so I'll just go over them separately, and then you guys can answer them in your heads, and then I will go over the right answer. So what family of virus is COVID-19 part of? Because remember, we, at least you can remember your answers, I suppose, from previous, because these are the same questions, except with answers at the end. So I'll give you a couple of minutes to think about it. So it's the Coronaviridae family. And remember that the coronavirus itself is not new. Coronavirus, SARS-CoV-2 is what is new. And by new, of course, we mean now a few years old. But there are several members of the coronavirus 19. Oh yeah, so if what you answered should pop up now on the screen. Are you seeing that?
We're seeing it now.
Okay, perfect. So at least now you don't have to remember, but and then feel free to put questions in the chat in terms of if you have further questions on the questions or the presentation. And then Dr. Stints will kind of help me with that a little bit later. So you can go ahead and type that into the chat, but after we answer these post questions, we'll go over that. So it's the Coronaviridae family. So let's see. So now the next question is, which of the following is not part of the infection process of the virus? Remember, we had a whole, we had the illustrations about that. And because this part's important because it's how coronavirus is coronavirus. So attachment, A, attachment, B, entry, C, replication, or D, protein denaturation. And I'll give you, if you didn't answer or you want to, in your head, change your answer, because I don't think you can change it in here. So I'll give you a couple of minutes. Let's see. All right. All right. Now the right answer is protein denaturation. That's the one that's not part of it. It doesn't denature the protein. It gives the your machinery its proteins to translate, because your machinery just knows this is a protein I need to translate. Hey, this is RNA. I need to translate it into a protein. Great. And so it just gives your machinery that, and your machinery is like, sure, I'll do it. And that's it, but doesn't denature a protein. And also, though COVID-19 targets the release of interferon, which in itself is a protein, it does not denature anything. It decreases the release of that. And the pro-inflammatory cytokines that it induces, it doesn't denature them either. It stimulates the production of them, which then, inflammation can cause quite a bit of tissue destruction in its path. So those are all the protein related things that it does, but denaturation is not one of them. Okay, and the last question is, which of the following is not an at-risk allergic or immunologic patient group? A, elderly. B, a transplant patient on anti-rejection medication. C, a patient receiving chemotherapy. Or D, a patient with severe seasonal allergies. I'll give you a little time. Okay, and the answer is a person with severe seasonal allergies. And I'll actually go into a little bit more detail, because I had a lot of questions in clinic, especially in the beginning of the pandemic, because what had happened is in the beginning, especially about vaccination, in the beginning, the A word was thrown around a lot, the allergy word. And so any of my patients basically thought they couldn't get the vaccine because they had allergies of any kind. And many of my patients were concerned because of their allergic rhinitis or allergic rhinoconjunctivitis or any seasonal allergies. And the answer is your seasonal allergies, though, they're not a risk factor to have worsened disease, nor are they any contraindication to have get the vaccine. In fact, another thing I want to touch on is even people with the allergic reaction to vaccines can still get the vaccine. Number one, it depends on their allergic reaction. One important thing about allergic things is that they're immediate reactions. So a lot of people were coming where the reactions were happening. Let's say I got the vaccine today, a week later I got a rash, and I think it's the vaccine, I'm never going to get it again. And the answer is twofold. One, allergic reactions happen within 4 hours, around 4 hours of that particular trigger for it to have been the trigger. And so a week later is certainly outside of that. And so that is no longer an immediate allergic reaction. Why that's important is because when we talk about, worrying about, anaphylaxis, which obviously is a severe allergic reaction, anaphylaxis is an immediate hypersensitivity reaction. Taking things out, if it's no longer immediate, it then no longer has the risk of anaphylaxis. And therefore that concern can now be debunked, and that's helpful. So we're getting a lot of questions like, I have this rash, I don't know where it's from, but a week ago I did get the COVID-19 vaccine. I don't know if I can get it again. And it's like, yes, you can. So, and even so, there's been research actually coming out of Boston that shows that even people with allergic reactions, classified as allergic reactions, the first dose of the vaccine, many could get the second dose and was fine. So even that is encouraging. And when we talk about vaccines, right, and we want to, we're concentrating on both vaccination and vaccination hesitation, all that stuff. One of the main things of vaccine hesitation is, oh, I think I had a reaction the first time, or my friend had a reaction, I really don't want to have a reaction, that type of thing. Arming our patients with the knowledge that, hey, this occurred days later, therefore it's not an immediate allergic reaction. We're not worried about you having anaphylaxis, that type of thing. I will say patients with that can be pre-treated, meaning take Zyrtec beforehand. If they have something like, hives and things like that, or angioedema, those things can get flared up after you challenge the immune system, because what you're doing with the vaccine is you're helping the immune system does what it do best. And if part of your system and what it does without any stimulation is angioedema or hives, you can flare those with the vaccine. So all you have to do is pre-treat your patient with antihistamine, which is Zyrtec, or anything, Zyrtec, Claritin, that type of thing. You want to do a long-lasting antihistamine. Once you do that, you want to pre-treat them a few days before and a few days after to mitigate or decrease the chance of those things happening.
Oops. Thank you so much, Dr. Joseph. We're still waiting for more questions in the chat, so please feel free if you have any additional questions to send them there. While we're waiting, I had some questions for you as well, Dr. Joseph. So thank you
Perfect.
for talking to us about the vaccine reactions. That's definitely something that I've been seeing in my clinic. I just wanted to see if you could touch on, I think one of the most common ones I hear are, I have an egg allergy in terms of, the flu vaccine. Is that an issue for patients who want to receive the COVID-19 vaccine?
Perfect. Great question. It's actually a very common question. And the answer is no. And so even with, if you have an egg allergy, you can still get the flu vaccine. And by still get the flu vaccine, I mean, you could just go in just like, just as if you didn't have any allergy to egg, and just get the flu vaccine. Same with the COVID-19 vaccine. That is not a contraindication. You don't have to take any extra precautions or anything like that. Just go ahead and get yourself vaccinated, get yourself boosted.
Thank you. And we do have a question in the chat.
Yes.
So this is from Dr. Hamner. So do you pre-medicate your patients who are allergic to PEG and polysorbate to administering the COVID-19 vaccine, which contains these ingredients?
So I guess the first answer to that question is, what are we saying the allergy is? Are we saying that they have an issue with what, like they specifically had testing for PEG? Or are we saying that they think they have an allergy to PEG? Or are we saying they had an allergic reaction to Miralax? Or I guess it kind of depends, because a lot of things are thrown into the category of allergic reactions that aren't. And so the answer to that question kind of highly depends on what that reaction is. Is it an immediate reaction? Is it not? That type of thing.
They're asking, they said a known reaction and confirmed.
Gotcha. Okay. But so when it comes to anaphylaxis reactions, so especially polyethylene glycol, I'm assuming that's what they said, right? There are alternatives now that you can have. You can get a vaccine that does not, there are vaccine options that do not have PEG. So they can certainly get one of those or get vaccinated with that. Because unfortunately, things like the Pfizer vaccine that has PEG as the main ingredient, if you have a confirmed known, anaphylactic reaction to PEG, that is a contraindication.
Yeah. And polysoberate within the Novavax vaccine.
So like I said, there are others. And I don't know. I don't think J&J has either. So that's definitely doesn't have PEG.
Interesting, like I know there's been a lot of studies that have been coming out in terms of that PEG allergy that have shown even with skin testing, it's very
correct,
consistent, and that many people who have this known PEG allergy really aren't allergic to the vaccine as well, and so they have been tolerating it. But I know at least in our clinic, we've been, for those who are really concerned, been giving just small amounts of the vaccine, like in a 2-dose kind of stepwise fashion.
For sure. Absolutely. And you bring a great point, Dr. Stinson. To who, I don't remember, I'm sorry, who asked the question. I'll look in the chat. But okay. So there is an option to send those patients to an immunologist, because what we can do, as Dr. Stinson put it out, we can always do a challenge, a graded challenge. Oftentimes, if we're in that period where we're not sure, we're unsure, we can always do a vaccine challenge, which is an in-office supervised challenge. It should also, Dr. Stenson also brought a great point when it comes to when we talking about confirmed I believe in the earlier days, we're talking about 2021, we were doing skin testing with PEG. But over time, research has been shown that that's not reliable. And so if the person was confirmed to be allergic, but it was by skin testing, we're not even sure, because again, we were at the time, it was such unprecedented, uncharted waters that we were even doing, when even that skin test sometimes had false positives. And so I had patients who had Miralax and been fine, and it tested positive in PEG. And we know that having eaten something or having ingested something is the gold standard to say yes, I'm allergic or no, because with any test there's a risk for false positives. Both that and polysorbate. And so that can always be a false positive, especially those tests could be, depending on how sensitive your skin is, you can definitely have false positives. What other questions? Let's see.
Any other questions?
Let's see. Oh, and Dr. Hamner, in terms of pre-medication, let's say your patient has seasonal allergies and they only have them in the spring or something like that, and there's concern, they can take a Zyrtec, or an antihistamine once a day for the first few days before the vaccine, if there's 3 days after. That's a relatively benign precaution to take.
This was another question that for you, Dr. Joseph. In terms of, I know like in our clinic, sometimes we have patients who are immunocompromised, like CVID or common variable immunodeficiency, and they're wondering if the vaccine would even work in them. Like, what do you say for those patients?
So immunocompromised patients still have an immune system, right? Like it's just not as robust as your typical. So helping the immune system, period, is a great idea, right? You don't want to just be like, well, my immune system doesn't work as good as everyone's, so throw your hands in the air, right? You want to help any way that you can. So that will help. It's just that, it needs all the help it can get is the answer, for sure. So you definitely still, you want to vaccinate those patients, because you don't want to leave it up to their native system, which is already compromised, right? To like fend for itself whenever should it get challenged, because we know it doesn't do well, challenged without any so if we want to give that system as much knowledge as we can, which is what the vaccine does.
All right, I don't see any other questions here, so I think we've answered most of them. Thank you all once again for, let's see. Oh, let me just see if there's another question actually. Hold on one second. Oh, okay, never mind. So thank you all for coming in once again. This was wonderful. I'm, had a great time discussing our, the side of the allergy and immunologist here. And thank you so much, Dr. Joseph. This was a wonderful talk.
Thank you so much. And I'd like to thank the National Medical Association for inviting us, and definitely want to give a shout out to everyone behind the scenes that has been working diligently and to making sure that this happened. This is very important and this is very much needed in our community. Thank you.
Absolutely. Thank you all.
Solomon, are you there?
I'm here. We can begin.
Just tell me when to start.
Yes, you can start.
Okay. Good afternoon, everyone. My name is Dee Banks, Dr. Dee Banks, and I am an infectious disease physician with the Northeast Ohio Infectious Disease Associates in Youngstown, Ohio. Thank you all very much, as we have continued to say today. Thank you so much, so much for joining us today for this important, these 2 days of important symposia on COVID-19. I never would have imagined when I started infectious diseases. This is my 49th year in the practice of medicine, but my 47th year in the practice of infectious diseases since my fellowship. And I never would have imagined that we would be here. I'm working as hard as I've ever worked. When somebody walked up to me when I started my fellowship and said, I don't know why you're going into infectious diseases, because everybody knows how to use penicillin and ampicillin. So here we are. So I want to again thank you all very much for joining us today. We have two wonderful speakers that are going to speak to us today on COVID-19 and updates and vaccine hesitancy. So I think we're going to start now. Solomon, can you bring up the pre-test questions? Okay, I'm going to go through the pre-test questions and then introduce to you our first speaker. Question number 1. Vaccine hesitancy is defined as an intermediate position in the middle of the continuum between the pro-vaccination and anti-vaccination positions. True or false? Single choice. According to research conducted by the African American Research Collaborative and the Commonwealth Fund, which of the following messengers is the most trusted and effective in the campaign to encourage Americans to get vaccinated? Doctors and nurses, A. B, friends and family. C, personal doctor or primary care physician. D, Center for Disease Control and Prevention. Next. Are there more questions, Solomon?
Yeah, just scroll down on your screen.
Oh, sorry about that. Okay, sorry. Question number 3. According to the World Health Organization, vaccine hesitancy is defined as a behavior influenced by several factors, including, again, these are all single choice. A, confidence, complacency, and convenience. B, confidence, culture, and convenience. C, confidence, convenience, and community. Question number 4. Which of the following strategies has been recommended to address vaccine hesitancy? A, build trust, empower healthcare professionals, and correct vaccine misperceptions. B, build trust, empower healthcare professionals, and engage communities and individuals. C, empower healthcare professionals, correct vaccine misperceptions, and acknowledge vaccine safety worries. Question number 5. COVID-19 warning signs that should lead to seek emergency care immediately include all of the following except one answer. Persistent chest pain or pressure, new confusion, pulse oxygenation greater than or equal to 95%, an inability to wake or stay awake. And last, true or false? The United States Black population has the lowest percentage through July 2022 of receiving at least one COVID-19 vaccine dose in comparison to other race ethnicities. True or false? Okay. I'm going to introduce our first speaker today, who's going to be talking to us about the latest COVID update, regarding the pandemic. Dr. Sabrina Kendrick is an infectious disease specialist in Chicago, Illinois, an assistant professor of medicine, Division of Infectious Diseases in the Department of Internal Medicine at Rush Medical School, She is board certified in 2 specialties, internal medicine and infectious diseases, and she is an ID attending at the John Stroger Hospital of Cook County, formerly Cook County Hospital. She deals with a broad array of diseases caused by bacteria and viruses, from flu to hospital-acquired infections to pneumonia. Dr. Kendrick received her medical degree from Chicago Medical School, completed her internal medicine residency at Emory University School of Medicine, and obtained a fellowship in infectious diseases at Northwestern School of Medicine. She has been in the practice for more than 20 years, and she has been a co-principal investigator of CDC-funded research. Her publications include HIV risk, perception, and pre-exposure prophylaxis, interest among a heterosexual population visiting a sexually transmitted infection clinic, and a comparison of lower genital tract glycogen and lactic acid levels in women and macaques. Implications for HIV and SIV susceptibility, macaque monkeys, of course. I introduce to you Dr. Sabrina Kendrick. Dr. Kendrick? You're muted.
Good afternoon, Dr. Banks. Thank you for that introduction. Let me share my slides. Sorry about that. Can you see that?
Yes.
Okay, great. Okay. Well, I am happy to be here today to give the COVID-19 update about the pandemic. These next few slides I put in just to show us how far we have come in this COVID-19 pandemic and how it has affected our lives. Early on in the pandemic, we were seeing our emergency rooms filled to the brim. We were seeing people lining up in their cars to get tested for COVID-19. And then we were also dealing with our homeless population, whether they were on the street or whether they were in shelters. We had to deal with them and how if they got COVID, and how we subsequently had to place them after getting COVID, particularly if they were getting better, but still had circulating, they were viremic. Also, it has affected us as physicians and how we communicate with each other, how we communicate with our patients, as well as how we attend or not attend conferences and doing everything virtually like we are now. And it has also affected our children. We have been, over the past 2 years or so, sending our children to school with masks, and they have done well and endured it in terms of the infections, but they were the last to receive an effective vaccine. So this also affected them tremendously in terms of their learning capacity, but I'm not going to get into that. And that brings us to today, where we are now without masks. There are no mandates for masks, and you can see this is an airport. No one has a mask on. We don't wear a mask anymore. And so just thinking about, as our COVID cases has been rising since the holidays, is where does this leave us, and what's around the corner? So in terms of demographics in the United States, there have been over 100 million cases of COVID and over 1 million deaths. I mean, that is just staggering statistics that we're dealing with just here in the United States. Now, I put this graphic in to point out the daily cases of COVID through December of 2022. We see in February, there were the spike in case of about 800,000 cases in February, and then there was a sharp decline. It reached a plateau, and that plateau has remained through the end of December 2022, when we were seeing about 60,000 cases per day, and that included 6,000 new cases per day. And so it's still around, it hasn't gone anywhere, but we're much better at dealing with it now. We're all too familiar with the COVID symptoms that usually appear 2 to 14 days after exposure to the virus, and they can consist of fever or chills, shortness of breath or difficulty breathing, muscle body aches. A lot of people early on were saying a new loss of taste or smell. Sometimes you may just have nasal congestion or runny nose, and then nausea, vomiting, and diarrhea. But then there are those symptoms that patients may present with that should trigger us to send these patients to the emergency room for further evaluation, such as if they have trouble breathing, if they have persistent pain or pressure in the chest, if there's new confusion or an inability to wake or even stay awake, or parts of their face and lips may have a bluish tinge. That's when we need to think that maybe they may need to go and further evaluate it, because they may be heading toward hospitalization and possibly the intensive care unit. Now, over the past 2.5, 3 years that we've been dealing with COVID, we've come to learn about long COVID symptoms, which usually occur after an infection. These symptoms can be seen in patients who are more commonly symptomatic as well as asymptomatic. They can include such as chronic fatigue syndrome, shortness of breath, joint pain, chest pain, and sometimes some patients may have lasting damage to the heart with an increased risk for heart failure. More long-term effects after COVID could be a fasting or pounding heart rate, brain fog, sleep problems. Some patients have even experienced rash or hair loss. Depression, anxiety, and post-traumatic stress syndrome has also been included with these long-term effects after having COVID infection. I put this graphic in to show the hot spots that we were seeing across the United States in December of 2021. And it shows the deaths per capita, where those states with the dark red had the highest number of deaths rates, and those states in the yellow had the lowest number. And we can see some of the states with higher cases of death rates were in Tennessee, Kentucky, West Virginia, Florida, Southern Texas, Alaska, and several of the Western states. But you may have wondered, so what was going on in December of 2021? That was when the Omicron variant came on the scene and had knocked out the Delta, and patients were coming to the emergency room again in throngs, like not as severe as it was initially, but we were seeing a lot of cases at that time. And then I show United States just a few months later in February, April of 2022, the hotspots, as you can see, again, these are the average daily case rates. And in California is this one state that showed high number of cases, and across the United States, mainly it's in yellow with lower rates of cases of COVID. So what happened between December of 21 and just several months later, it's probably due to a combination of people having natural immunity after having COVID infection. And we know that natural immunity lasts for about up to 3 months. And I think that combined with more patients being vaccinated by April of 2022 led to the decrease or the decline in the number of cases we were seeing at that time in the United States. This graphic shows daily hospital admissions by age. And I think we all know this information throughout the pandemic from in 2020 through the end of December. The majority of the patients who are being hospitalized and affected are those elderly people. And that is depicted in this slide by the top dark blue line for those patients 70 years old, 70 plus years old, in comparison to those younger patients who have less hospital admissions. And that, as I said, continues through the end of December. So this next slide is kind of busy, but it does show that racial and ethnic minorities, when compared to whites, have higher cases of COVID, higher hospitalizations, and higher deaths. These risk markers, and the reason why is because these communities have higher risk markers for underlying conditions that affect their health. And that includes socioeconomic status, their access or lack of access to health care, exposure to the virus related to occupation. For example, many of these patients in these communities are from frontline workers, essential workers, where they have to go to work because they have to make money. There's no way around it. So then they are exposed, they get infected, and then they go back to their home, where many people in these communities are living in multi-generational families, and they are not able to isolate and use because they have one bathroom. And so everyone in the household gets infected with COVID. So let's go on and talk about vaccines and what's going on here in the United States. If we look through December of 2022, 68% of all Americans have been fully vaccinated. And of those that are fully vaccinated, 34% of them have been vaccinated with a booster. Now, if you look at those people who are 65 and older, 93% have been fully vaccinated and 67% with a booster. I think that is a significant improvement in how when we started out, but you'll see later on when I get to other slides that there are certain communities that lag in these vaccination successes. This graphic shows daily case rates for vaccinated and unvaccinated through December of 2022. The average daily cases are 3 times as high in those who are unvaccinated compared to those who are fully vaccinated. As well as if you look at the death rates for those patients who are vaccinated versus unvaccinated through December of 2022, The average daily deaths are 6 times as high in those who are unvaccinated compared to those who are fully vaccinated. So we just have to impress upon our patients how important it is to not only get the vaccine, but get the full series of vaccines that are available. Because I know with my patients, they're like, oh, I've only gotten 1 or 2 of the vaccines, and then they will say, I'm not getting any more. And they think because they're not hearing a lot of deaths and hospitalizations on the news like it was early in the pandemic, that everything is okay. So, but as you'll see in further slides, it's important to get fully vaccinated and impress upon our patients to do this. This slide is kind of busy, but it looks at the rates of COVID deaths by vaccination status. And basically the take-home message from this slide is those people who are vaccinated, 12 and above, who are vaccinated with an updated bivalent booster that recently just came out in October, they are almost 19 times have a lower risk of dying from COVID infection. And this same population of people have been noted to have a 3 times lower risk of testing positive for COVID infection. And this is all in comparison to unvaccinated persons. And so it's more data just to show that our patients should be vaccinated, and we need to impress upon them how this will affect them if they're not vaccinated. I put this slide in to show that Blacks in the United States have the lowest rates of vaccinations in comparison to other race and ethnicities here in the States. As you can see, the bottom line, 59%, is depicts those Blacks who have received the vaccine in comparison to whites above that 64%, and Hispanics above that at 67%. And the Asian community is leading with the highest percent of those who have received at least 1 vaccine dose, and this is through July of 2022. We still have work to do in our community to try to improve that number of 59%. So what's going on in each individual state in terms of COVID-19 patients who are fully vaccinated? And this data is through December of 2022. As you can see, the percent of residents who are fully vaccinated with the highest percentage is that in the dark green. And those states that have the lowest percentage are the salmon color, the light salmon color. And we can see the northeastern states, Virginia, New York, Connecticut, and even Washington, D.C., have the highest percentage of residents who are fully vaccinated. I know in our state, Illinois, my state, I should say, we have a 70% of our residents are fully vaccinated. So as you can see, I wanted to ask, well, how's your state doing? I hope it's in the green. Okay, I put this slide in to show you the coronavirus hotspots in the world and how we're tracking the global outbreak. This slide shows the average daily cases with the higher number of daily cases as we see in Australia with the dark color, and the lighter color, the light yellow, with the lower number of daily cases. The United States falls smack dab right in the middle, where we're in the orange in terms of average daily cases. I find it quite interesting when you look at mainland China, which is here, and they're in the yellow, especially in light of the fact that we have been hearing more recently that they have a COVID outbreak and their cases are increasing. So is it a matter of just information is not leaking out appropriately, or what's going on? So I think it's just a matter of time will tell. So what do you need to know about XBB.1.5? And you may ask, what is that? Well, that is the latest COVID-19 variant to sweep the United States. It comprises about 40% of the current circulating variants. It's a subvariant of Omicron, and it like I said, comprises about 40% of those infections being caused by COVID and in the country. I'm curious, and I looked up to see what was the prevalent circulating virus causing the COVID epidemic in China, and it is not the XBB, as I'll call it from now on throughout the remainder of the presentation. It is, they still have their majority COVID circulating virus is the Omicron variant, I think B5. So when we're talking about even the severe cases of COVID caused by XBB, so far our vaccines are holding against preventing a lot of the cases. But the experts are concerned here in the United States if this becomes a highly prevalent and majority circulating. And so far, I don't know of any information or data to show that the medications that we have for the treatment of inpatient as well as outpatient is diminished with this new variant, but I think time will tell. This picture just shows the emergency room in China, where they're similar to how we were seeing our emergency room with increased cases during early on in the outbreak. The majority of the patients who are affected in China are the elderly, and they have been unvaccinated in those cases. And that's recent, I think, why the United States recently imposed this mandatory COVID test on travelers from China. I'm just interjecting. My opinion is that the concern is that we're seeing increased cases of COVID. We're seeing this new circulating variant, and we don't really know what's going on in terms of the variants, what's going on with China. We do know that they have increased cases, and so that mandate has been in place for about a few weeks now. So this next slide discusses the vaccine effectiveness of 2 versus 3 doses of mRNA vaccines for both the Delta and the Omicron virus, and in terms of preventing emergency room and urgent care visits. And we can see that after the 3rd dose of the vaccine, that it's highly effective in preventing these urgent care visits and emergent visits in comparison to only those patients who only receive 2 doses, particularly with the Omicron variant. So more data to impress upon our patients of how they should go ahead and get complete the series of vaccines that are available out there. Also, this slide shows vaccine effectiveness, comparing 2 versus 3 doses of the mRNA vaccines for both the Delta and the Omicron variants. Again, with the 3rd dose, significant increase after the 3rd dose of protecting against further hospitalization in these patients who get this in comparison to only those who receive the 2nd dose. And I wanted to include the vaccine schedule for who are immunocompetent and over the age of 12 years old. We have 4 vaccines that are available, 3 vaccines that are recommended, and Novavax has been the 4th vaccine to be approved. We have the 2 mRNA vaccines, Moderna and Pfizer. And for these patients who are not immunosuppressed, they have 2 vaccines in their primary series, and then they should wait 2 months and receive the bivalent mRNA booster. And the same for the Novavax vaccine. The Novavax vaccine has in comparison to the mechanism of action, it uses traditional virus blocking techniques that our other vaccines use, similar to the influenza and other vaccines that are on the market, which is different from the mRNA vaccine. You should know that Novavax is highly effective, as effective as the mRNA vaccines, but it is only covers the alpha strand of COVID-19 virus. It primarily can be used in those patients who are allergic to the mRNA vaccines. And all 3 of these vaccines, Moderna, Novavax, and Pfizer, can be used in pregnancy. For those patients who receive the Janssen vaccine as their primary dose, which is only 1 vaccine, they need to wait at least 2 months before they can receive the bivalent mRNA booster. The Janssen vaccine is no longer being recommended anymore. And that was due to, in certain populations, the association with the vaccine of having low platelets and blood clotting disorders. So it's, as I said, it's not being recommended for use anymore. So this is the vaccine schedule for people who are moderately or severely impressed. I take care of a lot of HIV positive patients, and they are included in this vaccination schedule. Their primary series consists of 3 vaccines. And then after the last primary vaccine, the dose, they have to wait 2 months before they can get the bivalent mRNA vaccine with Moderna or Pfizer. And then if they get the Novavax, their primary series has 2 vaccines, and they have to wait again at least 2 months before they can receive the bivalent mRNA booster. For those patients who receive the Janssen vaccine as their primary, and then probably receive an additional mRNA dose, they can have to wait 2 months after that last mRNA dose, at least, before they can get the bivalent mRNA booster. So this slide is really for those patients who are not that sick, they're not hospitalized, they have mild to moderate COVID-19 infection, and they do not require supplemental oxygen. This is the NIH panel recommendation that all patients should be offered symptom management, and it recommends against giving steroids in the outpatient setting. But for those patients who are at high risk for progressing to severe COVID infection, and that includes the elderly and those immunosuppressed patients, they recommend, in order of preference, Paxlovid, which is a ritonavir boosted viral vaccine. It's given in twice a day, 3 pills twice a day for 5 days. And it is not recommended for patients with liver failure and not recommended in patients who have impaired renal function. The major concern with this drug for those who are able to take it is the drug-drug interactions. So you need to be aware of these drug-drug interactions that I'll discuss briefly a little later on. And then remdesivir is available in intravenous form. A lot of us who work on an inpatient basis use remdesivir early on in the pandemic, and now it has been authorized to use as an intravenous infusion once a day for 3 days in the outpatient setting. Now, both of these therapies, the Paxlovid and the remdesivir, are highly effective in preventing further progression to severe COVID. They're about over 90 to 95% effective in reducing death and hospitalization. In terms of remdesivir, it should not be used in patients who have renal impairment, less than 30, their GFR should not be less than 30 milliliters per minute. And for those patients who are being infused in the outpatient setting, they should be monitored at least 1 hour after the infusion. Now, an alternative therapy that is available on the market, but it is not preferred, and because of the lower effectiveness of this drug, is molnupiravir, and it's only 30% effective in preventing further progression of disease to severe COVID. And it should not be used in pregnancy. And I'll discuss the side effects. The side effects for molnupiravir mainly are diarrhea and nausea. This drug is also a 5-day course. It's 4 pills twice a day for 5 days. I just wanted to go on and show again, in terms of Paxlovid, this is a busy slide, but just to point out again, not recommended in those patients who have a GFR less than 30, and not recommended in severe hepatic impairment. The major side effects from this is diarrhea, and then the drug-drug interactions needs to be followed with these patients. And then again with remdesivir, in addition to not using it in people who have a GFR less than 30, they should have their transaminases monitored, and again, be observed for at least or greater than or equal to 1 hour after the infusion. And then in molnupiravir, again, this should not be used in pregnancy. The major side effects is nausea and vomiting, and it's really, like I said, an alternative regimen for the treatment of outpatient COVID-19 infection. I include these slides because I know a video of this recording will be available. This is a chart of these drugs. If your patients are on these drugs, they should not be given Paxlovid due to the potential adverse effects of the drug-drug interaction. So do not give these medications if you're considering Paxlovid. Again, this is for Paxlovid. Patients who are on these medications should have them temporarily withheld while they are receiving Paxlovid. For example, recently I had a patient who was on rosuvastatin, and while they were receiving the medication, I had to stop the rosuvastatin and not continue with it just while they were, for the 5 days they were on it. So what's in our future? I think, as we've seen with COVID, that social determinants will define health outcomes, particularly what we had seen in the racial and ethnic minorities here in the United States. So it's important to have safe and affordable housing for our patients, get rid of the food insecurity, and take care of transportation problems when it comes to dealing with a pandemic like we dealt with COVID, and hopefully we won't have to go through this. But if we do, we need to focus on these determinants that play a huge part in health outcomes. What else is in our future? I think that COVID-19 will become seasonal. I think we will be having to become immunized against COVID on an annual basis, similar to flu. And I have heard from some experts that the third quarter of 2023, we should expect a combined vaccine with influenza and COVID to protect against these infections. And that is all from my presentation.
Dr. Kendrick, thank you so much for your wonderful, definitely for sure, updated presentation on COVID-19. We're going to save until the end of our session for question and answers. While I have it in my mind, you were talking about the new variant XBB, and I'm seeing a lot of patients now, but I am a little bit concerned about those few patients, and I haven't seen any data on it yet, breakthroughs, having gotten the bivalent vaccine, and I haven't seen any data yet whether or not it's as a result of the XBB, but we can talk about that at the end. They're not severe, nobody's coming in the hospital, but I'm certainly seeing amongst colleagues, friends and acquaintances and patients, some breakthrough with the bivalent vaccine, which underscores the continued need for masking and social distancing and all the things that we did previously to mitigate. So, but again, thank you very much, and we'll talk more after the next presentation.
Okay, thank you.
Our next presentation will be talking about vaccine hesitancy among vulnerable populations. And our speaker for that presentation today is Dr. Jacqueline Wiltshire. She's a visiting professor, social professor in the Department of Health Policy and Management, the Fairbanks School of Public Health. She holds a PhD in Health Services Administration and an MPH in Epidemiology, both from the University of Alabama at Birmingham. She also completed postdoctoral training in women's health and aging at the University of Wisconsin-Madison. Previously, she was an assistant professor of healthcare policy and management at the University of South Florida College of Public Health. Her research focuses on disparities in access to healthcare, including healthcare affordability and the patient-provider relationship. More specifically, her research aims to elucidate the social ecological factors that underlie racial, ethnic disparities in healthcare access, especially among older adults. She is an associate editor of the Journal of Healthcare for Poor and Underserved, a member of the National Association of Health Services Executives Research Committee, and serves as chair for the Cultural Perspectives and Inclusiveness Forum at the Association of University Programs in Health Administration. Dr. Wiltshire, welcome.
Thank you. Can you hear me?
Yes.
I don't see my video is on. Hold on. My camera is on, but I don't see. Can you see me?
Not yet.
Oh my goodness. Okay, hold on. Sorry. Okay. Can you now?
I can't, no.
What is going on with this?
Is your little door open at the top for the camera?
Yes,
Okay.
it is. Select the camera.
And do you have a little stop video icon at the bottom?
Okay, hold on. I try to avoid this, but here it is. It happened. My apologies, my apologies. I feel
It's
like an
okay.
idiot. And
More
I,
importantly, we can hear you.
and I don't have my students here to fix this for me. They'd be like, Dr. Wiltshire, let me fix this. So, oh, wow.
We're a little ahead of schedule, so sure.
Oh my
We're actually a
goodness.
lot ahead of schedule.
Okay. All right, so I am trying to get this video on. I'm not sure. Maybe I should log out and log back in, and that will fix the problem. Is that okay?
Sure.
Thank you.
Well, you know, in the interest of time, Dr. Kendrick, would you mind answering a couple questions while we're waiting?
Yes,
You're muted.
I was
Oh,
looking
hi.
in the chat to see if
Yeah.
there were some questions there.
Yeah, that would be great. How about the one, Dr. Kendrick, when should a Novavax booster occur? Your slide only speaks to messenger RNA vaccines with regard to boosters.
Okay, there was one slide and maybe something was covering it, but the Novavax vaccine in immunocompetent patients has 2 series of shots in it. And after the second vaccine, 2 months after that, then the patient should get the bivalent booster.
Okay, great. Would patient getting IV remdesivir, I'm just reading this, would patient getting IV remdesivir for 3 days need to be hospitalized for 3 days or return to the clinic times 3 days? How effective in underrepresented populations?
Yes, they do not need to be hospitalized. Usually this is done in an infusion center, at least in my clinic. So because we don't have, it's supposed to be done in an infusion center, but because we don't have an infusion center that is due to staffing issues, we cannot give this. But for those patients where you have the staffing, it can be done in an outpatient setting.
Excellent. I think we have Dr. Wiltshire back. Welcome. Yay. Now you're muted.
All right.
There you are. Welcome.
Okay. Thank you so very much. You ready for me to share my slides?
Yes.
Yes.
Excellent. All right. So before I begin, are you seeing my full slides? Just double checking.
Yes.
Okay. All right. Thank you for inviting me to talk about vaccine hesitancy among vulnerable population. The information in this presentation is from the literature, the academic literature, the CDC, and research conducted by the World Health Organization, the African American Research Collaborative, the Commonwealth Fund, and the Kaiser Family Foundation. So this is basically the outline for my presentation, like what is vaccine hesitancy, what are the determinants or influence or the factors influencing vaccine hesitancy, what are the current trends in vaccine hesitancy, and how can we address vaccine hesitancy. So I'm an academic, so we always have to have learning objectives. Hopefully after this presentation, participants will be able to define vaccine hesitancy because we seem to be using it a lot. And there's a lot of contradictions about what this really means. Describe factors that influence vaccine hesitancy by race, ethnicity, and discuss trends in vaccine hesitancy and strategies to address or overcome vaccine hesitancy. So I will first start with, what is vaccine hesitancy? Sorry, let me get rid of this. What is vaccine hesitancy? Okay, so vaccine hesitancy, there are many inconsistencies in the literature on the meaning, definition, and measurement. Some authors argue that it is something new, distinct from old-fashioned anti-vaccination, while others say that it's as old as vaccination itself. Some view it as an intermediate position in the middle of the continuum between pro-vaccination and anti-vaccination position. Others just view it as it's an ambiguous concept, and it's sort of like a catch-all than a real concept with any theoretical foundation. But if we have to define vaccine hesitancy, we will say that first, it said it's a set of beliefs, attitudes, or behaviors, or some combination of them shared by a large and heterogeneous population, portion of the population, and including people who exhibit reluctant conformism. They might either decline a vaccine, delay it, accept it despite their doubts, and vaccine specific behaviors. That's one definition. This definition really stems from the definition from the SAGE working group. The SAGE working group SAGE stands for Strategic Advisory Group of Experts on Immunization, and they're the principal advisory group to the World Health Organization for vaccine and immunization. So they define vaccine hesitancy. They say it refers to a delay in acceptance or refusal of vaccination despite availability of vaccination services. Vaccine hesitancy is complex and content specific, varying across time, place, and vaccines, and it is influenced by factors such as complacency, convenience, and confidence. They also give us a model to sort of, or framework to understand or define it. And it includes 3 categories of factors, like say complacency, confidence, and convenience. And complacency, people say, I just haven't gotten around to it. I've been careful. Confident, it was approved too fast. It's too new. It won't really protect me. And convenience, I can't get off work. What if side effects keep me from working? And within these buckets or groups of factors, you can fit a whole host of factors into these, and they call it categories, you could call it groups, you could call it domains, but pretty much everything you can think of can fit into these 3 categories. So what are the determinants or the influencing factors of vaccine hesitancy? A systematic literature review by Truong et al. They found like 7 major factors with vaccine hesitancy or acceptance, and they list demographics as one, not one, but an area. So demographic influences hesitancy or is associated with hesitancy, access and cost, personal responsibility and risk perceptions, measures taken based on decisions to vaccinate, trust in healthcare authorities and vaccine safety and efficacy of a new vaccine, and lack of information or vaccine misinformation. So they came, based on the literature, they came up with these 7 major factors, they call it. But this is a busy slide. This is provided by SAGE, which is the working group for the WHO on vaccines, the advisory body. And they basically have come up with a whole host of factors that influences vaccine hesitancy. So they've categorized it as contextual influences. And so I want you to focus on on the left side of the slides. So they have contextual influences arising due to historic, sociocultural, environmental, health system, economic or political factors. Then there is the individual and group influences. And there's the vaccine-specific issues. Now, I have, if you really think of this and then you look to from A to H, there's a number of things influencing vaccine hesitancy. So depending on the population you are working with, then any of these things will matter. As we can see, based on the US, we've seen politics be a determining factor. We can see we've had geographic barriers. So this is just a whole host of influencing factors or determinants that we should be aware of. So since I was thinking about, since we were looking at demographics, and if we really think about demographics is really, it's a proxy for a whole list of characteristics and other factors. So what we are really concerned about here today is looking at vaccine or hesitancy by race ethnicity. Now, this is research conducted by the American Research Collaborative, where they surveyed like 12,000 people. It's nationally representative sample. And then this is segmented by people who are like I said, by race ethnicity. So we are looking and seeing among the people who are among different groups of Americans, what percentage are both unvaccinated, who are both unvaccinated and are hesitant to get vaccinated. So as you can see, Latinos, Blacks, which is how they categorize it, Native Americans have the highest rate of vaccine hesitancy. Asian American Pacific Islanders, they're lowest in terms of hesitancy. They're more likely to want to get vaccinated. And as you can see, whites. So based on this, you could tell that racial and ethnic minorities are more likely to be hesitant, which is not a surprise. Now, one of the things they were concerned about too is if you are looking at whether they're hesitant, what are the factors that makes them hesitant? And we can find that factors differ by race, ethnicity. So based on the questions, you can see this is between Black and white Americans. African Americans, let me take that out. Black Americans, because that includes all Black people. They are more likely to talk about distrust and medical professionals discriminate. Whereas if you look at whites, they are more concerned about their personal right to opt out. And as you can see, they're concerned that, the blood clots, which is common in the whole population. But what I do want you to pay attention to is African Americans are more likely to talk about distrust and discrimination by the medical profession. So if we go and we look at Blacks and Hispanics tend to look more like whites. They have this, they value, one of their concern is personal right to opt out or autonomy. But African Americans, distrust and, like I said, discrimination is really what pops out in this data. So what we think, sometimes when we deal with racial ethnic groups, and we see this a lot, people think they are monolith. And what you find, it applies to all Black people. So for interest of time, I decided to present the concerns about unvaccinated Black by gender among Black men and Black women. So as you can see, Black men will talk about the medical profession discriminate and distrust, but what's different, distinct for women is they do remember the anti-Black in medical history of anti-Black in the medical profession, the history of discrimination in the medical profession, and they do remember Tuskegee. So if we want to like peel the onions or disaggregate the data, we will really find a lot of differences in how people respond to the concerns they have about vaccines. So good news, while we are saying, you know, minorities or racial ethnic minorities, there's vaccine hesitancy, there are effective messages for targeting people who are by serving the 12,000 people nationally represented. The most effective message is protecting the lives of my family, friends, and those I love. So if you were trying to reach, I guess, anybody in the population who was unvaccinated, this should be the first, this would be not the first, but one of the most important angles to take when trying to convince them to get vaccinated. On here, and if you look and see what percentage, so Asian American Pacific Islanders, they are the highest rate in saying this was the most effective, followed by Latinos and Black, whites, and the lowest percentage was for Native American, but still, even if 29% of Native Americans said that that was the most effective message, it was still the highest in that group. So if this is the most effective message, who is the most effective messenger to encourage unvaccinated Americans to get to be vaccinated? So the most effective messenger for all Americans was my personal doctor or primary care physician. And when you break that down by race ethnicity, 60% of Latinos, that was the most effective messenger or the most trusted messenger. Asian American Pacific Islanders, they were also up there, and followed by Blacks, whites, and Native Americans. So I decided to, since we know that there's a lot of vaccine hesitancy among Black individuals, I decided to look at who are the most effective messengers. So in addition to the primary care physicians and the personal doctor, these are the top 5 in terms of who they say are the most effective. Overall, they do trust doctors and nurses. But what was interesting to me is they still thought the State Health Department was convincing and the CDC. And if you look overall, this doesn't hold for the population. If you look at this deaggregate as a whole, CDC does not show up as being a trusted or effective messenger. If you look at this by Hispanic or Latino, they do say that the personal doctor or primary care is the number 1, but the number 2 is friends and family. They say who have taken the vaccine, doctors and nurses, local hospitals and state health departments. CDC never showed up. As you can see, if we go back to this, the previous slide. If you look at Native Americans who have the, maybe I would say the highest, who also have a very high rate of vaccine hesitancy, the trusted messengers are still the doctor. They do trust doctors and nurses. Then the second one was personal and primary care physician. But interestingly, if you go, the trusted messengers in the top 5 were tribal leaders and the tribal governments. So if you're trying to target them and you're focusing on just using the health department or the CDC, that might not be an effective, this might not be effective managers to reach Native Americans. So now I'm going to switch over a little and talk and see, well, what are the current trends in vaccine hesitancy? So people tend to use, when I stated earlier, people tend to use vaccine hesitancy to be catch-all for everything. So they will talk about vaccine acceptance rate. They will talk about who's unvaccinated, but basically this slide shows us acceptance rate of the US, and as you can see, the states in gray, we have no information, and this is from the literature. Somebody might have something more current than this. The people in the green appears to have the highest, the states in green appears to have the highest acceptance rates. And Florida, states like Florida, North Carolina, and New York seem to be between like 50% and 75%. But what we should really be concerned about is there's no really, when we talk about in the literature, if we are looking for acceptance rates for vaccination, it's dismal. We don't know much about it, and more needs to be done in terms of transparency and putting out this data in terms of vaccine acceptance rate. I thought that when we talk about trends, this study came out of JAMA, and they were saying that what they found is that the vaccine hesitancy among Black and white individuals is changing, although we are concerned about it, but it is changing. They surveyed like 12,000 US individual as a national representative sample, and found that COVID vaccine hesitancy decreased more rapidly among Black individuals than among white individuals. And a key factor appears to be that Black individuals more rapidly came to believe that the vaccine was necessary to protect themselves and their community. Remember when earlier I mentioned about who are the most effective messengers and what's the most effective message? What they based on the research, they were saying that African Americans were more likely to embrace that protecting their loved ones. So this is the reason that we are seeing this decline. With regards to this came out, I put this up, this came out from research conducted at UCLA. And they were saying, looking at African Americans and why there is hesitancy among Black individuals. And the research is showing that this hesitancy stems more from today's inequities than from historical ones. So the UCLA study, Martin and her colleagues, they did a convenience sample first of 300 people, then they did a national representative sample of Black and white individuals. in 2021, and consistently, Black Americans are more likely to report poor interactions with their physicians. And they're consistently saying it's the negative experiences they have now that's causing them to be distrustful of vaccines and the willingness to be vaccinated. This research in JAMA is consistent with what we've seen by the COVID-19 vaccine poll, which is conducted by, like I mentioned earlier, that I mentioned earlier. If you look at whites, and they're asking like negative experience or poor treatment by medical profession, whites are less likely to say they're poorly treated. So you look like Blacks, they are 40%, Latinos, 42%, AAPI, Asian American, Pacific Islanders, 45%, and Native Americans are at 44%. So basically, if you take this data and you think about why there's vaccine hesitancy, poor treatment is probably the #1 reason driving hesitancy among racial and ethnic minorities, in addition to the other factors. Now, I will switch over and go into, when we talk about vulnerable population, I thought I should say a little bit about parents and children, because I think we are so focused on COVID-19 and vaccine hesitancy that this is a problem this is bigger than just COVID vaccination. They in July of 2021, you had 3 in 10 parents saying that they definitely will not vaccinate their children, but a year later, it's like 4 in 10 parents are saying that they have issues. They want to definitely or can reconsider vaccinating children. Why am I talking about this slide? Because this has moved over into, let me go back. This trend has moved over into childhood vaccinations. So they're finding that in 2019, 23% of the parents were opposing vaccination for their children for measles, mumps, and rubella. In 2022, it's 35% of parents. So this is just not about COVID-19 vaccine. This is extended to other forms of vaccination. And this is not just in children, this is in the elderly losing confidence in other types of vaccines. So when we, based on what the slide we have seen before about concerns, like why should they not, why they're hesitant to be vaccinated. Parents are saying that they are concerned because of the long-term and serious side effects of COVID-19 vaccine in children. I'm speculating, but I'm also saying that the parents who are also thinking that about normal childhood vaccinations, like for mumps, rubella, and measles, they are probably having the same thought about how safe is these vaccines for their children. Piggybacking on the parents who are saying that they're concerned, they have this slide has all the concerns about why, and overall, like it's, parents are concerned about the long-term effects. But here I've highlighted that African Black parents and Hispanic parents seem to be more concerned, have a higher percentage concern about access related barriers. So perhaps when we're thinking about reducing vaccine hesitancy, that is an area we should really be targeting for Black parents and Hispanic parents. So how can we address vaccine hesitancy? Based on the literature, a systematic review of the literature, Singh and colleagues found that to increase vaccination, they found that community-based interventions, monetary incentives, technology-based health literacy strategies significantly improve vaccination uptake. Media-based interventions did not reduce vaccine hesitancy. So their suggestion is that the strategy should be based on the targeted population's need and reasons for vaccine hesitancy. And we need a multi-dimensional approach involving community members, families, and individuals to address vaccine hesitancy. So I like diagrams, and if you look and you have this strategy, and if it's parents, they're saying if it's parents in low income, maybe because they have issues with access related barriers, then we should be thinking of incentive-based approaches. If it has to do with knowledge and distrust, we need to be focusing on education and awareness. And if it has to do with like reminders, or technology, we need to be involved, calling them and sending them text messages to overcome vaccine hesitancy. But what you can see from this is you have to use multiple strategies to address vaccine hesitancy, and one size doesn't fit all. I got this straight out of CDC because we know that one of the things we talk about, African Americans distrust, and people have the system. The first thing that CDC has is about building trust. So we want to share clear, complete, and accurate messages about COVID-19 vaccine. And I will say that it's not even about just COVID-19 vaccines, it's about all vaccines. And their ways of their action steps, if you provided, if you want to sort of build trust among your population. Then the next idea, the next strategy they talk is about promoting confidence about healthcare professionals. And here are the action steps. So they're stating that we should engage National Professional Association, health system, healthcare, everybody. It's almost like you have to take a systems view in engaging in reducing vaccine hesitancy. Then the third step was engage communities in a sustainable and equitable and inclusive way. So I like to, I have this here, but sometimes you have to repeat what you already said. We talk about empowering healthcare professionals, engaging communities and individuals, and building trust, which really can apply to any population you addressing, even whites in rural communities, Native Americans, African Americans, all populations that applies to. But when I was thinking about all this research that's there about vaccine hesitancy, CDC also put out a list of strategies to help increase vaccine. They call it now confidence. As you can see, remember earlier on, I was like, what is vaccine hesitancy? People will call it vaccine confidence and uptake. They'll call it vaccine hesitancy. It's all sort of, it's all means pretty much the same thing, or it's like this catch-all phrase for everything. But on this slide, I crossed out COVID-19 vaccine, COVID-19, because I think at this stage, this sort of applies to everything we have to do from now on with vaccine hesitancy. This is not just about COVID. This is translating now into childhood vaccinations. This is also will be a concern about the elderly and getting them vaccinated with the influenza shot. So this is really important, but basically CDC was saying, like, you know, they have listed like 12 strategies that, you know, try a combination to help increase confidence and uptake. And it's pretty much self-explanatory. So they talk about having ambassadors to do this, having medical providers standardize, they all on the same page with what the information you provide patients. And they talk about having reminders and, you know, recall, motivational interviewing, financial incentive, thinking about vaccination programs in schools. So this is a whole host of strategies that have been recommended for people to try. But I also think that we should focus, you know, number 11, it's like, you know, effective message delivered by trusted messengers, which I mentioned earlier. This is really important in terms of when you're dealing with racial and ethnic minorities. You know, it's not just important to just have a vaccine ambassador. You should also be making sure that the vaccine ambassador is a trusted messenger. So when we're thinking about racial and ethnic minorities, in addition to all the strategies I've mentioned, I have found that if you want to really address vaccine hesitancy in racial and ethnic minority population, you really have to understand the demographic profile of the patients you are serving. So sometimes people say Black Americans, but Black Americans, sometimes Haitians fall under that umbrella. Africans fall under that umbrella, African Americans. So you have to understand the demographic profile of these population. Also, if you looking at, people say Hispanics or Latinos, there are several different, you have Hispanics from Cuba, you have Mexico, you have Santo Domingo. You have to think about all these different population if you want to address vaccine hesitancy. It has to be targeted. You have to identify the concerns. You know, people have issues, and if you first identify what the issues are, so for Haitians, it will not be like Tuskegee or the history of discrimination in the healthcare system. They might not be able to relate to that, but they'll have different concerns in terms of maybe like immigration issues or language issues. Then they talk about like engaging grassroots leaders. That's very important, but you also have to remember that grassroots leaders might not be able to speak or for the population you're trying to target. So I found that sometimes people will reach out to a pastor And that's all they want to do. They never want to go into the community and do the legwork of connecting with the people in the community, talking to parents and guardians, and trying to deal with that population. Grassroots leader is one person that's great. You know, the church people, the barber, people who own the barber shop, but you have to go in the community and connect with the people in the community in addition. Then we think about improving convenience and access. When we talk about convenience and access, I was really thinking about information access and language and cultural barriers. Mentioned earlier, if you're looking at Black individuals, there's so many different groups within these, within the percentages or within that population we call Black Americans, that you really have to, if we really seriously want to address some of vaccine hesitancy, we have to think about the language and cultural barriers. African Americans, like I keep telling some of my colleagues, they're not a monolith. Hispanics are not a monolith. We have to now, we have to address anti-vaccination perspective. That's very important. Not like to tell people, you know, what, you know, you should be vaccinated, but just address it and just be very cognizant. People want to be heard. Even if you don't agree, you have to sort of address that perspective. The biggest thing, I guess, we all should be focused on is valuing all individuals and populations equally. There is, this goes back to the whole idea about people feel they're getting poor treatment in the healthcare system, but if we value individuals and population equally, especially racial and ethnic minorities, then that would be one way of addressing. Another thing which might be intuitive is we have to collaborate. Sometimes people, you know, you have to collaborate with academics, you have to collaborate with people in the community, community partners, the health department, the CDC. You have to sort of take a systems view to vaccine, to reducing vaccine hesitancy. And I even will argue that we even need to get policy makers on board with reducing vaccine hesitancy. So in summary, it's a busy slide. If we want to address vaccine hesitancy, we have to understand what it is. We have to understand the factors that influence vaccine hesitancy. We have also, you know, the research shows that it's more driven by inequities, today's inequities, like poor treatment by the medical profession. However, the nugget in there is that healthcare providers are still the most trusted people in the campaign to encourage vaccination. So because they're the most trusted, it's our job or their job to sort of like build trust. You know, the strategy would be to build trust, empower healthcare professionals, and engage communities and individuals to overcome vaccine hesitancy. This is sort of like what CDC provided in the 3 yellow slides I have, but there is so much in that last bullet. But what I want people to take from that is they're trusted messengers, and there are messages that are effective that we can use to increase vaccine hesitancy in vulnerable population. Thank you for listening, and I will end my presentation here.
Thank you, Dr. Wiltshire, very much. A lot to say. I have lots of questions and comments, and so
I know.
No, it's a great topic. You know, the first thing when you were talking about children and vaccine hesitancy, I'm sure many of you have read that we have a cluster of children in Columbus, in the central Ohio Columbus area, who are unvaccinated, and we're having a major measles outbreak here. So it speaks to your issue about children not wanting to vaccinate their children. We can talk about that later because we have a lot of time. I think, Solomon, let's do the questions post our post-test questions now. And I'm going to ask Dr. Wiltshire and Dr. Kendrick to come back on, and each one of you take your questions that you submitted. So we have question number 1. Vaccine hesitancy is defined as an intermediate position in the middle of the continuum between the pro-vaccination and anti-vaccination positions. And the answer is? Whose question is that?
It's mine.
Oh, okay. You want to give us your answer?
It's false.
Okay.
Because I remember that I said that it's one of these nebulous concepts. And if you go back to the slide or where it could be viewed as a set of attitudes, behaviors about vaccination, but it refers to the if you go back to the first slide, not the first slide, sorry, it refers to the SAGE definition that it's not on a continuum. It refers to a set of behaviors, attitudes towards vaccinations. So if you said that, then you'd be positioning yourself that it's somewhere in the middle, and it's not.
Okay, thank you.
Thanks. Can we please have the attendee answer the questions, and then I can post the result?
Oh, so I'm sorry, what did you say, Solon?
Can we have the attendees answer the post?
Oh, she said false.
No,
Is that-
answer, for them to answer the post, the questions, for the attendees to answer the questions.
That's what I thought it was.
I'm sorry, I don't understand.
I mean,
so Dee, they have to answer the post before she can explain the answer, so we know whether they learned from the lecture or not.
Thank you, Dr. King.
So I guess I'm trying to figure out how is this manifested?
It's just nothing. It's just you're giving everybody 10 minutes.
Oh, okay,
to
gotcha,
answer
gotcha,
the
gotcha.
post-test.
Oh,
question.
okay, all right, gotcha.
Okay.
All right, question number 2 then. According to research conducted by the African American Research Collaborative and the Commonwealth Fund, which of the following messengers is the most trusted and effective in the campaign to encourage Americans to get vaccinated? I remember that slide. So we'll give a few minutes, Dr. Kane.
Yes, Then you can move on to the third question.
Okay. And then they'll come back and give their answer.
Everybody will answer and submit, and then we'll know how they responded.
Okay, so you want me to go on to question number 3 then?
Yes, please.
Okay. According to the World Health Organization, vaccine hesitancy is defined as a behavior influenced by several factors, including, and this is single choice. What is this? This is alliteration, right? Confidence, complacency, and convenience. A lot of alliteration going on here, I think. Confidence, complacency, and convenience. Confidence, culture, and convenience. Confidence, convenience, and community. Which of the following strategies has been recommended to address vaccine hesitancy? Build trust, empower healthcare professionals, and correct vaccine misperceptions. B, build trust, empower healthcare professionals, and engage communities and individuals. And C, empower healthcare professionals, correct vaccine misperceptions, and acknowledge vaccination safety worries.
That's a tough one.
Moving on to question 5. COVID-19 warning signs that should lead to seek emergency care immediately include all of the following except one of these: a persistent chest pain or pressure, new confusion, pulse oxygenation greater than or equal to 95%, inability to wake or stay awake. And the last question is true or false. The U.S. Black population has the lowest percentage through July 2022 of receiving at least one COVID-19 vaccine dose in comparison to other race ethnicities. True or false? Okay, Solomon and Dr. Kane, let's see, so we're going to go back to 1 and we'll see how the audience did.
Okay, now you can go through the questions.
Oh, okay, so question number 1, the correct answer is false with respect to vaccine hesitancy is defined as an intermediate position in the middle of the continuum between the pro-vaccination and the anti-vaccination positions, and Dr. Wiltshire explained that to us. According to research conducted by the African American Research Collaborative and the Commonwealth Fund, which of the following messengers is the most trusted and effective in the campaign to encourage Americans to get vaccinated? And the correct answer is personal doctor or primary care physician. I guess I must have missed this because I thought that first big slide on the left said doctors and nurses is number 1. I was wrong. Okay, personal doctor or primary care physician. And I do want to comment on that with an article that just recently came out.
Jacqueline may want to comment about that. I don't know, Jacqueline, did you want to say anything more about that?
Oh, so this was conducted, African Americans said, which answer? Hold on. One of the most trusted is, they said doctors. Overall, it's primary care physician and you call it primary care physician. But when you went to African American, when you did that by race ethnicity, they did say doctors or nurses. So a response to that may be because sometimes racial and ethnic minorities do not have personal physicians. They don't have a usual source of care. So they might in general say it's doctors and nurses.
Since we're on this question, so I won't forget, I want to comment on, there was an article that just came out and it's actually an article in press, but it's in the Journal of the National Medical Association, entitled Examining Black and Hispanic Physicians and Other Healthcare Providers' Attitudes Towards the COVID-19 Vaccine. And one of the authors on this article is our past president, Dr. Leon McDougall. And I'll let you all read the article, but in conclusion, this article states that this is likely the first cross-sectional study in the United States demonstrating the substantial vaccine confidence among Black and Hispanic healthcare providers who serve minoritized communities that have borne the greatest risk of adverse COVID-related outcomes. Support of recommending the vaccine is encouraging and suggests that Black and Hispanic healthcare providers may play a vital role in the acceptability and uptake of the COVID-19 vaccine in minoritized and historically marginalized communities, which of course dovetails with everything that you said, but this just came out just recently. Did you want to make another comment, Dr. Wiltshire?
I showed this slide. I wanted to say that, to tell that people still have confidence in doctors and nurses. The whole thing, but if people show up and they're treated poorly, then that does damage, that will reduce hesitancy. So since they still see doctors and nurses as trusted messengers, then it's our job, or it's their jobs, to at least give people a positive experience. So if they treat them with respect and they treat them like they value them, then they'll be more likely to get vaccinated. That's one of the reasons I thought that I should talk about the messengers, because the research is showing that providers are treating Black and brown people in a disrespectful way. And maybe it's not even the vaccine they might be opposed to, it just might be the provider, the messenger.
The messenger.
Yes.
Agreed. Question number 3, according to the World Health Organization, vaccine hesitancy is defined as a behavior influenced by several factors, including, the correct answer is confidence, complacency, and convenience.
Yes. Now, remember when I said vaccine hesitancy is such an ambiguous concept? It's a lot to take in, to go through the literature. So, but if you're a provider, to me, an easy way to remember that is complacency, confidence, and convenience. And it's an easy model, and you could pretty much fit everything under that model. So if you want to take anything away from what I've said, just remember the vaccine hesitancy conceptual framework.
Excellent. Question number 4. Which of the following strategies has been recommended to address vaccine hesitancy? This was a toughie. The answer was B, build trust, empower healthcare professionals, and engage communities and individuals.
So that was straight out of CDC. And if people didn't get that, then I tell my students that it was a reflection of me. I didn't do a good job. Yes. So there is so much you can do, but if there is 3 things, the 3 strategies to remember, it's this one. So if people didn't get that, is because I didn't do a good job, or I made it the response too convoluted.
No, I mean, it was a good question, and it was a little tough, but great. No, good. Thank you. Question number 5, COVID-19 warning signs that should lead to seek emergency immediately include all the following except. The answer is pulse oxygenation of greater than or equal to 95%. Dr. Kendrick, was that your question?
Yes, that was my question. And so if someone has a pulse ox of greater than 95%, they're doing well, and they do not have, one of the concerns with COVID is that you are concerned about them having pneumonia, a low oxygenation level, and those are the people who are more likely to end up in the intensive care unit and maybe even intubated. So if you have a good oxygenation level, then you probably have mild to mild COVID, and there's no need to send them to the emergency room. You can treat with them with some of the outpatient regimens that I mentioned in my presentation.
And this is something I think I'm blocking. See, can I close this a little bit? This is what I recommend to my patients to buy, to get. And myself, I must use it at least once a week because I'm always worried. But these pulse ox,
Right.
Apparatus that you can get in the drugstores, I think are very helpful for just the question that you talked about. I think I lost my last question, Solomon, because let me see, should I click on share screen? No, I lost the last question. I lost the last question, Solomon. Maybe can you all see it? Dr. Kendrick, I think that was your question. Could you
Yes,
read
I
that
can
and
read
read
it.
the correct answer? Thank you.
I can read it. It's the correct answer for the US Black population has the lowest percentage through July 2022 of receiving at least one COVID-19 vaccine dose in comparison to other race ethnicities. Is that true or false? And the correct answer is true. That was in one of my slides in terms of when you look at vaccination percentages of those who received at least one vaccine, 59% of Blacks in comparison to 64% of whites, 67% of Latinos, and like 87% of Asians. So Blacks fall at the bottom in terms of the lowest percent of receiving at least one vaccine.
Great, thank you. Dr. Kane, how are we doing on time?
Good. You need to direct to our questions and answers right quick.
Okay.
We're doing fine on time.
All right, great. So I'm going to go to the question and answer section. We answered some of them before Dr. Wiltshire's talk. Let's go back. So to be clear, Dr. Kendrick, a patient that is confirmed allergic to messenger RNA vaccine should receive the booster mRNA bivalent after being vaccinated with Novavax.
Yes, I'm sorry, I misunderstood that. So if they are allergic to the mRNA vaccine and they have the 2 series shots of the Novavax, then the alternative that they can get is the Johnson & Johnson or the Janssen vaccine.
Okay, great. Can anyone speak to the incidence of long haul COVID in the pediatric population? I hear about long haul COVID in adults, but I have not heard much about this occurring in the pediatric population.
And I do know about long haul COVID symptoms in adults, but unfortunately, I am not aware of it. I don't know if you, Dr. Banks or Dr. Kane, is aware of it in children.
So unfortunately, I'm not a pediatrician. I'm sure there are some cases of long COVID in pediatrics, but I have not reviewed the literature or the data related to children.
Yeah, nor can I speak to that as well. You know, I think yesterday's talk was, and I guess it depends on what you call long haul. There is a definition for it, but in the cardiology section, I don't know if myocarditis might come under that because I believe Dr. Allende and the other cardiologist that was on they were talking about a pediatric population with respect to heart disease. So, you know, I don't know whether that would be included or not, but again, we're not pediatric infectious disease specialists.
So they do say that I think somewhere about 4% of patients who have COVID as children, that they will have lingering symptoms, and those symptoms can last, I'm sorry, let me put my video on. Those symptoms can last anywhere from about 1 to 6 months. And so that they can occur. So these children can get, you know, like when they have the loss of taste and smell that can be persistent. And of course, we see the most likely thing, especially with adolescents who are in athletic ability or males who've had their second vaccine can have not only acute myocarditis, but they may develop a chronic myocarditis associated with the vaccine. So it's very uncommon and usually will last maybe somewhere between 4 to 6 months. That's probably as much as I can tell you. Children definitely recover much faster than adults for whatever reason.
Thank you, Dr. Kane. On question 2, there was a difference between the general population and African Americans. I think this question is confusing. Dr. Wiltshire, you want to comment on that? She said on question 2, there was a difference between the general population and African Americans.
Okay. So, in terms of, what was question 2? The trusted messengers? Sorry. Hold on. Let me go to this. Question number 2. Okay. So if question number 2, the most trusted and effective in the campaign to encourage Americans to get vaccinated. That was question number 2. And the most trusted was personal doctor or primary care physicians. But when you de-aggregated the data by race, ethnicity, African Americans said that doctors and nurses, they said they were the most trusted. They selected doctors and nurses overall. So if you look, if you think about the literature that says African Americans tend not, well, let me not categorize. They tend, African Americans, some African Americans tend not to have a usual source of care. So when you don't have a usual source or usual provider, but you have somewhere, then they can pretty much, they might select that, you know, doctors and nurses overall. But people who have a usual source of care with a usual provider, it makes sense that they would say their personal doctor or primary care physician. Does that make any sense? Because I could clarify it. So overall, aggregated, the most trusted and effective messenger to encourage all Americans to get vaccinated is the personal doctor or primary care physician. When you de-aggregate the data by race, ethnicity, African Americans had doctors and nurses as number 1. But if you look at that, didn't, you know, there's only maybe like 1 or 2% difference in their responses. Did I clarify that?
Yes, thank you. I hope so. And the author of that question, please feel free to put another question in or ask for further clarification. Dr. Kendrick, there's a question here that I want to pass to you. And there were a couple of articles out on this in recent times. The question is, or comment, important to note false oximetry readings on Browner patients.
Right, I did see that question, and I was not aware that that occurred in dark complexion patients. So I don't know if anyone else is aware of that. I didn't know that.
I don't know.
What was the question? I'm sorry.
About the false oximetry. There have been some articles. I don't know about false oximetry readings in Browner patients. It's just come out recently that I've read about. Dr. Kane, you want to comment on that?
Yes. So there is clear in recent studies to show that oximetry for people of color, especially the darker skinned individuals, that the readings are false, especially these pulsometry instruments that are used for Black and African Americans, which is very serious because it makes a difference whether someone may be eligible to be hospitalized for COVID based on what the oximetry results show. So that's a huge concern.
Thank you. And last question that we have here, and then I have a couple. The World Health Organization use of complacency may not consider determinants of health and culture. Dr. Wiltshire?
Actually, if we go back to the slide, they do give a list of factors, and it falls under contextual factors. And remember, I say, if you think about confidence, so confidence, hold on, I want to be accurate when I give you this response. When you look at confidence has under that category will have trust in there, and it has cultural factors under there. So I am sorry, but let me go back to the slide. If you go back to slide number, and I said it was a very busy slide, it has contextual influences arising due to historic, socio-cultural, environmental, health, system, institutional, economic, or political factors. They have from A to H, they have a whole host of factors. And under there, you can have, it has religion, culture, gender, socioeconomic factors. But if you take all of these determinants and you take the complacency, you take confidence, and you take convenience, you can fit all these variables under these three categories. So confidence, sorry, let me go back. So confidence, they define that as, confidence is defined as trust in the effectiveness and safety of the vaccine, the system that delivers them, including the reliability and competence of health services and health professionals, and motivation of policy makers who decide on the needed vaccine. So it does, and confidence, convenience has availability, affordability, willingness to pay, geographical accessibility, ability to understand, language and health literacy, and all these things. So you can sort of fit all these factors under these three buckets if you want it.
Okay, thank you. Dr. Kendrick, I have a couple questions that are not in the Q&A, but just this past couple of days, the Infectious Disease Society of America came out with a couple of questions and answers regarding Paxlovid treatment. And since you mentioned earlier about taking care of HIV patients, I have a couple. Can people with HIV develop drug resistance to protease inhibitors with Paxlovid?
Well, because I didn't see that article that came out, but I would think that there has not been any resistance that I know of. Now, patients to Paxlovid in this patient population, because the Norvir is actually boosting the other antiviral, and so it's not acting as an antiviral itself in the terms of treatment. So there has not been any resistance that I know to the main antiviral that's treating the COVID virus infection. So, and not any of the HIV positive patients has been exposed to that particular virus probably before, but ritonavir, they have been, but it's not a major player in the treatment of this. So I am not aware of any resistance to Paxlovid in HIV positive patients.
And it's given for a short period of time too. So, I mean, theoretically, but it's given for such a short period of time. So that hopefully it's not, I mean, there's not that much exposure.
Exactly.
I'm not sure whether this next question is broad. I don't necessarily, we don't need a broad answer, but did we touch on Paxlovid in hepatitis C patients?
I did not touch on that.
That was a question that has come up on occasion in patients that are on hepatitis C treatment. Are you seeing any patients with HIV and Hep C who have received Paxlovid? Or it may be a unicorn, but
Yeah, I don't know. I don't know if either Dr. Kane, I don't know if
Dr.
you.
Kane?
I think the problem is with Paxlovid, that if you have significant severe renal failure, or even if you have severe liver disease, you probably should not use Paxlovid in that regard. And based on the severity of, for example, the renal disease and what stage, you can almost half the dose for Paxlovid, but for severe hepatitis, you may not be able to use it and have to use alternative a regimen, say, as our IV remdesivir infusion for 3 days. I think Dr. Brown had asked a question to us as specialists. When you use the alternative treatment of remdesivir, which is a 3-day infusion process, do you hospitalize people for that, or do you have them come back each day for the 3 days of IV infusion? So the answer is you have them come back each day because it's very costly to hospitalize them for 3 days. But secondly, some places are not set up for have an infusion center in order to do that, especially if you're in a rural and small community. So that's
even in
the
our
problem.
community, we were not able to staff, even in a big Bon Secours Mercy Hospital where I am, we were not able to staff outpatient clinic like that. So that was kind of went by the wayside.
All right.
I don't have any other questions. I'm going to toss the baton to my friend and colleague, Dr. Virginia Kane. Again, thank you very much for having me, National Medical Association, to moderate. Thank you, Dr. Kendrick, my colleague, and my other colleague, Dr. Wilcher. Thank you very much for your wonderful presentations today. And I hope everybody learned something a lot. I've certainly learned a lot as well. So thank you very much. And Dr. Kane, I'm going to pass. Solomon, thank you also for your assistance and help with us today. Thank you,
yes, thank you so much. I want to just thank our moderator and our speakers so much for this infectious disease section. Before I close, though, I'd like to invite Dr. Nancy Joseph to provide some few remarks before I get to the closing, if you don't mind, Dr. Joseph.
Yes, hi. Thank you so much, Dr. Kane. I just wanted to, I entered it privately, but I figured it would be very helpful to at least give it some people some answers to, there's a couple of questions. Number one, there was a question about someone who is PEG allergic and or polysorbate allergic. And so if your patient is PEG allergic, that means, they can't get the mRNA vaccines, but as we know, there's other options, and more specifically an option. So Novavax is the option. Previously, before that, it was really only Johnson & Johnson. So we mentioned Johnson & Johnson, but I just wanted to clarify that because obviously, I think Dr. Kendrick had talked about, had mentioned all of the blood clots and all of the concerns with the Johnson & Johnson. So your choice would be the Novavax then, as the PEG allergic patient. Of course, if a patient is polysorbate allergic, then you would go to the mRNA vaccines. But I also think the person was concerned that their patient was both PEG and polysorbate allergic. And though that is rarely seen in that particular patient, it would be beneficial to send them to an allergy immunologist. And then we can take it from there, because where we go from there, the steps from there and all that stuff can be quite nuanced and patient specific. So that was what I wanted to say with that. And then there was a question about immunocompromised patients and whether or not to get the COVID-19 vaccine. And the answer to that is also nuanced, because there are special populations of immunodeficient patients, more specifically common variable immunodeficiency patients. And those patients, of course, can have deficiencies in different parts, or more than one part of their immune system. And so patients, again, special population patients would be a CVID patient. And for that, it'd be best to just go ahead and, they're probably seeing an immunologist already anyway, because they're on immunoglobulin infusion, things like that. So that answer, just go ahead and send it over to their immunologist to further kind of tease that out, answer that, and manage that particular portion of their concern. So that's what I wanted to make sure I clarify for everyone while the recording is still going on too.
Well,
thanks so much for that, Dr. Kane.
Thank you so much. I appreciate that. One last thing I didn't mention about that long haul too for pediatric COVID, their symptoms are similar to adults. So if you do have a child that's got looks like chronic fatigue, doesn't have the same energy, or used to play a lot of sports and they don't want to participate, or they can't walk like they used to, you have to be concerned. And then definitely these children can get brain fog. So they have that inability to do calculations. They can't seem to do their homework right, or having a lot of difficulties related to that. You may have had an asymptomatic infection with COVID with your children and not be aware of it. And of course, going along with that heart condition, like I told you, sometimes they can get racing heartbeats or palpitations. And so you really kind of have to really evaluate your children and kind of monitor and watch them to see if there's something different or new about them that you hadn't noticed before. In the last couple of years, you may have had long COVID, they may have experienced it, and you might not be aware of it. So, but you need to get someone who's got the expertise in it to do the really good evaluation related to that. So thank everyone.
Dr. Kane, I just want to, one quick thing, I just want to also shout out and thank Dr. Chanda Nicole Holsey, who has also been involved with this, but she wanted me to make sure that I told you all, and I think Dr. Kane, you might have said it too, but I want everyone to know that since this is not an ACCME accredited program, we still want everybody to fill out your evaluations. This is so important. They are going to be mailed to you to your email. It's so important in order to aid us in assessing program impact and participant satisfaction. So I just wanted to get that last thing in.
Thank you. So let me just say that on behalf of our NMA president, Garfield Clooney, and special thanks to our chair of internal medicine, Dr. Marie Borum, who, as most of you know, is the chief of gastroenterology at George Washington University, and all of our subspecialty chairs and the faculty that they've identified over these past 2 days have just been phenomenal. And I want to thank all of you attendees who've been able to come on board and to ask those critical questions and to learn some of the differences related to, you know, whites and blacks. Who would know that a pulsometry, if you were darker skin, you know, these sensors with this pulsometry, they can't penetrate the dark skin with their light sensors. And so it gives us a false higher rate of oxygenation by 5% or more. So I'm looking like I'm fine, when in reality I'm not. But it's these webinars that are able to define the differences related to patients of color that you may not always see in other webinars, emphasizes the importance of having these procedures. And of course, hey, we got to give our special thanks to our internal medicine administrator, Dr. Shanda Holsey, and her colleague, Solomon Doroje, you know, for the logistical things that they make to make this happen. A lot of work behind the scenes. And so, you know, we just always appreciate them. And then we want to thank you again for participating in this webinar. And like Dr. Banks says, we are asking you to participate in a short survey for an evaluation, because we want to know how we can, for future webinars, what you want to hear about, you know, what things will make our webinars better. And so that's so critical. And so soon as you leave this link, you will get that. Secondly, for those who want to see these presentations again, you will get another link that if you want to review any lectures that you might have heard or whatever, you will have the ability to hear our speakers with another link that we will send to all attendees. If someone wanted to get a copy of a PowerPoint presentation, that's a request that you would have to ask the individual speaker, but I'm sure those speakers would most likely accommodate you. I know that all my infectious disease speakers here on this section are willing to share their slides. So thank you again. We appreciate all the hard work that you do out in the community to do the type of education we have to have for our patients, the amount of advocacy we have to do in order to make sure that we've got resources and access for our patients. We have a lot of work ahead of us, but only with your help, your assistance, your advocacy, and your expertise will make a difference in the lives of all of our patients. So thank you again. I appreciate everything. And so Dr. Borum, I don't know if you wanted to say anything or not before I close.
Thank you, Dr. King.
Thank you, Dr. Treadwell.
That was excellent.
Treadwell.
Excellent.
Dr. Borum?
Yes, I am so appreciative of everybody who has participated. I am so thankful for our virtual audience. I'm thankful for everybody who's come this evening, this morning and evening. I learned so much. I'm sure the audience learned so much. The experts have offered some incredible information for us to allow us to continue to optimize the care of our patients in our communities. And I thank everybody who's come and participated. Thank you very much and have a great evening.
Okay. Thank you, everyone. See you. Be safe out there. And don't forget.
Thank you.
Thank you, Dr.
Treadwell,
Treadwell.
my home guy, fellow North Carolinian.
Keep those VA patients safe, Dr. Treadwell.
Okay.
But everybody, don't forget the importance of wearing the mask and that there's a lot of asymptomatic infection out there, especially as people travel in a large number of employees. And always, we need to protect not only ourselves, but our friends and our family and our colleagues. So be a great example. Thank you so much.
Thank you. Thank you, everybody. Thank you, everybody.
Bye-bye.
Bye.